بسم الله الرحمن الرحيم والصلاة والسلام على الرسول الأمين. Professor Anna Sureda, President of the EBMT, colleagues, respected attendees and members and guests, it's my honor to welcome you today to the 12th annual conference of the Saudi Society of Bone Marrow Transplantation and to the 10th annual conference of the Hematology Oncology Nursing meeting. Over the next 2 days, you would witness highlights from the EBMT meeting 2023 and should we turn this off? Sorry for the noise. So over the next 2 days, we'll see focus and highlight from the EBMT meeting that took place recently. And I would like to thank Professor Anna Sureda and Professor Muhammad Muhti for helping us putting this program, and all the speakers from the EBMT, whether attending this meeting or presenting virtually, for their participation. And I would like also to thank our speakers and moderators again for their participation in this meeting, and all the members who are attending this conference. As you are aware, the SS BMT focuses on educational activities that brings update to the region, and also in addition we focus on other domains like research, patient awareness, and also we recognize people that are contributing to the development and progress of hematology in the region. So having said this, we would also today recognize one of our colleagues who was granted the annual SS BMT Hematology Career Achievement Award, and so this recognition will take place very soon. Our members have reached 2,700 already in the SS BMT, and we're proud. And again, thank all members for their support and presence. And I would also like to thank our sponsors, especially our main sponsors, Sanofi, Astella, Gilead, for their generous support, and also our platinum sponsors, Menarini, again for their generous support, and all the supporting companies participating in this meeting. And I would also like to remind you of the upcoming 17th ICML highlight and hematopathology overview, which will take place on September 15 and 16 this year. So make sure you mark your calendar and be there. So without further ado, I would like to invite Prof. Anna Sureda, President of the ABMT, to give her remarks. Thank you.
Hello, good morning everybody. So my name is Anna Sureda. I am a clinical hematologist working for more than 30 years in Barcelona, Spain, and president of the EBMT. It's really an honor for me and for all the EBMT community to be able to participate in this meeting that has been organized for quite a few years right now. We had to do it virtual, or you had to do it virtual during the pandemic. But last year we were already here in Riyadh, and this is the second year that we are face-to-face here, also in Riyadh. I hope that some of you attended the EBMT meeting in Paris. It was really a very special meeting for the society, because after 3 years of having it virtual, we were able to meet everybody face to face. I think that everybody enjoyed it. We had a lot of participants, really very good signs, and last but not least, a lot of face-to-face interaction, which was something that we had been missing for many years. And I think that it's really an honor for us to be able to participate in these 2 days, as Professor Alaskar has already mentioned, with the highlights of EBMT. We have tried to put quite a comprehensive program, inviting key people in the different fields that we will be discussing. I really hope that you enjoy the day in the same way that EBMT speakers are going to enjoy it. Hopefully we will have a lot of fruitful discussions. And once again, really thank you SS BMT and Professor Alaskar for the invitation to EBMT to organize these joint sessions, which it's clearly in line with one of the objectives of EBMT, to try to be as global as possible and to cooperate as much as possible with sister transplant societies around the world. So enjoy these 3 days, taking into consideration the nurses one too at the end. Thank you very much.
Thank you, Hussein, please. So I'd like to invite Dr. Turki Husseidi, who is a board member of the SS BMT and who will present the Hematology Career Achievement Award.
We can for this. Can we have في موسيقى هذا? Can we stop it? Just Good morning, everyone. Our Hematology Career Achievement Award for this year, it's Dr. Zakaria Muhammad Al-Hawsawi, who was graduated with MBBS from King Faisal University at Dammam, Saudi Arabia. After that, with the collaboration of Ministry of Health and Riyadh, he obtained diploma in Children Health from Edinburgh University, United Kingdom. That followed by obtaining him Arab Board in Pediatric from King Khalid University Hospital, with further training courses in Pediatric and Hematology Oncology at King Faisal Specialist Hospital in Riyadh. He got a fellowship in Hematology Oncology of Pediatric specialty. Dr. Hawsawi, he was the founder of Hereditary Blood Disease and Thalassemia Center in Medina Maternity and Children Hospital, and also he was the founder and president of Hereditary Blood Disease Charity Society in Medina, and he was the president from 2010 till 2017. As well as he was the dean and the founder of College of Medicine at Al Rayyan Private College in Medina, and he was the dean from 2017 till 2020. Currently, he's a consultant pediatric hematology oncology at Medina Care Private Center and accreditation surveyor and Saudi Commission of Health Specialty, as well as a consultant of Health Power Company. Thank you, Dr. Zakaria, for all this achievement and the contribution for our society. And you can come to the board. Dr. Ahmed. الفيديو نقدر نشغله ولا نشغل الفيديو هون؟
Good enough.
Thank you very much.
Yes, only one. We just we're gonna call for the first session. The moderator, Dr. Ayel, and me, Dr. Ayel Yahya. We'll start with the first presentation and updates for multiple myeloma with Prof. Mohammed Moti. Prof. Mohammed Moti is a full professor of hematology, head hematology and cellular therapy department at Saint Antoine Hospital and Sorbonne University in Paris, France. He obtained his medical degree from University of Montpellier, France, and PhD of University of Marseille, France. He also head of translation research team and at Saint Antoine Research Center in Paris. Dr. Moti is the past president of EBMT and currently the chairman of Acute Leukemia Working Party in EBMT. He also founder and chairman of International Academy of Clinical Hematology, board member of EBMT Intergroup Francophone du myeloma. In addition, he was publishing more than 900 peer-reviewed articles in the field of stem cell transplant and leukemia and myeloma. Dr. Moti served as an editor-in-chief of journal Bone Marrow Transplantation and Clinical Hematology International. Also, he served as an editor and board member and reviewer across numerous other respectful journals. Dr. Moti, floor is yours.
Good morning, everybody. Assalamu alaikum. Thank you for the kind introduction and for the kind invitation. It is always a pleasure and an honor to be with you. And congratulations for this fantastic event. I remember a few years ago when we signed this memorandum of understanding with SS BMT, and it is now flourishing thanks to the efforts of all of you, and especially, of course, the leadership of Dr. Al-Askar. I do apologize I wasn't able to be with you today because of some local commitments related to my PhD students defending a thesis later today. So I hope we'll be soon together, and thank you all for your contributions to the EBMT annual meeting a few weeks ago in Paris, but also to all your contributions to EBMT and the hematology field. So for this morning, I was asked to provide an update about multiple myeloma. And I think you will hear during this event a lot about myeloma because it's a rapidly moving target. There are many advances. But I thought that for us as a transplant community and cellular therapy community, one important aspect that is hotly debated, and it was really key topic of the last EBMT annual meeting,
is the replacement or the contribution of cellular therapies, especially CAR T cells, to the field, especially in replacement to stem cell transplant, whether auto or allo. For instance, we know today very well, and this is highly reflected in the EBMT registry activity, that auto transplant for non-Hodgkin lymphoma is becoming less and less frequent, thanks to some major randomized phase 3 trials which could show the advantage of CAR T cells. And obviously, a key question for all of us today is whether CAR T cells will replace autologous stem cell transplant in multiple myeloma. We all know that autologous stem cell transplant for multiple myeloma is actually the most frequent, most popular, and the safest stem cell transplant approach. It is widely used across the globe, and obviously, if at some point one or we can demonstrate that CAR T cells are better or should replace, that will be a huge, I think, revolution in this field. Obviously, I don't think I have the right or wrong answer, but I will try to walk you through this problem and how can we tackle these issues. My disclosures, just for the sake of introduction, is to highlight, especially for the youngest colleagues and friends in the room, about the incredible advances we have witnessed in the field of multiple myeloma for the last 50 years or so. For 30 to 35 years, actually, we lived with the era of conventional chemotherapy. Then in the late 80s and actually early 90s, we had the development of high-dose melphalan and auto-transplant. And this has become quickly a standard of care, and I will go back to this. However, we should acknowledge that later in the early 2000s, we have seen the advent of new families of drugs, especially the IMiDs, with thalidomide, later lenalidomide, more recently pomalidomide. We had also the proteasome inhibitors, first in class bortezomib, then later ixazomib and carfilzomib. In the mid-2000s, 15, something around this, we had the first monoclonal antibody. And I think this was really turning point in the field of multiple myeloma. We had also some small molecules like panobinostat, selinexor. But in the last 3 to 4 years, we've seen a new wave, actually, of treatments, namely immune therapies. And this is about cellular therapies, but also T-cell engagers, bispecific antibodies, and to a lesser extent, the antibody-drug conjugates. And there are now approved products for each of these options. However, if you look before the immune therapy era, actually the advent of all the new drugs, including the monoclonal antibodies, wasn't opposed to transplant, at least from my perspective. And actually, I'll show you data, it allowed to synergize and to improve the results of transplant. But now, I think maybe we are switching where the cellular and immune therapies are going to be opposed to transplant, and we'll figure out how this will work. My personal feeling is that probably CAR T cells will replace autotransplant or will take a major place, but I don't know when, actually. It may take some time, and actually even if you have randomized trials, and they are ongoing, showing this, in many places across the globe, it may take a lot of time because of accessibility and affordability. First of all, just a quick reminder about the value of auto-transplant. We are in a transplant meeting, in a transplant environment. It's a post-EBMT event hosted by SS BMT. And I would like to remind all of us that auto-transplant is really well established since now the early 90s. First, thanks to the IFM trial, which could show the superiority over conventional chemotherapy. And this was later confirmed by other trials, including trials from the UK. There have been a lot of attempts to improve the conventional high-dose melphalan auto-transplant. And the transplant community worked a lot, including EBMT and cooperative group studies, on whether we can do better than melphalan 200. And TBI was tested, bortezomib was tested, busulfan plus melphalan was tested. But at the end of the day, it proved that in terms of the balance of efficacy and safety, melphalan 200 is a standard of care. The first lessons from these studies were that actually the value of high-dose melphalan is by deepening the response. And when you deepen the response, you can improve progression-free survival. And in some studies, there was even an improved overall survival. Of course, I will not go through the details of transplant eligibility criteria, but I think as transplanters, you're quite familiar, although we may debate a lot the threshold, the age, whether it's 60, 65, 70, 75. It depends, I think, on comorbidities and frailty parameters. But definitely deepening the response and later achieving MRD negativity maybe has been a major step. And this was a background to further improve the procedure. And actually, one way of improving the procedure was about actually improving the tumor debulking process. This is what we call induction before the high-dose chemotherapy. And I will not go through all the developments. We started with VAD, we went to VD, bortezomib dex, TD, thalidomide dex, Lendex, VTD, VCD, VRD, but actually KRD, but actually today, I think it is well established that quadruplet regimens are becoming the standard of care and are allowing to improve the results of auto-transplant. And for instance, this Griffin trial, similar to the IFM Cassiope trial, could show that Dara-VRD, daratumumab, bortezomib, lenalidomide, dexamethasone is superior to the standard of care RVD because of a higher response rate, and most importantly, at the last follow-up, the very high percentage of MRD negativity. At end of consolidation, 47% were MRD negative with their VRD at the level of 10^-5. And this has been also shown in a German multi-center randomized trial, actually using another anti-CD38 monoclonal antibody, namely isatuximab, and exactly showing this 50%. So clearly, we have moved radically 180 degrees from less than 5% CR to 50% MRD negativity. So you can appreciate that the auto-transplant field has really improved, and that is making the bar quite high for CAR T cells. Please bear with me. So now, if you look at the relatively long-term follow-up of the Griffin trial, actually we're talking about 87% PFS at 4 years. And this is going to be like 85% at 5 years and so on. So we're talking probably in the standard risk cytogenetic patient, because obviously myeloma is a very heterogeneous disease, but for the sake of time, I'll not go through all of these details. But definitely, we're talking about more than 10 years of median overall survival, which makes it difficult, actually, to prove things in the frontline setting. And actually, just to echo the story of the high-risk cytogenetics, probably there will remain a room, in my opinion, in the future for the chemotherapy, the high-dose melphalan, in those patients with high-risk cytogenetics or even high-risk genomics, because now probably we're going to move from the cytogenetics maybe to whole genome sequencing in multiple myeloma. And you can appreciate that the standard risk cytogenetic, this is likely where we will achieve long-term outcome and cure. And actually, just to highlight the importance of auto-transplant. So here I am advocating and pushing for auto-transplant, not to forget about it. In the high-risk cytogenetics, we probably even need a double auto-transplant. Of course, while the topic is about comparing auto to CAR, you may wish to ask me later about why not combining auto-transplant plus CAR T cells, because at the end of the day, maybe this would be a good option. Nevertheless, in the high-risk cytogenetics, double is still recommended. We have this latest IFM data showing the feasibility of double auto in this population, but also, and this is again another important finding, if you want to bring these high-risk patients closer to the standard risk, I'm not saying equivalent, closer to the standard risk, maybe that is the path forward, because you can achieve 60% MRD negativity in these patients. The follow-up is relatively short, but these curves are a good starting point in my opinion. So you can see the background. The auto data are quite solid, even double auto. The safety is very good. I didn't mention it, but the mortality is less than 1%, And in many centers, it's almost 0%. It has been a long time since we didn't see a transplant-related death with auto-transplant for myeloma. It's a different story in lymphoma. So it is important to see that we are the starting point. The bar is very high in terms of safety, but also in terms of efficacy. And you need to beat this with your CAR T cells. Of course, probably there are patients attending and listening to us. I'm not minimizing the side effects of auto-transplant in the short term, when it comes to mucositis, when it comes to diarrhea, when it comes to neutropenia, febrile neutropenia, the need of hospitalization in many places, the need to travel to a dedicated transplant center, etc. But at the end of the day, if you are able to go to a transplant center, then the safety and the efficacy is very high. Well, the transition is, we as transplanters are strong believers in the power of immune therapy. In auto transplant, we're more relying on the power of chemotherapy, which is still very, very helpful. I mean, you know all this. But in the allogenic stem cell transplant field, we know very well about the immune-mediated anti-tumor effect. And this is now fascinating with the tools we have, let's say, in the autologous setting, thanks to CAR T cells, where you can educate, you can engineer the patient's own T cells, transform them, and I'm sure this community is quite familiar with the CAR T cell process. And I would like to congratulate and praise the effort of SS BMT and Dr. Alaskar to bring actually CAR T cells, academic CAR T cells, into the region, because this is very important. But also immunotherapy, because it's not only about cellular therapy. I think we need to think broad now. It's not about transplant. It's not about CAR T cells or cellular therapy. It's about curing a given disease. And for this, you need to rely on all options. So we should not ignore also the bispecific antibodies, the T-cell engagers, which are relatively easy to use, accessible, and are providing a sort of an in vivo immune therapy. So for CAR T cells, and I think there will be a talk by Dr. Rodriguez Otero, who was featured at the Presidential Symposium during EBMT. But we know that we have, for instance, this ide-cel product, which was approved thanks to the KARMA trial. I have presented this several times. You know the data. In highly relapsed refractory patient, median prior lines of 6, you can achieve 9 months of PFS. You can view it as the glass is half full or half empty, but these are quite good results when it comes to patients who are supposed to be in palliative care. There is another product, another construct approved in multiple myeloma, CAR T cells, namely cilta-cel. And the results of cilta-cel are quite incredible, actually, because you have 98% of overall response rate. And if you look to the PFS and overall survival, especially in those patients who are able to achieve deep MRD negativity, the results are very impressive. And you may have seen yesterday, so we're Friday, yesterday, Thursday, that the company of cilta-cel has applied actually for approval in earlier lines of therapy, in earlier relapse, thanks to the results of the CARTITUDE-4 trial, which will be presented at EHA in the Presidential Symposium in 2 weeks. So, and this is in line with the fact that we have already data showing that we are able, and we do have the capacity and also some data that we can use CAR T cells early in the course of the disease. And actually your T cells are likely better. And you would imagine where I'm going there. I'm trying to push the CAR T cells from the end stage progressively into the first line, just showing you, walking you through how we can move forward. And actually, in the KarMMa-3 trial that will be presented by Dr. Rodriguez, actually, you can use them earlier, and they are better than standard of care. And you have also, in the KarMMa-1 pivotal trial, showing efficacy in early relapse after frontline therapy. It is also true in one of the cohorts, cohort B of CARTITUDE-2, showing actually that they can be used in early relapse, so early, less advanced disease. So if things are working end stage, intermediate, earlier, then why not pushing them into earlier relapse and later first line. And this is exactly, as I mentioned, what Dr. Rodriguez will present to you. And this is exactly what Dr. Ainsley will present in a couple of weeks at EHA when it comes to the CARTITUDE-4 trial. So CAR T cells, they are effective. I didn't mention the safety, but it is now well known when it comes to the key issues, CRS and neurotoxicity, the cytokine release syndrome and neurotoxicity. Interestingly, in multiple myeloma, the incidence and severity of these side effects is, in general, much lower than what you see in lymphoma and even in acute lymphoblastic leukemia. So it doesn't look like that in myeloma, at least with these CAR T cell constructs, which are targeting BCMA, but I'm sure you're aware of this because I didn't mention it, we don't have these safety issues, and they work well. So how to move it forward? Given the very high bar of efficacy I showed you, 90% PFS at 4 years now with a quadruple Dara VRD or isatuximab VRD, 50% MRD negativity, excellent safety, less than 1% mortality. So if you want to move it forward, you really need to have a very robust, well-designed, well-powered phase 3 randomized trial. And this is exactly the European Myeloma Network 28 CARTITUDE-6 randomized trial, which has, I think, started or about to start, at least for us in France. We will start, I think, in a couple of weeks, including patient there, where they are randomizing standard of care Dara VRD, so very fair comparison, auto transplant, Dara VRD consolidation, lenalidomide maintenance, 2, Dara VRD induction, 6 cycle, cilta-cel, lenalidomide maintenance. So I think the design is fair, very well balanced. There's no bias. There is this issue of maybe doing apheresis immediately before the induction. We'll see the feasibility. The question here, and you may have noticed that one of the advantages of using CAR T cells, at least today, the way we do it with cilta-cel and ide-cel with the label and the indication, is that we don't use maintenance therapy. And here, and this is huge for the patient in terms of quality of life. They love it, the treatment-free interval. So here, it looks like we are reintroducing the concept of maintenance, which we have with auto transplant. So we are maybe switching and changing the philosophy of of CAR T cells without maintenance. But I think we have already some phase 1 data. For instance, here, these data from colleagues in China, in Shanghai, small biotech, developing dual targeting CAR T cells. And this was presented at the last ASH meeting. Small number of patients, but definitely you can do them frontline after VRD induction, and the results seems to be very promising. But obviously, it's only 16 patients, and you can appreciate no comment, 100% everywhere when it comes to response and MRD negativity. So when we look to the first line treatment, actually, you can see that if it comes to response to MRD negativity, even in resistant disease, CAR T cells are ticking the boxes. They are doing well. Single administration, that's true. Short-term side effects, in general, I had a lot of patients telling me who had auto transplant and then CAR T cells at relapse, oh, why you didn't do CAR T cells before? Because the side effects were much milder. We should not ignore the pharmacoeconomic evaluation, because it's not only about the rich countries and those people who can afford it. It's about accessibility, availability, and we do have a shortage of CAR T cell slots these days, and affordability. So we need to pay attention to this, that we have to allow access to the broader number of patients. We should not ignore the need for bridging therapy, and it may not be very easy. Well, maybe in the frontline setting, well, you do your induction. But in the relapse setting, we don't know yet, although I would say it would be a good problem to have, what are the long-term side effects? Well, because if I'm talking about long-term side effect at 10 or 15 years, well, it means we are anticipating the patient are going to be alive, which usually the patient like. We should not forget that for the time being, these CAR T cells are being used only in big academic centers. And the question is, if you're using, for instance, frontline an anti-BCMA CAR T cell, in the time of relapse, actually, probably you will need different constructs if you want to rely on CAR T cell. But maybe the problem would be solved with the bispecific antibody. So, as you can appreciate, there are more questions than answers, but it's always better to discuss a problem, even if you don't find solutions, and avoid, hiding it. I think we all believe that CAR T cells against BCMA today, but also GPRC5D or other tumor antigens, are effective, safe. They are feasible even now in early relapse progression, thanks to KarMMa-3 and CARTITUDE-4. There are new modalities, including the fast CAR, because the manufacturing duration is important. And now, I think the trial in newly diagnosed patients comparing or challenging auto have started. But also, I didn't mention this, but there are trials outside the auto setting. So with this, I'd like to thank you all for your attention, and more than happy to take your questions. Thank you very much.
There is any question?
Assalamu alaikum. Thank you, Dr. Muhammad, for this nice presentation. My question, what is missing here just to make CAR T cell curative in myeloma? Prof. Mohti, are you hearing us? Prof, you are hearing us?
Yeah, now I can hear you, because you have disappeared from me.
Thank you, Prof. Mohti, for your nice lectures. My question is about what is missing to make CAR T cell curative in myeloma. If we are starting to consider using CAR T cell, this is expensive and not available anywhere. So if it is just one line of myeloma treatment, but if it is a curative treatment, this will make it very well justified to use it early in myeloma treatment.
Well, the problem is that this is a wishful thought, because today we're speaking about multiple myeloma, but multiple myeloma is not a single disease. So I think before speaking about cure, and we can debate the definition of cure, of course, the idea is to dissect the different entities of multiple myeloma. And it is likely that there are subsets of multiple myeloma which are definitely curable. So at this stage, we are giving the same treatment to all, but we cannot exclude that in the next 5 years that there will be some well identified entity. I didn't mention this, but for instance, we do have already an entity. This is the translocation 1114 multiple myeloma, who is highly sensitive to anti-BCL2 agent like venetoclax. So I think the idea of cure will go with the better understanding of the different myeloma entities.
Thank you, Dr.
Thank you, Dr. Martin.
Is
Is
allotransplant be an option for myeloma these days?
Sorry, is allotransplant? Is this a question?
Yes,
Yes, allogenic stem cell transplant
be an
option
for any
Yeah.
patient these days?
Well, this is a recurrent question. And I think the answer is that more and more we are not recommending or performing allotransplant in multiple myeloma, except maybe in plasma cell leukemia. And of course, I'm not speaking about clinical trials. With all the available treatment options today, I don't believe that allotransplant remains viable, I would say, option unless we see key developments there in reducing the toxicity or separating the GVL from the GVHD. Having said this, I will need to be humble and moderate in my response, because depending where you are and where you're practicing, if you have a young patient, I have no access to any of these novel treatment options, bispecific, CAR-T, etc. And you're telling me I have a young patient with no comorbidities, I have a family donor, I would say why not? But in general, we do not recommend as a standard of care or routine practice allotransplant in multiple myeloma. We've done hundreds of these cases, and unfortunately, toxicity remains relatively high, although it's much lower compared to the historical data. But also, all of these patients, unfortunately, will progress, relapse at some point.
Thank you. We'll
get last question.
So thank you, Dr. Mufti, for your nice presentation. I have two questions in my mind right now. The first one regarding the CAR-T product that you used. How many days wash out from gas? Is it kosherable? Does it need to be according? Do we have any few days to stop it before the CAR-T? And what about the post CAR-T that have been used pre the CAR-T cell procedure? The second question.
So sorry, the sound is not very good, so I'm not sure I understood everything.
Yeah. The first question that I need, what about the washout duration for DARA before the CAR? Is it still
Okay, let me answer this one. So today, in the manufacturing process and in the label, we are required to stop any treatment 14 days before doing the apheresis, to collect the T cells and send them for manufacturing. Then it will take another 4 weeks. So it gives you like 6 weeks. Now, having said this, interestingly, you may think that daratumumab and an anti-CD38 will kill the CAR T cell. Actually, there are at least preliminary data showing that not only it doesn't kill them, but it can stimulate them. So it's a bit paradoxical. But I think when it comes to the relapsed refractory setting today, that's not really a big issue for us because obviously these patients have received daratumumab and failed some time before going to CAR T cells because CAR T cells are used in a really advanced stage. But the process as it is that you stop 14 days everything before doing the apheresis, then it takes you another 4 weeks. The issue is that this will give you like 6 weeks where you need some bridging. And obviously we don't use daratumumab or isatuximab for bridging.
So the second question, what about the patient relapse? Do you consider in the future we're gonna have alloCAR?
Okay, so you mean a relapse after CAR T cell, after the autologous CAR T cells? Well, here there are several options. Obviously, today the most widely used and popular option for us, which is available, is to use bispecific antibodies. And we have access to elranatamab, teclistamab, hopefully soon talquetamab. You have also, don't forget, XPO1 inhibitors like selinexor. You have antibody peptide conjugates like melflufen. So there are other options. Also, they're not commercially available, but we do have other autologous CAR T cells directed against GPRC5D in clinical trials. Now, what about the allogenic CAR T cell? It's a very good question because they are off the shelf, easily available, and we already could show, and we published this answer 3 years ago in December 2020, I think, during the COVID, our experience with allogenic CAR T cells against CD19, that they're very safe and quite effective. In myeloma, there is this construct, the allogenic CAR T cell. We didn't use it, so I don't have experience. But you have a nice publication in Nature Medicine about the phase 1 trial. They are safe for sure. They don't induce GVHD. They don't have CRS or neurotoxicity. The efficacy is still modest, so I believe it still needs optimization. It would be ideal, of course, if we can have easily available allogenic CAR T cells.
Thank you. Last question, Professor Mahdi. In the clinical trial that you are going to start as first line CAR T compared to transplant, the apheresis before starting treatment in the CAR T line, is it for stem cell or for T?
No, it's to collect the T cells.
So there's no blood collected this line because
they will be collected after the induction as we do usually. So there will be stem cells collected. Yes.
Okay, thank you. Thank you, Prof, for your closing lecture. We'll go to the second lecture.
Shukran.
My name is Dr. Masih Zahrani. Second lecture is going to be by Dr. Rodriguez Otero. He's going to talk about cerebral therapy in multiple myeloma. Dr. Rodriguez Otero is a consultant and deputy professor at the University of Nevada. She is a member of the myeloma unit at the same institution and medical responsible of the clinical trial unit at Clinical Universidad Nevada. In Spain, where she leads the clinical trials and immunotherapy program since 2011 under the direction of Professor Jesus San Miguel. Dr. Rodriguez Otero's research interests include the malignant treatment and the biology of multiple myeloma and immunotherapy strategies. She has collaborated in more than 50 oncology and hematology clinical trials and several translational research projects. Dr. Otero has published articles in high-impact hematology journals and has presented at national and international conferences. Welcome, Dr. Otero. You can start your presentation.
Hello, my name is Paula Rodriguez Otero. I work as hematologist at the University of Navarra in Pamplona, Spain, and I would like to start by thanking the Saudi Society of Bone Marrow Transplantation for the kind invitation to join you in this post-EBMT 2023 meeting. I would like to apologize for not being able to be here with you. And my topic today is cellular therapy in multiple myeloma. And I have decided to focus mostly on the latest presentations that were shared in the European Bone Marrow Transplantation meeting regarding CAR T-cell therapy in multiple myeloma. These are my disclosures. So we know that the treatment landscape of multiple myeloma has significantly evolved in the recent years with the incorporation of second-generation proteasome inhibitors, second-generation immunomodulatory agents, as well as anti-CD38 monoclonal antibodies. However, unfortunately, patients with myeloma continue to relapse, and we know that outcomes where patients are exposed to the three main classes of drugs remain suboptimal, with a median progression-free survival that is shorter than 5 months and an overall response rate of only 13% based on the data from the prospective observational locomotion study. We also know that triple-class exposed patients do not have a standard of care regimens, and in this study, 92 unique therapies were used for the treatment of 248 triple-class exposed relapsed refractory myeloma patients. Therefore, novel agents with different mechanisms of actions are needed to be able to overcome multi-drug resistance in the setting of triple-class exposed relapsed refractory multiple myeloma. And this has been the population of patients that was defined as an unmet medical need population in which BCMA-targeted therapies has been developed. And luckily, we do have now 2 BCMA-directed CAR T-cell therapies that are approved both in the European and also by the FDA, that are ciltacabtagene autoleucel, cilta-cel, and idacabtagene vicleucel, or ide-cel. These 2 CAR T-cell constructs were approved based on phase 2 single-arm pivotal studies. So ide-cel was evaluated in a population of 3 or more prior lines of therapy, the majority of them triple-class exposed in the context of the KARMA study. 3 different doses of ide-cells were evaluated, 150, 300, and 450 millions of CAR T-positive cells, and in the 128 patients that were infused, overall response rate was 73%, with 1/3 of the patients achieving complete response or better. Importantly, patients that were treated at the highest dose level of 450 millions of CAR T-positive cells had a better overall response rate, 82%, and also 39% of the patients achieved complete response or better. Median progression-free survival in all ide-cel treated patients was 8.8 months, and it was longer for patients that were treated at the highest dose level, and also longer for those patients that achieved complete response or stringent complete response. Ciltacabtagene autoleucel, or cilta-cel, was approved based on the data from the CARTITUDE-1 study that also enrolled a population of patients with triple-class exposed myeloma that were exposed to at least 3 prior lines of therapy. The outcomes are depicted here in the slide. Overall response rate among 97 patients that were infused was very high, 98%, with an stringent complete response rate of 82.5%. With a median follow-up that is now over 27 months, the median progression-free survival has not yet been reached in this latest update presentation, with a PFS rate at 27 months of 54.5%. So this study is going to be updated in this European Hematology Association meeting this summer. So regarding the safety, so more or less we can say that the safety profile was comparable between the 2 products. So regarding cytopenias, the incidence of grade 3 or higher neutropenia in the 2 studies was 95% for cilta-cel and 89% for ide-cel. Cytokine release syndrome was very frequent, seen in 95% of the patients treated with cilta-cel, in 96% of the patients treated with the higher dose of ide-cel, but importantly, the majority of the events were grade 1 or 2. The median time to onset for CRS symptoms after cilta-cel infusion was 7 days and was only 1 day for patients that were infused with ide-cel. Neurological complications were less common, seen in roughly 20% of the patients, and 5 out of the 97 patients treated with cilta-cel in the CARTITUDE study developed a delayed neurological complication with movement and neurocognitive symptoms that are not fully understood, but apparently are related to the BCMA expression in the basal ganglia, and that were typically grade 3 or higher. So we do have now real-world data that is being generated, and this is the first experience of the Myeloma CAR T-cell consortium with 159 patients that were infused with ide-cel in the real-world setting. Importantly, as you see here, 75% of the patients that were treated with ide-cel did not meet the KarMMa inclusion criteria due to comorbidities, and despite this, the median progression-free survival was comparable to that of the KarMMa study, as well as overall response rate and complete response rate. In this latest EBMT Congress, the retrospective experience from the EBMT register was also published, and you see here that 33 patients were treated with ide-cel across Europe, 20 patients were treated with cilta-cel, and the median progression-free survival was 12. The median follow-up was 12 months for ide-cel, 7 months for cilta-cel, and 76% of the patients were alive in the last status at last follow-up for cilta-cel, 90% for ide-cel, and you see here that responses are, let's say, comparable to what we see in the pivotal studies. So what's next in the development of CAR T-cell therapy in multiple myeloma? So as other colleagues in the lymphoma and the BALL setting have done, so the idea is to move CAR T-cell therapy earlier in the course of the disease in populations that still have an unmet medical need. And the first of these such populations are patients that are triple class exposed, but in earlier disease settings. And these are typically the patients that have received at least 2 prior lines of therapy that become refractory to an IMiD and refractory to anti-CD38 monoclonal antibodies, in which the options that we do have approved are not very exciting, let's say. So this is in fact the population that was enrolled in the KarMMa-3 study that compare ide-cel against standard of care regimens. Patients with 2 to 4 prior lines of therapy, all of them triple class exposed, were randomized 2-to-1 to ide-cel or to standard regimens. Patients that were allocated in the standard regimen arm received 1 of 5 of these standard therapies based on prior exposure and prior refractoriness. Treatment was continuous until disease progression, and at the time of confirmed PD, patients could cross over to the ide-cel arm. Patients that were enrolled in the CAR-T arm underwent leukapheresis, received optional bridging therapy using the same 5 standard regimens that were proposed for the standard of care arm, and then received lymphodepleting chemo and ide-cel infusion with a target dose level between 150 to 450. Patients were followed for progression-free survival, and the primary endpoint of the study was progression-free survival assessed by the independent reviewing committee. So this is the summary of the key efficacy data. So the patient population that was enrolled was an advanced myeloma patient population with a median number of 3 prior lines of therapy. Sorry, because here there is a mistake. A median time from diagnosis to a study entry of only 4 years, and over 40% of the patients had high-risk cytogenetic abnormalities, and roughly 66% of the patients in both arms were triple-class exposed. So among the 386 patients that were randomized, 254 were assigned to the ide-cel arm, and this comprised the ITT population, and of these, only 225 patients were infused, and 91 are still ongoing for progression-free survival. Among the 122 patients that were assigned to the standard regimen arm, 126 did receive a therapy, with DPD being the most commonly used standard therapy. So regarding progression-free survival, a single infusion with ide-cel resulted in a significant improvement in progression-free survival with a median of 13.3 months compared to 4.4 months for patients that were treated with standard regimens. Likewise, overall response rate was also superior for ide-cel treated patients with an overall response rate of 71% as compared to 42% for patients that were treated with the standard regimens. And notably, the progression-free survival advantage was seen across different subgroups of patients, including patients with older age, patients with high-risk cytogenetic abnormalities, regardless of tumor burden or the presence of extramedullary plasmacytomas, and also regardless of the numbers of prior anti-myeloma regimens. The PFS benefits was also seen in patients whose disease were triple-class refractory and also penta-drug refractory. Regarding the safety profile, this was consistent with previous report. Hematological toxicity was the most commonly seen in the two arms, with a higher incidence of grade 3 or 4 events, hematological adverse events in ide-cel treated patients as compared to patients treated in the standard regimen. The median time to recovery of persistent grade 3/4 thrombocytopenia or neutropenia was 2 months for the thrombocytopenia and 1.9 months for thrombocytopenia and 1.7 months for neutropenia in the cohort of patients that were treated with ide-cel. Infections were also common in the two treatment in both cohorts, and grade 3 or 4 seen in around 20% of the patients. Of the grade 5 events that were reported, 18 out of 36 in the ide-cel arm and 3 out of 8 in the standard regimen arm were consistent with disease progression. If we focus on the patients that were infused with ide-cel, 225, cytokine release syndrome was seen in 88% of the patients, with the majority of the events being grade 1 or 2. 9 patients developed a CRS event grade 3 or 4, and 2 patients died because of a grade 5 CRS event, one in the context of the candida sepsis and another one in the context of a decline in organ function. Regarding investigator-identified neurotoxicity, 15% of the patients developed any grade neurological complications that were mostly grade 1 or 2. If we move forward to bringing CAR T-cell therapy to an earlier disease setting, another population of patients that continue to be difficult to treat and can be defined as an unmet medical need populations are patients that are refractory to lenalidomide. If we focus on the schemas that we may have available in our hospital, like KD, DVD, or PVD, we see that median progression-free survival for lenalidomide refractory patients is shorter than 10 months. Also, if we evaluate the data from DPD, although this is more of an advanced myeloma patient population, we do see that the median progression-free survival in lenalidomide refractory patients is only 9.9 months. So this is the exact population that was evaluated in the CARTITUDE-4 study. That's a study cilta-cel efficacy compared to standard regimens, pomalidomide, bortezomib, and dexamethasone, or daratumumab, pomalidomide, and dexamethasone in the treatment of patients with relapsed refractory multiple myeloma that has received 1 up to 3 prior lines of therapy and were lenalidomide refractory. We know already that the trial met its primary endpoint of significant improvement in progression-free survival, and the full disclosure of the data will be done at ASCO and EHA this summer. But still, another population of functional high risk are still are still relevant, and we do know that patients that, for example, relapse early after first-line autologous stem cell transplantation continue to do poorly with the therapeutical options that we have today, and there is an unmet need of and a need of evaluating the efficacy of BCMA CAR-Ts in this setting. So here we have data from the cohort B from the CARTITUDE-2 study evaluating cilta-cel in patients with early relapse after frontline therapy. And as you see here, only 19 patients were infused, and overall response rate was 100%, with 68% of the patients achieving a stringent complete response. The follow-up is still short, but 18 months PFS presented in the last ABMT meeting was 83%. We need to wait for more follow-up to see how this early use of CAR-Ts in these populations with poor outcomes really makes a difference. Another population of functional high risk that we know have a suboptimal outcomes are those patients that do not achieve minimal residual disease negativity after frontline autologous stem cell transplantation. So again, ide-cel has been evaluated in this setting. Patients that achieved less than very good partial response after autologous stem cell transplant, 31 patients were treated. The median follow-up of this cohort is close to 30 months. And you see here that the overall response rate was very high. 87% of the patients achieved PR or better, with 74% of the patients achieving complete response rate. You do see here that responses are durable for patients already lasting more than 13 months. And although the follow-up is still short, we can say for a population in first line, you do see here that the PFS curve looks very good, with a median follow-up of 13 months. So, so now we know that several BCMA strategies are being developed. And now we do have bispecific antibodies targeting BCMA and also another targets, CAR T-cell therapies we already discussed, and also antibody-drug conjugates. And more and more patients are being treated with BCMA strategies today. So the post-BCMA setting, patients that progress or relapse after BCMA-directed therapy represent a new unmet medical need population. And can we use BCMA therapies in patients that have been previously exposed to another BCMA-directed therapy? So the first question that we need to ask ourselves is BCMA still present? So we know that BCMA is shed from the surface of the plasma cell thanks to the action of the gamma secretase enzymes, and that we can follow the BCMA expression using soluble BCMA. So soluble BCMA is a surrogate of BCMA expression, and it also works as a surrogate of tumor burden. So we know that after BCMA-directed therapy and at the time of response, and this is data from the DREAM2 and DREAM1 studies, soluble BCMA levels decrease, reflecting the decrease in the tumor burden. And at the time of disease progression, the levels of soluble BCMA go back again to the baseline level. So in the majority of the patients, BCMA continue to be expressed, and we can follow this expression by measuring soluble BCMA levels. Nevertheless, we are seeing some patients in where there is a complete BCMA antigen loss. So in the KarMMa phase 2 pivotal study, only 4% of the patients that progressed after ide-cel therapy had a complete BCMA antigen loss. So this is still probably not a very frequent and probably not the main mechanism of resistance to CAR T-cell therapy. Still, we are seeing patients in which there is a biallelic loss of the BCMA locus that leads to a complete loss of the BCMA expression. Therefore, alternative targets or dual targeting may be a way to improve CAR-T outcomes. So what we know about real use of BCMA therapies or BCMA CARs after BCMA therapy. So this is the experience of the Myeloma CAR T-cell Consortium. And if you see here that patient that has received prior BCMA therapy, the median progression-free survival of ide-cel was very short, only 3.2 months, and the same holds true in a retrospective experience in the Chicago, analyzed in Chicago, 28 patients, and you do see here that patients that were previously treated with belantamab did very poorly with ide-cel therapy. We have similar information with cilta-cel, and this is data from the cohort C from the CARTITUDE-2 study. And again, we do see that median progression-free survival is shorter, 9 months, as compared to patients that were treated in the CARTITUDE-1, all of them BCMA naive, and also the overall response rate is no longer 98%, but mostly about 60%. So we do see that outcomes of CAR-T therapy after exposure to prior BCMA treatments is not optimal, and eventually dual targeting or the use of alternative targets may be a way to overcome this limitation. So this is experience that is still rather immature, only 16 patients, dual CD19 and BCMA targeting. Overall response rate is quite high, but the follow-up is still very short. Again, so this is a preclinical data from the Barcelona group evaluating a BC-stronic CAR-T targeting CD229 and a BCMA. And you do see that in a model that had heterogeneity in the expression of BCMA, with 15% of the cells that were BCMA negative, you do see that the BC-stronic CAR-T is the one having a higher survival. So again, suggesting that a dual targeting may be superior to overcome either a down modulation of the target or a heterogeneous expression, or also maybe to overcome a BCMA negative relapse. So also we have other targets, and GPRC5D is a very interesting one. And we have here data from the phase in human dose escalation studies evaluating a GPRC5D targeting CAR-T. The median follow-up is still very short, but I think that the data in patients with prior BCMA therapy is very encouraging. 78% of the patients achieve an overall response rate, 44% of the patients achieve a complete response or better. We do see here that responses seem to be durable and tend to deepen over time. And for sure, this is another attractive alternative for patients that have already received prior BCMA therapy. So to conclude, despite continuous improvement in survival, myeloma patients continue to relapse, and when patients already fail to the three main classes of drugs, outcomes remain very poor, and we need new therapies to salvage these patients. So CAR-T therapy, mostly targeting BCMA, is showing impressive clinical results in late-stage myeloma. We have now 2 phase 3 randomized studies in unmet medical need populations in early relapse. The CARTITUDE-4 evaluating cilta-cel in lenalidomide refractory patients, and the KarMMa-3 evaluating ide-cel in triple-class exposed early relapse patients, the 2 of them showing benefit in terms of progression-free survival. Novel modalities, we've included novel targets, strategies to shorten vein-to-vein time are being developed. And also we know that some phase 3 randomized studies evaluating CAR-Ts as part of the frontline therapy are ongoing. And with that, I close, and I thank you all for your attention.
Thank you, Dr. Rodriguez. This actually was the recorded presentation. Dr. Otero, are you with us?
Hello, my name is Paula Rodriguez Otero. I work as hematologist at the University of Navarra in Pamplona, Spain, and I would like to start by the Saudi Society of Women for the kind invitation to this poster.
الدكتور موجود الدكتور.
بس ميوت احنا ولا
شيء اونلاين دكتور اوتيل؟
لا 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 مو موجودة.
She is not online. Okay.
اللي بعد دكتور.
So maybe we'll proceed to the third presentation and the speaker will be introduced by Dr. Turkis.
We'll move to the next talk about latest advances in myelofibrosis. That's going to be presented by Nicholas Kreuger, who's a professor of medicine and medical director of Department of Stem Cell Transplantation at the University Medical Center Hamburg, Bendorf, Germany. Prof. Kreuger is board certified in hematology, oncology, and internal medicine, and from 2018 to 2020 was a president of EBMT, and from 2012 till 2018 he was a chairman. Was the scientific council chair of EBMT. Dr. Kreuger has received several awards and working to date, including prestigious EBMT Bambam Award in 2015. In 2020, he was awarded as a doctor from University of Belgrade. Dr. Kreuger, floor is yours.
Thank you very much. Just give me a sign whether you can hear me. Can you hear me?
Yes.
Okay. Can you see my slides?
No.
No. Okay. We should go back.
Yes, now it's there.
You can see it now?
Yes.
Great. That's okay. So overall, it's a great pleasure to be at least online on the Saudi Arabian EBMT highlights 2023. I really would like to thank Ahmed Alaska for inviting me, and also Anna Zoreda for inviting me. So for this nice, long-lasting collaboration between the Saudi Arabian bone marrow transplantation unit and society and the EBMT society. So for me, it's a great pleasure to give you an update about the latest advance in myelofibrosis, especially regarding the curative treatment of allogeneic stem cell transplantation. So these are my disclosure for this presentation. So as you know, there are several hallmarks of the disease myeloproliferative neoplasia. So this is myelofibrosis, and one is a huge spleen, and the other is a severe myelofibrosis, but also osteosclerosis, as you can see, which historically was a major issue for transplanters, because huge spleen and also the severe osteomyelofibrosis was something which concerned the transplanters to do hematopoietic stem cell transplantation in this otherwise malignant and non-curable disease, because they were all afraid of engraftment. And still today, the engraftment still is, in contrast to other hematological disease, more frequently observed in myelofibrosis. But in the last years, let's say 10, 20 years, several approaches has been developed to facilitate this curative treatment in myelofibrosis.
Can you change the mode of presentation from speaker mode to the one slide mode?
Okay.
You can stop share. End the presentation. Just share it again and to continue like this.
It's better for you?
No, let's go back to the speaker. That's fine. Okay.
It's okay. It's
Go
okay.
ahead. Go ahead.
Okay. So as you can see on this example of bone marrow histology, you can see the severe fibrosis, you can see the osteosclerosis here, and you can see this malignant megakaryocytes, and you can see reduced hematopoiesis. So this was the reason why this disease has not been transplanted for many, many years. And one of the first reports about stem cell transplantation was just 20 years ago when the French Society of Stem Cell Transplantation, together with Fred Hutchinson Cancer Center, the Italian, and the EBMT, just reported only 55 patients, very young patients with a median age of 42, that this kind of treatment can be curative, as you can see in about 50% of the patients by using here at this time point myeloablative conditioning. But also at this time point, you can see that unmanipulated HLA matched transplantation resulted in a better outcome than those who were T-cell depleted or had received an alternative donor. However, when we look to the registry and the development of myelofibrosis transplantation in EBMT, but also in CIBMTR, so you can see until 2000, 2002, 2003, you can see less than 50 patients were transplanted per year in the entire European EBMT community. And you can see also that the median age of the patient was about 50 or a bit lower than 50 years of age, which is actually not the current median age at diagnosis for myelofibrosis, which is 65 to 70. So then in the EBMT, we developed in the late 90s a prospective phase 2 study investigating the reduced intensity fludarabine regimen followed by allogeneic stem cell transplantation, either from HLA identical sibling or from matched unrelated donor. And in some patients, also mismatched unrelated donors had been performed. And we included more than 100 patients. The median age is now older. It was 55 years of age. And you can nicely see that in younger patients, about 80% could be cured. So age was a significant factor, but also the donor. So HLA identical matched sibling, but also matched unrelated donor has also in survival about 80%, which was worse for those who had only and mismatched unrelated donors. And also the disease of the myelofibrosis at time of transplantation had also some impact on the outcome. However, at this time, the score was not the updated score according DIPS, it was the old Lille score. However, this prospective EBMT study has really moved the field forward because it could not only show that you can induce molecular remission by allogeneic stem cell transplantation, but also you can see a very rapid decrease in the bone marrow fibrosis, as you can see in this example. So on the left-hand side, you have seen this already. You have seen the severe fibrosis, osteosclerosis, and just 100 days after transplantation, you can see a complete resolution of the bone marrow fibrosis, a nearly complete resolution of osteosclerosis, but you can see there is some osteosclerosis, but you can also see a nice hematopoiesis without any fibrosis and a completely disappearance of this atypical megakaryocyte. So this then led to a rapid increase in using allogeneic stem cell transplantation, mainly with reduced intensity conditioning in Europe, but also worldwide. And nowadays we have about 500 patients per year who are receiving allogeneic stem cell transplantation for myelofibrosis. And the other development which we can see is that the increasing age. So nowadays the median nearly 60 years of age for patients who are receiving allogeneic stem cell transplantation, mainly by reduced intensity conditioning regimen. So you can see by this development, a rapid increase in this treatment approach has been observed in our history. So coming back to about the time point and which should be transplanted. So you know that the myeloproliferative neoplasia are divided into essential thrombocythemia, polycythemia vera, and both of these can transform into post-ET, post-PV myelofibrosis in about 10%. And also this disease can directly devolve into plastic phase, more frequently in P. vera rather than in ET, and also myelofibrosis, whether this is post-ET or post-P. vera myelofibrosis or primary myelofibrosis, can also transform in about 20 to 25% into plastic phase. And I talk briefly about plastic phase, but then the major indication is myelofibrosis, primary or post-ET, while ET and P. vera has a quite good expectancy of life. So currently there is no indication for doing allogeneic stem cell transplantation in ET or P. vera. So I start with the plastic phase. So plastic phase usually is associated with poor outcome in non-transplant setting. And interestingly, if we adjust secondary myeloid leukemia, this is data from the EBMT, into the underlying disease, you can nicely see, even if you adjust according age, cytogenetic, and other risk factors, that outcome of secondary leukemia derived from MDS is significantly better than those who were transformed from CMML, and the worst outcome were noted for patients who were transformed or transplanted for secondary leukemia after MPN treatment. And this is mainly due by a higher risk of relapse rather than a higher non-relapse mortality. So some data about the transplantation in plastic phase has been reported. So the early phase from EBMT, you can see resulted at least in a survival, overall survival out 30% long-term. And the major risk factor was being in complete remission at time of transplantation. More recently, EBMT had updated this with a higher number of patients, but the results were pretty much the same. About 30% can be salvaged by allogeneic stem cell transplantation in plastic phase. And also here confirmed the early EBMT data that being in CR resulted in a significant better outcome than those who received no CR and then proceed to allogeneic stem cell transplantation. So regarding overall survival, about 20% has been reported by CR and BMTR as well. However, here the achievement of complete remission was not so important rather than cytogenetic features, mainly if patient harboring P53 mutation, which resulted in a pretty poor outcome. Interestingly, accelerate phase. So accelerate phase in myelofibrosis is defined with blast count between 10 and 90% in peripheral blood or bone marrow. In this large cohort, which we did with international partners involving more than 300 patients, we could find in 35 so-called accelerate phases, means patients who underwent allogeneic stem cell transplantation with a blast count in peripheral blood between 10 and 19%. So interestingly, if you see the different results, there was no major difference in overall and relapse-free survival in patients who received stem cell transplantation for accelerate phase without any induction therapy before transplantation. There was a slightly higher risk of relapse, but this did not result in a poorer outcome, probably because the risk of non-relapse mortality was actually a bit lower in those patients who received allogeneic stem cell transplantation for accelerate phase. So I come now to the more chronic phase. So this is a chronic phase, is a myelofibrosis, the primary or post-ET myelofibrosis. And I will focus in the next 20 minutes about the patient selection, the best timing, but also how we can improve outcome after allogeneic stem cell transplantation. So here you can see what we talk about primary myelofibrosis. So in contrast to ET and P. vera, so this is the worst outcome. So the median survival, even if it had improved over the more recent year, the median survival for those patients is only 6.5 years. But you can see the disease course is quite heterogeneous. So we have patients, so about 20% of the patients who died within the first 2 years, but we have also about 20% of the patients who are still alive after 10 or even 15 years. So here it's very important to select patient, and for this reason, several so-called disease-specific risk scores has been developed. And one of the prominent is the so-called dynamic international prognostic scoring system, which can be used at every time point during the course of the disease and include age, constitution symptoms, anemia, leukocytosis, and peripheral blast count. You can see you have points, and then you can build a score between 0, intermediate 1, intermediate 2, and high. And you can see the survival differs substantially according to the different risk group as defined here by this DIP score. So more recently, other molecular genetic has been come into the field of myeloid malignancy and also in myelofibrosis. And there are some high-risk mutations, especially A6L1, ECH2, but also IDH1 and IDH2, which is part of this new classification, which is called molecular IPSS 70. So 70 means these are potential patients who can be treated by allogeneic stem cell transplantation. And with this score, you can also divide low risk, intermediate, and high risk. And you can see the median survival for low-risk patients is more than 25 years, for intermediate about 7.1 years, but for those patients with high-risk features, it's only 2.3 years. So that's because no randomized study existed and is very problematic to perform randomized studies if there is no other, let's say, curative treatment approach. So there are several methods to compare transplant to a non-transplant approach. This was done by EBMT study or by studies from the EBMT comparing transplant to non-transplant by so-called left truncation decision model. This is a hypothetical model, but it shows you that for low-risk patients, the non-transplant approach is more of benefit significantly, while for intermediate 2 and high risk, there is a benefit for going immediately to allogeneic stem cell transplantation. While this is not so clear for intermediate 1 patient, you can see an earlier, higher non-relapse mortality, but you have also some curative approach. So here, after 10, 15 years, the curve is crossed. So currently, no clear indication for allogeneic stem cell transplantation for intermediate 1. So CIBMTR reported similar results, even if the statistical model they used were a bit different, but they compared also non-transplant to transplant approach. So here in A, you can see the low-risk group, the intermediate 1, the intermediate 2, and high-risk group. And you can see the curves always cross, but they cross at different times. So for low risk, you can see the curve cross after 10 years. Here in intermediate 1, a bit earlier than in the EBMT, about 7 years. But you can see an early cross of the curves for intermediate and high risk. So CIBMTR resulted, so confirmed, or let's say they proposed also indication, a clear indication for myelofibrosis in intermediate 2 and high risk, and also a relative the indication in Europe in 2020, and you can see for DIPS intermediate 2 and high risk, there is a clear recommendation for allogeneic stem cell transplantation, either for matched sibling transplantation, but also for unrelated transplantation, but also here for mismatched unrelated transplantation. But I will come to this a bit later. So, however, when we see all the disease-specific risk scores, we ask a question whether the outcome of transplantation is also good if you use these different risk scores in the transplant setting. So we try to develop the so-called transplant score to show whether we have other risk factors for allogeneic stem cell transplantation than for non-transplant approach. And in this more than 360 patients where we had also a complete molecular workup, we could find the leukocyte count, the Karnofsky index, the CAL-MIBL unmutated genotype, the platelet count here, the cutoff was 150s, the age cutoff was 50, 70 years. Also, HLA mismatch unrelated was significantly a poor outcome, or for the molecular mutation, it was the A6L1 mutation, which has a hazard ratio 1.42. So interestingly, what you can see in this multivariate analysis regarding outcome after transplantation, so neither anemia nor the number of blasts were significantly for outcome after stem cell transplantation. So patient with a hazard ratio more than 2 received 2 points, the others received only 1 point. So we ended up with a score about low, intermediate, high, and very high. And you can see this translated into a very nice discrimination in overall survival. So low-risk patient had an overall survival about at 5 years of 90%, and then a relative low non-relapse mortality. However, if you have very high score, so let's say high or even very high, then the overall survival after 5 years decreased to 5 or even only 34%, with an increase in non-relapse mortality up to 50%. So this might help us. Here you can see the corresponding figures. So this is the cohort, then you see the validation cohort, and you can see this slightly discrimination between the different risk scores regarding outcome transplantation. And here you can really counsel patient probably what is the expected outcome after allogeneic stem cell transplantation, or what is the expected risk of non-relapse mortality if patients undergo allogeneic stem cell transplantation. So this has also clinical implications. So in our daily practice, when we see patients with myelofibrosis and they came to us with intermediate 1, intermediate 2, and high risk, and just asking for the indication for transplantation, especially for the intermediate 1 group, where there is actually no clear indication, but we should counsel the patient more on a personal basis. So here you can see in this slide, this is a correlation between transplant risk scores and the DIP score. So patient with DIP score intermediate 1, let's say intermediate 1, this is the yellow one, you can see that about 22 patients who are intermediate 1 have a low transplant risk. So that means these patients have an outcome of about 90% overall survival. So particular this patient, if this patient, we counsel them that the outcome of transplantation will be pretty good. And for us, this might be a patient group, especially if they are younger, to go also for allogeneic cell transplantation if they are only in intermediate risk 1 group. However, we have also 20% of the patient who have a high risk according to the transplant score, and these patients have a lower probability of survival after allogeneic stem cell transplantation and have a higher risk of non-relapse mortality. So these were patients where we certainly would not recommend allogeneic stem cell transplantation in a stage of intermediate 1. So this might help us to guide patients, to counsel patient probably, and then have a more personal approach in allogeneic stem cell transplantation. So we further try to develop this to further go more into personal medicine, and we look for dedicated mutations. And we recently looked for this P53 mutation, which is very unfavorable, especially for AML, but also reported for MDS, but only very few data were available for myelofibrosis. So we checked more than 360 patients for P53 allelic status. You can see, fortunately, the majority has no P53 mutations. And a very small group here, 19, has a so-called single hit mutations, while 30 patients from this large cohort, about 10%, had what we called multi-hit P53. That means they have 2 different mutations in P53, or they have a high allele frequency, more than 50%, or they have, beside this P53, also a complex karyotype. And these patients are characteristic usually by a low hemoglobin and platelet count. And when we see the outcome of the allogeneic stem cell transplantation on the right-hand side, you can see you can still cure patients with this multi-hit P53 mutation. However, the likelihood of being cured is only 30% and is significantly lower than for the wild type and for the single hit mutation. And interestingly, the single hit mutation did not differ significantly from those who have wild type. So if you check for P53, the recommendation is also to see whether this is a multi-hit mutation, because only these patients have a poor outcome. And this is mainly related to a higher risk of relapse, which we observed after allogeneic stem cell transplantation. And this patient group is also very interesting, often relapsed pretty fast, and they relapsed not very rarely with secondary acute leukemia. So more recently, also the CIBMTR developed a transplant score to counsel patient probably. However, they hadn't had any molecular data. So they included age, the cutoff of 50 years, hemoglobin here in their cohort. In their cohort, it was significant, and the donor, they found similar, that the donor is only partially matched, unrelated. They have a higher risk of non-relapse mortality. So, and this was just recently published, is on online only. You can see they separate also 3 different groups. However, the discrimination, so the EBMT, they provided some validation cohort, the discrimination was not so significant as we have seen for the transplant-specific cohort. So lastly, I will just give you some ideas how we can improve outcome after allogeneic stem cell transplantation. So you know, the stem cell procedure is not only the conditioning and the stem cell infusion. So it started already with the pre-treatment. This is important in leukemia patient, but becomes also more important in MPN and MDS, conditioning, the GVHD prophylaxis, and relapse prevention. And we have several options to intervene in these different steps. So when we start in the pre-treatment, so it's nowadays recommended, especially in patients with huge spleen and constitutional symptoms, to start with a JAK inhibitor. So for instance, ruxolitinib prior to allogeneic stem cell transplantation. And usually a couple of weeks is enough to shrink the spleen and improve constitutional symptoms. In this large EBMT study, interesting, we could observe, or we could see that patients who received ruxolitinib and then received stem cell transplantation, while they are still responding to ruxolitinib, they have a significant lower risk of relapse. This is the green right here, resulting in a significant better event-free survival, and also a trend for overall survival. However, the follow-up was quite short. While patients who did not receive ruxo had similar outcome than those who received ruxo but failed to ruxo and then received allogeneic stem cell transplantation, as you can see here in the red and in the blue curve. So suggesting in this retrospective but large EBMT study that if you have a patient who had indication for transplantation and has a huge spleen and constitutional symptoms, and you start ruxolitinib, you should not wait until patient is losing response to ruxolitinib, rather than to proceed immediately if patient respond best to allogeneic stem cell transplantation. So the intensity of the conditioning is always a question of debate. However, largely this is a larger study from EBMT showing that reduced intensity and myeloablative regimen resulted actually in similar event-free, relapse-free, and overall survival. And even another study which we did using molecular marker to see whether maybe high-risk cytogenetic, high-risk molecular genetic might benefit from a more intensive regimen. So you can see here all the different factors we analyzed, and at the end there was no significant factor which was really in favor for myeloablative or was in favor for reduced intensity. So thus, at least in our institution, we do only reduced intensity conditioning, also in younger patients. So the impact of the donor is, I mentioned this already, several groups has shown this. This is a combined Seattle-Hamburg approach in more than 380 patients, and clearly you can see matched sibling transplantation is still the donor of choice if available, followed by complete matched unrelated, and then followed by mismatched unrelated, or more recently some data about haplotransplantation. They are coming more and more haplotransplantation. This is one study from the EBMT, published just a couple of years ago, but there come also other studies from CIBMTR, from single center in Italy. They show all the same, so that the risk of non-relapse mortality is in general a bit higher. The risk of non-relapse mortality by graft failure is higher. So the overall survival is not as good as for a completely matched donor, but this is a learning curve. So we hope that with the PTCy approach, but most of these patients were treated with PTCy, that maybe in the future the learning curve will improve the results, so that allogeneic stem cell transplantation with haplo can achieve similar good results as with completely matched donors. So very important, and lastly in my presentation, is the so-called prevention of relapse. And in this disease, we have so-called driver mutation, with this JAK2, calreticulin, or MIPL. So in about 90% of the patients with myelofibrosis, you have at least one of these mutations. And you can monitor this with PCR technique. So in this 90% of the patients post-transplant. And here we analyzed this mutation load at day 100, on day 180. And in both time points, you can see patients who are still positive here by day 180. They have then a significantly higher risk of a clinical or hematological relapse during follow-up than those patients who were at this time point, 180 days post-transplant, MAD negative, detected by a sensitive PCR with CAL, MIPL, or check. And this is important for your follow-up because this is a disease, even if they relapse, the relapse is not so, let's say, so rapidly as you see in AML or in other disease. So you have time to intervene. And what we did in the last 20 years, actually, so we monitor this patient closely, if possible, and we call this then, if they were negative, becomes then positive, we call it molecular relapse. So this has to be determined by twice consecutive samples. Otherwise, they still have a good blood count and they have otherwise no signs of myelofibrosis. And we have also 20 patients who had received a hematological relapse, so with bone marrow fibrosis and the typical signs in the peripheral blood. So all these patients achieved donor lymphocytes infusion in an escalating fashion. So if they received a second transplant, they were censored. So what you can see that about nearly 90% of these patients who were detected molecular relapse and received DNI could achieve again a molecular relapse. And this could be achieved also in 60% in those patients with hematological relapse. However, the numbers of DLI to achieve this molecular relapse was significant, was a bit, not significant, was lower in the molecular arm. And very interesting, what you can see, there were some GVHD, but very limited. Interestingly, and this is here, I want to show you on here. So that is patients, there are significant, so half of the patient, which is not here on this slide, unfortunately. Let's see whether it's on the next one. No. There are about 40% of the patients who could achieve the molecular remission without GVHD. So you can target the GVL or GV myelofibrosis effect without graft versus host disease. So the outcome is quite favorable. So here you can see those patients who received, who achieved the molecular remission. So you can see the long-term run is about here after 15 years. So still 75% of the patients are still alive, while those who did not achieve the molecular remission, so who were treated for hematological relapse, you can see there is also a chance for long-term survival, about 30%. However, this was less than if you intervene in a status of molecular relapse. However, if the patient achieved a molecular relapse independent of the molecular or hematological relapse, you can see here, and then the outcome is always very favorable. However, all this data suggested that a monitoring of this patient post-transplant should be done regularly, also after 5 or 6 years, because late relapse can occur. And then an early intervention with donor lymphocyte infusion is justified in molecular relapse. And preferentially, you should not wait until patient has a complete hematological relapse. And with this slide, I want to end. So you have different options to intervene in the pre-transplant, pre-treatment, in the conditioning I mentioned, the selection of the donor, the GVHD prophylaxis, and most importantly, this harnessing of the immuno effect post-transplantation by monitoring with molecular marker and then discontinue CNI early on and start donor lymphocyte infusion. And to the lack of time, I did not mention, but also those patients who did not respond to donor lymphocyte infusion with the second allogeneic stem cell transplantation in selected patients at 30 to 40% long-term survival can be achieved. So I would like to thank all the members of my department from the European Leukemia Net, from the different, from the Chronic Malignancy Working Party, but also on the other partners who are working in this field with us to improve outcome after allogeneic stem cell transplantation for myelofibrosis. So I'd like to thank you for your attention, and I'm open for questions. Thank you very much.
Thank you, Prof. Further for this excellent presentation. We'll get to a question from Dr. Zaya.
Thank you, Prof. This is an excellent presentation. I have two questions. The first question, those patients with the intermediate risk group, nowadays we are doing the molecular marker, and we see a discrepancy between DIPS scoring and the indication of transplant and the MIPS 70s. Those patients, the MIPS 70, they are being having those high molecular marker, they are candidate for transplant based on the MIPS 70, but if you go to the DIPS scoring, they are not, they are intermediate one. So how strong the molecular marker justify your transplant, and would you still using the DIPS scoring or the MIPS 70? And the second questions, and this year, in 2023, when you will push for haplotransplant, because all the data mentioned in the, and you also presented nicely, the mismatch group, they are doing very poor. So, in those patients with high indication for transplant, and there is no match-related donor, when you push for haplo?
So very good questions, very interesting and good questions. So I will start with the first question. So it can happen that if you use both classification, MIPS and DIPS, and for the post-TT, for the secondary, we use also the MISEC system, if you're familiar with the MISEC system. So it can happen that patient is in DIPS, it's only intermediate 1, and in MIPS, it's high risk, yeah? In general, if we have this, let's say, not clear recommendation, we use actually both classification, but we see also the patient in which condition he is. And if the molecular data alone is for us not alone, let's say, an indication. So even if the high risk by MIPS is based on the molecular marker like A6L1 or IDH, we probably would not go or recommend the transplant immediately. But as I mentioned in my presentation, more importantly is then for us the transplant risk score. So then we look for the transplant risk score and we recommend the patient, if they have a survival, let's say a low risk for transplantation with 90% survival, we would recommend to go for the transplantation. If patient belongs to a high-risk group with a high non-relapse mortality, we would not recommend for the transplantation. So we would wait until patient is more progressingly. And then we come to the second question. Then we would go in high-risk patient also to haploidentical stem cell transplantation, mismatch unrelated transplantation. I think your second question is correct. If patient belongs to a high risk according DIPS or MIPS, and there is no HL identical sibling and no available 10 out of 10 unrelated donors, it depends on your experience whether you prefer 9 out of 10 or you prefer an haplo with PT-Cy. So currently it's no conclusive the data, but if you are more familiar with haplo, then I would recommend go for haplo. Otherwise you go for 9 out of 10. It depends a bit on the donor availability, on the donor age, on the relation, whether this is a male patient and a female donor. So male should be male. So there are also secondary factors which we selected when we decided whether we go for 9 out of 10 matched unrelated or we go for haplo. But in general, I agree, if patient becomes high risk according DIPS and MIPS, and you have no available donor, then you should proceed with haplo or with mismatch unrelated donors. However, you should be aware that the outcome is worse than after sibling transplantation. But as you can see in the curves, this is still curative. So these patients have more complications, but they still have a chance of being cured by transplantation.
Thank you, Prof. Kroeger, for your presence today with us. I think we're going to conclude our session, the first session for today.
For the sake of time, we are going to go back into the auditorium in 5 minutes.
5 minutes.
Just Jummah prayer.
I don't know if you can see my screen on the first slide.
Yes, we can see it.
Okay, thank you so much. So I will give an overview about last advances in MDS in the setting of transplantation. And here is my plan, quite simple: when and who transplant and how to transplant, especially how to optimize a transplantation. So to consider transplantation, the main question will be, sorry, I can't see my screen. And the main question is when consider transplantation in MDS patient. And to think about that, we have to estimate what could be the life expectancy without transplantation, which is mainly influenced by the disease, but not only, also patient characteristics. And what is the life expectancy with transplantation, which is again influenced by the disease, but not only, as you know, that's also influenced by transplant procedures and post-transplant potential complication. And we should not forget that these patients are at higher risk of cardiovascular risk. So here, that's the expected survival outside the setting of transplantation, and I have taken this recent analysis published in almost 3,000 with almost 3,000 patients. And using to develop the IPSS molecular. So you can see that from this IPSS molecular, we have 6 groups of patients from the very low risk to the very high risk who have a median survival around 1 year. And it has also been validated with a European consortium cohort, showing again these 6 groups of patients. So just to say that MDS is a very heterogeneous disease. And when we try to compare the most often used score, which are the IPSS, revised IPSS and the IPSS molecular, we have 2 categories of very high risk patients with survival less than 18 months, and we have this intermediate risk patients who have median survival around 3 years, and for them that's especially difficult to know when they can have an indication of transplantation, and I will go back to this later. We should not also forget that some lower risk or intermediate risk IPSS patients have actually a higher risk of mortality due to different reasons that can be a non-response to treatment, myelofibrosis, or life-threatening refractory cytopenia, for example. That's not included in the IPSS. And here, that's just to show, for instance, that patients who are not responding to erythropoietin stimulating agent have a much lower expected survival than patients who responded. So now we move to the outcome we can expect with transplantation with these 2 studies. On the left, and the cohort from the Italian group, and you can see that IPSS, the revised IPSS, is still prognostic in transplanted patients with survival from 20 to 70%. And on the right, that the same before, but in transplanted patients, you can see that IPSS molecular is still predictive with different groups of patients. And again, even if that's a selection of patients, the survival are heterogeneous. From the last EBMT Congress, we have also this experience from the Latin American registry showing again that the revised IPSS is still predictive in transplanted patients, and in this cohort, that's the very high-risk patient who have the worst outcome. So if we would like to predict the outcome after transplantation, as I said at the beginning, we have to take into account different parameters, and we have many scores to do that, but I will show more in details the EBMT score, taking into account the age, cytogenetics, the type of donor, Karnofsky score, CMV, blast, and platelet. And you can see that if you use this score, you can predict quite very well the survival in this patient with low, intermediate, and high and very high risk. And all these variables which are predictive are not related to the disease itself. So that's very important to estimate before transplantation what could be the outcome in this patient, especially in intermediate risk patients. So that's the same issue finally that for myelofibrosis, where Nicholas Kroger explained that in this category of intermediate risk, that's very important to take into account all other parameters. So we have 3 prospective trials based on the donor availability, meaning that if we have the intention to transplant the patient and the patient has a donor, we can compare the overall survival of patients with donor and without a donor. Unfortunately, or fortunately, I don't know, today we cannot do anymore this kind of study because almost all the patients have a donor, which can be an haploidentical donor. But anyway, in this study, we can see that there is an advantage of with transplantation, so in with donor, in terms of overall survival or event-free survival in higher risk patients. So these patients are intermediate to or high according to IPSS. All of them are older than 50 years. And in the German study in the middle, all patients receive 5 ASA at diagnosis, and only patients with a donor were transplanted. And you can see that there is an advantage for EFS, but not the first 18 months where the 2 curves are superimposable due to the delay to transplant first, and secondly to the non-relapse mortality after transplantation. So the benefits is observed after the second years. So there is an advantage of transplantation upfront for higher risk MDS patients, but is it true for all patients? The problem is that we also have very high risk patients, mainly due to genetic alteration. That's what are showing these curves here, with survival less than 10% in patients who have a monosomal karyotype, especially complex, and high risk karyotype with poor risk mutation. So, for instance, in this large CIBMTR study, we can see that the overall survival is only 20% in TP53 mutated patients. And when the patient have no TP53 patient, but they are younger than 40 years, we have to check if they have other high-risk features, which are here. If not, the survival is 82%. If yes, that's 49%. In patients older than 40 years, we have to check if they have a RAS pathway mutation. If yes, the survival is 30%. If no, if they have JAK2, that's not different. The survival is 28%. So we have 3 major mutations with poor prognostic here. Given overall survival after transplantation between 20 and 30%. So now we will see if we can do better in these very high-risk patients, and keeping in mind that the only transplanted patients can have a long-term survival. So even if the survival is only 30% or 20% after transplantation, that's still better than without transplantation. So one of the issue may be to reduce the failure to transplant. What does that mean? It means that in the prospective study I have just shown, 20 to 30% of the patient could not reach the transplantation, mainly due to disease progression, but not only. And so that's also published on the basis of a Swedish registry, where 24% of the candidates to transplant could not receive the transplant. So it raised the question of the pre-graft therapy to know if this is benefit or not. Unfortunately, we don't have any prospective study randomizing the pre-graft treatment, so that could be a little bit provocative, but you can see that, for instance, in this single-center study, which compare upfront post-hypomethylating agent or post-intensive chemotherapy, the relapse-free survival is strictly similar. So the question of upfront transplantation in MDS patients without waiting for the response to a treatment is still a debate, but can reduce the failure to transplant. The second point is actually this chemotherapy or targeted therapy before transplantation. And we don't have prospective study, but we have a registry study. On the left, the French registry study showing no difference using intensive chemotherapy or hypomethylating agent in MDS patients. Only patients who received both in gray had a worse outcome. And on the right, at the EBMT study, showing that even if you have complete remission or not, that's not really important for the outcome. Which is important is that patients who are primary refractory have the worst outcome. And if we take all the studies testing meta-analysis for pre-graft therapy in MDS patients, we fail to demonstrate a benefit of this pre-graft therapy. But we don't have all the information regarding new drug in development as well as combination, which may improve the rate of complete remission and maybe change or challenge this pre-graft therapy. And for example, here that's the treatment of AML-MDS patient with CPX-351, which give a very high rate of response. And in patients who have a donor, it can be used as a bridge to transplant. And you can see that the overall survival in transplanted patients is very good in these very high-risk patients. Now we'll see if we can improve the conditioning regimen to reduce the risk of relapse and if that's possible to intensify this regimen. So we have several phase 3 trials. The first one is the comparison between FB2 and WSI, and there is no difference in terms of overall survival. The second one is the American study, so it includes AML and MDS, and here I show you just the MDS subgroup. So that's different kind of marker versus different kind of RIC. The overall survival at 18 months is similar using RIC and MAC, but there was an excess risk of relapse in the RIC group. So usually, the idea is to do a MAC when that's possible, meaning in fit and young patients. And the last study is the randomization between a RIC and a sequential conditioning regimen, FLAMSA, to reduce the risk of relapse. But unfortunately, this is a negative trial without any difference with the control. Recently, we have an update about the phase 3 randomized study comparing FB2 to fludarabine and triosulfan. And there is an advantage of triosulfan in MDS-AML patients, mainly due to a reduced rate of NRM, but of course it should also be confirmed by other studies, but it can be an option in MDS patient to reduce NRM this time.
5 minutes remaining.
Yes. So I will speak about prevention, maintenance therapy to improve the post-transplant outcome, and it has been published with different combination or new therapy. All these new therapy gives a dropout around 50% due to infection, GVHD, or cytopenia. But when that's feasible, that's safe and it lowers the relapse risk. And at EBMT, there was the registry study comparing ESA to observation using a propensity score, showing an advantage of this maintenance therapy. Maintenance therapy with eprenetapopt may be very important in TP53 mutated AML and MDS patients. And here in this phase 2 study, we have very encouraging outcome in these patients. But unfortunately, the phase 3 trial comparing 5-ASA to observation was negative without any advantage in terms of relapse-free survival and incidence of relapse in the patient receiving low-dose 5-ASA maintenance. But there was again a lot of drop-off due to disease progression. So we should also think about the prophylactic donor infusion in MDS patients. And there are many ways to perform this donor lymphocyte infusion. The classic way is after immunosuppression withdrawn, but that can be an added back DLI after T-cell depletion, for instance, or manipulated cells. They are very encouraging results, but we don't have any prospective trial in this setting. And here, that's an BMT abstract from the German group showing that using preventive DLI, the relapse risk is very low. So that can be an interesting strategy. And regarding preemptive strategies, that means that we follow CD34 monitor chimerism or some specific leukemic antigens, and we start the treatment as soon as this is positive. And in these two phase 2 trials, we can see that 88 to 100% of the patients can receive 5-ASA, and the response rate is around 80% in these cases. So maybe preemptive strategies are a very good option in the future. So to conclude, high-risk patients have a better outcome with transplantation. Pre-graft therapy with intensive chemotherapy and hypomethylating agent may limit progression to AML, but has not proven to be benefit in MDS patients. MAC is recommended when patients are fit and young, but you have shown that RIC give quite good results in these patients. Triosulfan may improve outcome as compared to besulfan, but should be confirmed in specific situation. Maintenance with 5-ASA has not proven its benefit in phase 3 trial, but more prospective trials are needed to, especially in specific categories of patients. So I thank you very much for your attention, and I would like also to thank all my colleagues from Paris University, to the French Society, and from EBMT. Thank you very much.
Thank you, Dr. Robin, for this excellent presentation. Because of the time constraint and Juma prayer, we'll go on to the second part, will be presented by Dr. Badr.
All right, thank you very much. It's my pleasure to present the next speaker, Dr.
Sebastian Jibbin, who's the head of the Department of Transplant and Oncology Hematology at the Maria, it's called DISCA National Research
Institution of Oncology in University of Poland. Prof. Jibbin is president of the Polish Adult Leukemia Group, and he's leader of multiple societies, the leader of ALL subcommittee of the Acute Leukemia Party, and of the EBMT, and
it's our pleasure to have Jibbin today. This talk
Thank you very much for the introduction. Mr. Chairman, ladies and gentlemen, it's a great pleasure to be here. I was assigned a very provocative question as the title of my presentation. And in fact, I would prefer not to answer this question, transplanter, believer in transplants. Nevertheless, I will try to do my best. These are my disclosures. Unfortunately, EBMT 2023 abstracts are not very helpful to answer the question who should and who should not be transplanted. So I will start with a short introduction on the current standards. Current treatment of adults with acute lymphoblastic leukemia is quite different for pH-negative and pH-positive disease. In pH-negative ALL, we still use intensive chemotherapy, and we try to follow pediatric protocols to intensify the treatment in terms of the doses and time. It may be accompanied by rituximab for patients who are CD20 positive. After consolidation, we evaluate the risk of relapse, and for patients with standard risk, we follow with maintenance. For those with high risk, we refer these patients to allotransplant. In case of MRD positivity, after induction or after consolidation, we may try to eradicate it using blinatumomab, usually considered as a bridge to allotransplant. For pH-positive ALL, the intensity of chemotherapy is reduced. TKIs are the most important component of the treatment protocols. Imatinib is the only one approved for first-line therapy. All patients with pH-positive ALL are considered candidates for allogenic transplant, which should be followed by TKI maintenance, either prophylactic or MRD-driven. So, trying to answer the question who should not be transplanted, nowadays, I think patients with standard risk pH-negative ALL are the only group who may be avoided allotransplant. Obviously, we should not refer patients who are ineligible due to poor performance status, comorbidities, or age. The issue is that the definition of standard and high risk differs among countries and study groups, and this is the list of indications of factors that are considered indications for allotransplant according to a particular country. As you can see, the only common uniform factor is MRD status after consolidation. For those who are MRD positive after consolidation, allotransplant is the only chance of cure. The other factors like high leukocyte counts, adverse karyotype, or adverse immune subtype are considered only by some study groups. So coming back to EBMT 2023, there were no abstracts dedicated to answer the question on the indications for allotransplant, but I think some important presentations that may allow us to optimize the procedure and give insight into results, in particular ALL subgroups. So I will briefly mention the most important abstracts selected by me. The first one is the analysis of the Polish adult leukemia group, comparing results of allotransplant for patients with Ph positive versus Ph negative ALL. Ph positive ALL was traditionally considered a very high risk factor, while nowadays with the use of TKIs, results improved dramatically. And in terms of allotransplant, as you can see, results of allotransplant are much better for Ph positive ALL compared to Ph negative ALL that I believe was shown for the first time. Another analysis comes from the EBMT, Acute Leukemia Working Party. This is for the first time comparison of de novo versus secondary ALL. Secondary ALL is diagnosed relatively rarely, but it happens, and we performed a matched pair analysis showing absolutely no difference in terms of results for de novo versus secondary ALL. Another analysis regards autologous transplant, which is almost abundant, but some study groups still use it for patients who achieve MRD negativity as a treatment intensification. And my colleague, Dr. Svoboda, performed a retrospective analysis on behalf of the EBMT, showing that results of autotransplant are quite satisfactory for patients with T-ALL and much better compared to B-ALL. So maybe T-ALL, which is a population where we cannot offer modern therapies, modern immunotherapies so far, may benefit from autologous transplant instead of allogenic transplant. Another issue is the donor type. We have already published several publications showing no major differences between alternative donors for patients with ALL. During the EBMT meeting, the Chinese study group presented results of their prospective study focused on T-ALL, LBL, both pediatric and adults, transplanted in first or second complete remission according to genetic randomization. Those having matched sibling donors were treated with such a donor, while those lacking matched sibling donor were transplanted from haploidentical ones. These are results DFS for the entire cohort, showing no differences between disease subtypes, non-ETP, ETP, or near ETP. And these are comparisons for haplo versus matched sibling donor. For the entire cohort, there was no difference, some tendency towards better results for matched sibling donor transplants, but not statistically significant. While for ETP, the highest risk subgroup, results were even better for haplo compared to matched sibling donor transplant, and this difference reached statistical significance. So if we want to perform allotransplants, we can do this, in fact, in all cases, because almost all patients have either related or unrelated donor when we consider haploidentical as equally valid. The issue of donor type was also raised by the Spanish group for children between 1 and 19 years old and second complete remission. The authors compared once again results for haploidentical versus HLA matched donor transplants, once again showing absolutely no difference in terms of either overall survival or leukemia-free survival. Regarding conditioning, TBI is a standard of care for ALL. The most frequently used dose is 12 grays and 6 fractions. We raised the hypothesis that maybe reduction of the dose of TBI may result in a significant efficacy while avoiding some toxicities. And indeed, in this retrospective matched pair analysis, it seems that TBI 8 gray is safer, allows for reduction of non-relapse mortality without any effect on relapse incidence. As a consequence, there's a tendency to better LFS and better OS compared to 12 gray TBI. Finally, we also found that TBI 8 gray was associated with lower incidence of acute graft-versus-host disease and improved GRFS. Another issue is the type of immunosuppression, in particular T-cell depletion in vivo. Most centers, in case of matched sibling or unrelated donor transplants, use ATG, while mainly in the UK, alemtuzumab is used as a in vivo T-cell depletion. And Gesine Buch from our study group decided to compare in a matched pair fashion these two types of serotherapy. for patients aged 40 to 72 years old in first complete remission treated with RIG transplants from met sibling or unrelated donors. As you can see, there is no difference, so we are free to choose either alemtuzumab or ATG in such cohorts. Finally, some news about CAR T cells. In fact, in adults, we have one product approved for relapse refractory BCP ALL, which is brexucabtagene autoleucel. The registration was based on results of ZUMA-3 trial. These are follow-up data that were presented last year during the EHA meeting, showing approximately 50% probability of the overall survival at 2 years, which is very satisfactory, taking into account that was heavily pretreated, very, very poor risk population. During the EBMT meeting, there was a post-hoc analysis showing that probably patients pre-treated with blinatumomab respond worse to CAR T cell therapy compared to those blinatumomab naive, and also previous allotransplant may be associated with shorter median overall survival compared to those patients who did not experience prior HSCT. Italian study group showed some real-life data. The first 10 patients treated with commercially available brexucabtagene autoleucel. They confirmed a high response rate. 9 out of 10 patients achieved complete remission with MRD negativity, and in some cases, this remission state is long-lasting, although the median follow-up is still very short. That was summary of the BMT 2023. Now a few data from the literature regarding perspectives of the treatment of ALL, because the standard that I presented at the beginning of my presentation is going to change, I think, quite soon. The most important issue is incorporation of immunotherapy in first-line treatment. We have data presented during the ASH 2022 showing results of the randomized ECOG-ACRIN trial run in USA and Canada that was focused on BALL Philadelphia negative for patients aged between 30 and 70 years old who achieved MRD negativity after induction. These patients were randomized to receive either standard consolidation based on chemotherapy or chemotherapy in sequence with blinatumomab. As you can see, the overall survival was significantly better for those patients who were treated with blinatumomab in consolidation, and therefore the authors concluded that blina plus chemotherapy should be a new standard for BCP-ALL patients who achieve complete remission with negative MRD status. So not only to eradicate MRD, but also to achieve deeper response and potential cure among BCP-ALL patients. The rate of allo-HCT in both arms was very low, only 18%, so maybe this strategy allows to avoid allotransplant in a significant proportion of patients. Another study comes from the German group, which was focused on patients above the age of 55 years old, using inotuzumab plus dexamethasone and 2 courses of inotuzumab as initial treatment. These patients are generally not considered for myeloablative transplant. In fact, only 4 patients were treated with allotransplant in this cohort. But what is the most important finding is 100% complete remission rate achieved using inotuzumab monotherapy, in fact. So we don't need chemotherapy in induction for BALL to achieve complete remission. Event-free survival, overall survival, quite satisfactory considering the patient population. Now, for pH-positive ALL, there is a tendency to incorporate both immunotherapy and second, third generation TKIs in frontline treatment. This is the study from Italian GMEMA group that was published 3 years ago, showing that without systemic chemotherapy, we are able to cure the majority of patients with pH-positive ALL using dasatinib followed by blinatumomab plus dasatinib. In this group, approximately 1/3 of the patients were treated with allotransplant, which was at the discretion of the physician, mostly due to MRD persistence or recurrence. Only one patient out of these 23 died of transplant-related complications, which means that when avoiding chemotherapy in the front line, we reduce the risk of mortality after transplant. I believed 3 years ago that those results could not be better, but this year, group from MD Anderson Cancer Center published the results of their study using ponatinib plus blinatumomab followed by maintenance with ponatinib. Only one patient treated with allotransplant in first complete remission. By the way, remission rate 96%, complete molecular response 87%, despite quite advanced age. What is striking is 95% overall and disease-free survival, which for this patient population appears a miracle without allotransplant. So I believe this is the direction that we will follow in the treatment of adults with ALL Ph positive. How I see treatment standards maybe in 2024, maybe 2025, I believe that for BCP ALL, we will start with inotuzumab, maybe without chemotherapy for induction. Then consolidation should include blinatumomab. And if the patient achieves MRD negativity, he will not be a candidate for allotransplant despite the presence of other traditional risk factors. Only MRD positive patients will be considered for allotransplant. For TCP ALL, we will still use pediatric-like induction and consolidation, so intensive chemotherapy, because there is no alternative so far. And we will stratify patients according to currently used criteria, so standard risk patients will follow with maintenance high-risk allotransplant. For Ph-positive ALL, I believe dasatinib or even better ponatinib will be used frontline in sequence or in parallel with blinatumomab. Only patients who will remain MRD positive will be candidates for allotransplant, but this will be a minority. So as shown by MD Anderson Cancer Center, probably allotransplant will not be necessary for Ph-positive ALL anymore. So who should not be transplanted in 2024? This is speculation, but I would say patients with Ph-negative BCP ALL and CR MRD negative, patients with standard risk TCP ALL, and finally, all patients with Ph-positive ALL who achieve molecular remission. Obviously, those ineligible because of biological reasons as well. And finally, what is the future? This is a visionary, but I believe the treatment of ALL in the future will be very simple and very short, in fact. For BCP ALL, we will start with 100% complete remission, then consolidated with CAR-T. For TCP ALL, we'll still use chemotherapy, but only induction, then CAR-T specific for TCP. And finally, for Ph-positive, we'll achieve complete remission with ponatinib, and we'll consolidate it with CAR-T. So CAR-T, in my eyes, is the future, and I believe that this treatment will be very, very simple. But who knows when? Thank you very much.
Thank you very much, Dr. Jebel. Right in time. We have time for one burning question. Any questions? Oh.
I'm a pediatric medical oncologist in my background, so imatinib showed in superiority, at least safety, cost, and even outcome to this drug. So can you comment on that?
As I understand well, the tolerance of imatinib is better than dasatinib. Yes, this was your statement. Yeah, it is true, but
we are back to imatinib, at least in pediatrics.
Yeah, I agree with you. But if we think of avoiding allotransplant, we should start with second or better third generation TKI, in fact. But they are not approved in first line. So there is no dilemma for now. But this is the direction, I think. Ponatinib, blina, and no transplant.
All right, thank you very much. We will conclude the session today. Our next session, inshallah, will be at 1 p.m. 15. Okay. Thank you very much.
reviewer of multiple journals. The title is a very important title about CAR T-cell academic manufacturing. Dr. Kwame.
So thank you very much for the introduction, and thank you to the organizer for inviting me to be in this nice Congress. I will try to explain our experience in Barcelona in the development of this CAR T-cell academic manufacturer. These are my disclosure that are summarized in the fact that I'm very interested in CAR T-cell because I have been working for more than 10 years now, and even I don't have profit because I work in the hospital and I have my own public salary for this. I think the concept that I want to explain you is that for treat any kind of patients, we need to think about the different tools that we have, and one of these tools is the immunotherapy that should be combined in a clinical care, but also the production of the products that are necessary to introduce. Both elements should be, when we are trying or we are talking about products, should be controlled or should be managed by the pharmacology concepts, but both elements need to have good clinical practice and also good manufacturing practice for all the elements. So to arrive to this point, we need to have in mind the possibility to develop good elements in relation with the industry, and also to have good infrastructures to make possible to give this product in the best way. Finally, for arrive to have this product, we can go to someone that develop, but if you want to develop this product, we need to have good basic research, but also very good clinical research to have here. Talking about what is a CAR T-cells, I think it's important to have in mind that the CAR T-cell is a T-cells that is modified with a gene that allows the expression of a receptor. But it's a CAR T-cell, it's a T-cell that has their own TCR in general, and it's the way to have the final function of this, recognizing the tumor cell, whatever was these tumor cells. And even the CAR, it's just the chimeric antigen receptor, it's just the molecule. The function of this molecule arrives because you have a T cell, and the T cells are different for everybody that are doing these cells. If the cells in general can be cytotoxic, you will have cytotoxicity to the tumor. But this CAR T cell that is considered a drug, in fact, it's a product, it's a procedure, sorry. In fact, you obtain these cells for a patient that it's obtained their own T cells and later are modified by the introduction of the gene with the lentivirus or whatever was editing in the way to introduce the gene. And later you expand this and you obtain this final product, this ATMP product, Advanced Therapy Medical Product, that it's a product that arrives just for the cells of the donor. And this donor will be received just this product. So in some way, even this is a final product. This final product, it's under the responsibility of the producer, of the company, or whatever was the producer, but it's the ownership of the product start for the same patients. I think this is a really important aspect to have in mind. Later you will infuse, and the results will arrive not for all this procedure. The result will arrive after a good monitoring and clinical follow-up of the patients. And I think it's very important to have in mind that the CAR T-cell will work if we have the two elements in a good shape, the production and the clinical management. So both elements are very important for defining the procedure, and I think until now, even in the future can arrive to be allogenic products, until now the products is autologous procedure, and I think this is a different way to see the elements. In our hospital, as all the hospital I think in the world, our aim was to give the best treatment as possible to our patients. And this was the reason why when the first data about the options of CAR T cells appeared, we decided to develop our own clinical trial, our own product, our own card, based in our own antibody, CD19 antibody that we developed 30 years ago in our immunology service. And after have the opportunity to learn with Dr. Carl June in Pennsylvania how this will be managed, we decided to apply for grants, Spanish grants for the research agency in Spain, and we obtained the first grants to allow us to make all the preclinical, what we talk preclinical, the experimental data that allows us to be sure that we are able to have a product that are similar to other products used by this. After that, we have an addition. I think it's important, sorry, these two pictures, because these two postdoctoral students was very focused in this. Even the product will be a CAR-19, very similar to other. But they decided to focus in this because they want to arrive to have a product to be used in the patients. In any way, finally, after this, we make a point-of-care proposal of production, and we develop a clinical trial based in these preclinical elements. And after to have the support first of the government of Spain in a small grant of 300,000 euros, we arrived to obtain an additional €1 million that allows us to develop the clinical trial, because less than 1 million euros is almost impossible to develop a clinical trial, at least under the rules that we have. With this money, that is not too much for a clinical trial in general, we develop all the steps to demonstrate that we are able to produce this under GMP quality conditions. And later we defined the clinical trial that was approved by our Spanish drug agency. And this clinical trial allows us, especially due to the fact that we have a huge commitment in our hospital, more than 200 people in the hospital are in some way involved in this CAR proposal. But later, after to develop this in patients, we obtained results that was very comparable to other results of other products in CAR-19. And this was the reason that after presenting these 40 people treated in our hospital, we present this to our Spanish drug agency, and they authorize us to use as a product under this concept called in general hospital exemption. So we arrive in this point to obtain the aim that we have at the beginning, to treat our patients, because all these elements was for treat our patients. The problem is that as the product was good enough, not only for treat our patient, it's clear that we will never treat our patient if the product was not good, but having this as accepted by the regulators in Spain, a lot of people ask if it was possible to use this product in other places. And now this situation was only possible because we are a hospital, we are not a company, if we have collaborators. And this is the situation that we are now. We are looking for national and international partnership, trying to expand the use of this under this academical concept. Just to explain you that we are in the middle of Barcelona, it's a hospital in the center of Barcelona, directly related with the Hospital Sant Joan de Déu, that is a pediatric hospital, and we have now an additional facility just for production of the new quantity of lentivirus if we need to provide to other people to use this in their own hospitals and countries around the world. In any case, our hospital that it's next to the School of Medicine has this U shape. This is the building of the hospital, and in the middle of the School of Medicine, and is really related to the research institute that is here, that is very important for all this development, and also the University of Barcelona. And now this relationship between our hospital, the research institute, the pediatric hospital, and this company that allows us to move to production of the lentivirus in a higher scale, we have the relationship with our government, the Catalonia government health system, it's CatSalut, and later we have a relation in Spain with more than 32 centers around the city. And now we are looking for these partnerships with people that want to move in this, in the public concept of development. In any way, it's not impossible to make collaboration with companies. And in fact, we have a pharma company in India that is interested in develop this in the country. And after contacts between foreign offices of both countries, they decided that the only way to do this in India was through pharma companies. But there is a strict control of all the elements, how this product will be developed there. In any way, this is our proposal. Try to find people that want to use this. Our hospital has this U-shape in red, and we have clean rooms in the School of Medicine in the middle that allows us to produce a lentivirus at the beginning, but in a small quantity. It was very manual. We can produce 20 slots of virus for treating patients, so it's in 2 weeks of work. And now we are scaling up to make this more possible to share. And our clean rooms for the facility of production of the cells is inside the hospital. And here we have several bioreactors in our C-qualifier rooms, where now we have 4 in here, 2 in other place, in other small room for HIV, and we have other bioreactors that allows us to produce this for our patients in this way. This is the facility that you can see here, how we manage one patient around 7 or 8 days of production for arrive to have here. In Hospital Sant Joan de Déu, in this part, now we are developing a new facility that the building is already done. This is all the clean rooms, and we expect to start to producing for pediatric patients there probably at the end of this year. This is the building where is the facility, and we expect to go there. And in the other side, to have the capacity to produce enough lentivirus, because it's the key element for all this production, we have this agreement with Leitat in this northeast part of the city, where we have this GMP facility in this building, and this is a video where you can see how we are managing and producing here the lentivirus, and we are scaling up to be able to produce not 20 bags for each 2 weeks. We want to arrive to have at least 500 bags for 2 weeks of work. And we are moving this. And this is the first product that we developed. This is called burning captagene autoless cell. We call this burning cell. This is our carnitine, based in our antibody here. It's a 2-generation CAR, and we produce in this individual bioreactor. This is our articles that demonstrate that the product is sure and at the same time efficacious, and it's possible to treat patients. And in some way, to summarize all the data that you can find in this publication, these are the data for pediatric kids and for adult kids. That if you look the articles, by now we don't have been able to make any kind of comparison, direct comparison in a randomized way, but all the other products are not also compared between them for the same indication, but the data are very similar to the data that are appearing in the article. There is data in relation to acute lymphocytic leukemia that is shown in this graph, also for extramedullary disease that nobody has been able to introduce in this, and we have very good results and data. And also, surprisingly, I don't know why, but our product is quite good for CLL, and now we are trying to develop in a more deep work the indication of CLL. This is the Spanish document that allows us to produce this under hospital exemption rule. and you can see here this. And I think that's a first idea is that this RE1 is the first ATMP product to be authorized for a hospitalization in cancer in Europe. It's the first European CAR product to be authorized for ALL. Now we have other commercial product for adult ALL, but it's the first one that have any kind of authorization. And in fact, it's clear the first and I think the only public CAR product to be authorized. This is a general timeline schedule where you can find here the different steps starting in 19th, but in fact, it was just the antibody. But in 2013, we start all the procedure to arrive to this approval by the Spanish Drug Agency under hospital exemption. And now, in the last 2 years, almost 2 years, we obtained the prime designation by the European Drug Agency, the EMA, and we expect to arrive to have the final authorization for the product in Europe. This prime designation have never been authorized. It was not possible or was not available for any academic proposal. All the commercial proposal that all the proposal that was designated as prime product, priority medicine is the concept of prime, was until now a commercial product. Even some academic products was asked to have it, but we obtained this prime designation. This is the document of the prime designation, and this is the schedule that we have trying to obtain the next year, because I think it will be impossible to have it early, to have the final authorization. We move also for another CAR. This is CAR 19. We move to develop a CAR BCMA. This is called, as you can see here, Thesnicel. This is the name that we obtained. We call this RE2. The first was RE1. It's a CAR BCMA. And using this new construct, we have been able to combine the production in 2 centers in Spain and 5 centers, and now 7 in Spain. This multi-center, and try to obtain this hospital exemption for all the centers in Spain, and we expect to have along this June, maybe July of this year, and later move also to the EMA. These are the results. 100. This is partial results because now we are near to publish the additional 30 patients and to arrive to 60 patients, but with the first 30 patients, we obtain a 100% overall response. Even later, some patients are not complete response, and you can see here that the best response was at day 100 with negative MRI, but later there is evolution that lost some patients here. In any case, I don't know how we can change, because I'm sorry. Thank you. Oh, yeah. So we have other projects. We have this consortium of Spanish Children's Hospital, and we are developing for pediatric because we don't obtain the authorization in the pediatric at the beginning because the numbers was not enough for our drug agency. We have this agreement with this company in India, with a company also in Netherlands that is called CellPoint, that are developing this CLR proposal. And we have a very interesting agreement with this cooperative Netherlands group, Hoven, trying to make the first in the world, I think so, the first comparison between 2 different products, a commercial product and our product in lymphoma. The first 9 patients has been also introduced in the clinical trial. Even the clinical trial needs to arrive to 150 patients to make the comparison. So we have a long trip to be sure if the product is at least not inferior in the efficacy. We are developing a new product that is called RE3 with a company in Spain, a public company in Spain called Galeria. And this RE3, in fact, it's just a combination between our 2 lentivirus in just one product. We produce a dual CAR, just co-infecting our RE1 and RE2 lentivirus in the same cells. And we obtain cells that have both, just one or the other, and we want to use this in the treatment of lymphoma. So next to the CD19, this BCMA, we have different options here. And I want to comment that it's very important to have any opportunity to be used this under academic development, is to have the support of the government. And the health minister in Spain, through different proposals, all these are in Spanish because are documents for Spanish, are focusing to help this development through this academic network. And now we are looking new places in Europe, but also around the world, trying to arrive to an agreement and to have the possibility to make the procedures produced in different places. We have been able to produce more than 240 production by now, very similar success that other. And I think that this slide is the last concept that I want to comment, that it's a fact that until now all the development in CAR T-cell has been done in academic first step, but later the company obtained the rights, and the pharma company is the one that have the rights for development of the CAR. We think that this can be in some way maintained in academic world. I don't know that this will be easy, but we are in this way trying to compare the conventional way that develop drugs and this CAR that is start in the academy and later work to the pharma, by using the hospital extension as a bridge to move the first step of production under hospital extension and later to move to a market authorization by the EMA. I don't know if we will be able to do it, but it's our concept. Even we are not able to avoid the possibility to make a collaboration with pharma company. In any way, this is our aim, trying to maintain everything in academy. And I think that develop CARs in academic world, inside the academic field is possible. It requires a change of mentality, even of some rules that are not happy. Needs the help of the regulation and requires some to be patient to arrive to have this, but it's possible. It's important to have a big team, and in our case, 200 people is involved in this, mainly hematology, immunology, and research, but also pharmacovigilance, but a lot of different patients, in some way summarized in this picture, where there are not 200 professionals, because it was impossible to arrange this picture together, but hematologists are here, Susana Ribes in the pediatric area, Julio Delgado in the adult area, and here Álvaro Urbano, also immunologists, and the support of the hospital, the gerency, expressed in this yellow square that is showing the medical director, and a lot of people that make this possible. And thank you very much to everybody. And if you want to have some questions, probably later.
Thank you very much. So maybe we can attend. Yes, please. We'll take the questions.
Very nice, Manuel. This is great presentation. And it's shed the light on the role of academia and production of this CAR-T, not only pharma. So my question, I'm sure you compared the cost, and it would be nice to hear about this. And why didn't you license it at the end to pharma? Is there...
Why?
Why not?
Because in Spain it was very difficult. We are at the beginning we tried to find pharma in there, but later we are convinced that we need to have the freedom to operate in some way, the freedom to decide which are the patients, when, how, which is the clinical trial. Because when you are doing the things through pharma companies, you should follow the rules. And probably one of the final reason that for us is very important is that it was, at least in Spain, in some way defined that we don't have accessibility for all the patients. Specifically for CAR in relation to pediatric patients, where pharma company never will have enough patients to have their reimbursement. So we think that it's a good opportunity to change the way to make this autologous product. When the product was allogenic, probably will be different. But while this is autologous, I think it's important to change the way to focus this, because we have an opportunity, as has been demonstrated for more than 30 years with stem cell transplantation, of treat in a more personalized way the patients.
Thank you. You said now you are using it based on this program, hospital exemption, so not as an investigation.
No, it's already
So
approved.
my question, when you come to the patients and you counsel him for use of this product compared to the commercial FDA-approved and EMA-approved products, do you find any difficulties with patients accepting using this product?
No, in fact, in the opposite way. In general, the patient accept better product because they have confidence with the doctors, and we are the doctors. So in general, it's they are more confident with the doctors than with the pharma. So this is not a major aspect, because finally patients decide what is explained by the doctors, and the doctors try to be very accepting in the way to explain, because the patient is the important thing. So for us, I think the clear aspect is we accept to make this comparative study with Netherlands people, because if finally the product of the commercial is better, we will use just the better product. But now we don't know which is the best. The data seems to be very similar. We have less toxicity because we are able to decide. We infuse the product in a fractionated way, in 3 fractionated doses, making 10%, 30%, 60% of those, and this allows us to reduce a lot the toxicity. So there is too many reasons, but in any way, the patient doesn't have any problem because the product is approved, and finally, how this is explaining to the patient is the important element to decide which is the product. It's not a major issue.
We have time for one more question. I know it's an exciting and stimulating lecture.
How about the cost?
Sorry, the cost in our hands is 89,000 euros for patient. In Spain, our product for commercial product is 320,000 euros. So it's a 1/3, more or less, a little more than 1/3 of the commercial price. But have in mind that we are not able to scale up the production because we are treating our patients. So the cost, well, one important part of the cost is because we are treating a small quantity of patients. So we expect, if we have collaboration, the price of the lentivirus, that it's around 8,050 euros for each dose of the lentivirus, can decrease, because we are not a profit. So we are looking the way to make in the cheaper way, but at the same time, we need to return all the inversions in all these things.
I hope you can resist the attraction to go into pharma industry.
No, now it's sure that we'll resist. Nobody wants us to be involved in our product, but I think the product is good enough. But I understand that in different countries the solution should be different. And it was explained by our health ministry that in India was impossible that this product was developed in hospitals, because public hospitals is not easy. So we are open to find a way, like was possible in each country, to use this in a collaboration, because finally the responsibility and the product is for our side. So it's we want to share all these things. Sorry.
Have you noticed any learning curve in the improvement of the outcome or in the management of the toxicity of your products, or even in the containment of the costs, which may suggest that with time you will go commercial, or you haven't noticed any learning improvement over time?
We are learning a lot over time in all the production, and we try to share this with this, but we don't have in mind now to find a commercial
So the
sharing.
outcome hasn't changed over time since you started the program until now?
Yeah.
Thank you very much, Dr. Manal.
The important thing is the cells. I'm sure that it's not the product, because the important thing is the patient. How is the patient? How is the immune system in the patient? And how are the cells that you are using? How do you manage is not so important. Sorry.
Thank you very much. Thank you.
Good afternoon. It's an honor for me to be here and to introduce my friend and colleague, Dr. Mohsen Zahrani. Dr. Mohsen is a consultant hematologist and stem cell transplant at King Abdulaziz Medical City, and he is currently head of the division of stem cell transplantation and cellular therapy at King Abdulaziz Medical City, Riyadh. Dr. Zahrani has obtained his medical degree MBB CH from King Abdulaziz University. He obtained the Saudi Board of Internal Medicine, and then he did his fellowship in the Dalhousie University, Halifax, Canada, 2 years there, and he's did a stem cell transplant in the same university. Dr. Mohsen will talk about the stem cell transplantation hemoglobinopathies. So Dr. Mohsen, you have 25 minutes.
Thank you, Dr. Saad. I'd like to thank SS BMT for inviting me to present in this congress. I will talk about stem cell transplant for sickle cell disease, and the next speaker, Dr. Jozo, he will talk about the thalassemia. This is my disclosure. I will try to summarize in this presentation our transplant activity in our center, especially for adult, and some of the challenges that we are facing and how to overcome them. And I will present selected abstract from the latest BMT 2023. I will start with the case presentation. This is a 19-year-old male referred to us for transplant. He had history of stroke 5 years before he came to us. He was treated with monthly transfusion and hydroxyurea. And his MRI brain showed multiple old infarct and moya disease. So continuing with chronic transfusion, the risk of another stroke is around 11%, and if there is no intervention, the risk is more than 60%. So this was very clear indication to take him for transplant. We find a full match related or sibling donor, his brother, who was healthy. He underwent the transplant in 2015. If you see the first visit, his hemoglobin was 98, and the last visit, 7 years post-transplant, his hemoglobin is 152. His hemoglobin S now is 0, despite having only 87% chimerism or mixed chimerism, and he has no hemolytic marker. He did not require any transfusion, no admissions, no GVHD. He finished his school, then he finished the university study, and we think he is cured now. Sickle cell disease is a very common monogenic disease. More than 300,000 babies born every year worldwide. It is common in Saudi Arabia. We have more than 80,000 patients. For Ministry of Health website, there is the rate of carrier state is 4.2%, and disease state is 0.26%. In some areas like Eastern Province, the carrier state is up to 17%, and the disease is 1.2%. It was estimated from one of local studies around 10,000 of the patients they need transplant based only on 3 indications, which is stroke, recurrent acute chest syndrome, and VOCs. This is a very big load of patients who need the transplant. Sickle cell disease and mortality is a known problem for a long time, and we know that sickle cell patient previous decades they lived until the 3rd decade, but now with improvement in therapies, we see some sicklers living to the 4th decade, and rarely we see patients in the 5th or 6th decade, especially with the new modalities of the treatment, and hopefully this curve will go further. So their survival is lower than normal general population. In one of the studies from USA, 2 centers, the median survival for sickle cell and S-beta-null thalassemia is around 48. The median survival is around 48 years. And for sickle cell C and S-beta plus is 54.7 years. So there's also poor quality of life in sickle cell disease. This was a study with the questionnaire about health-related quality given to different types of diseases, including cancer patient, thalassemia, sickle cell disease, and compared them to the healthy population. So in the left side, we see the pediatric population, and the right side is the adult population. You see the sickle cell disease, their score for health-related quality of life is almost similar to the cancer patient, and also for adult patient, it's less. The health-related quality of life score was even less than cancer patient. The cost of the treatment for sickle cell disease is very high. This is a study from USA. The lifetime sickle cell disease attributable cost is very high. For a female patient is $1.5 million. And for male is $1.7 million, and out-of-pocket cost is $42,000 for female and $45,000 for female. The total economic burden on inpatient care of individual sickle cell disease patient in the United States was $811 million in 2016 alone. And we have similar number of population to the USA, so we estimate the cost of treatment here in Saudi Arabia may be similar or around that number. So the sickle cell disease is associated with lower survival, poor quality of life, high cost of therapy. Unfortunately, we don't have a very effective therapies. We have the old-fashioned treatment, transfusion, hydroxyurea, folic acid, and the new drugs like risankizumab, foxilitora, and L-glutamine. None of this is curative, and some of them just provide mild control of the disease. One of the drugs, like risankizumab, was negative in the phase 3 study compared to placebo. So we have to look for curative options like allogenic transplant and gene therapy. The first case treated with allogenic transplant was in USA, published in 1984, a patient with sickle cell disease who developed acute leukemia, and the patient underwent transplant from a matched sibling. So the patient was treated cured from the leukemia and from sickle cell disease. This opened the door for transplant in hemoglobinopathies, and we saw the curve of transplant over the years increasing. This is a report from CIBMTR, especially starting from 2010. The number of cases reported to the CIBMTR and which underwent transplant is increasing year by year, and we expect now even more cases will undergo transplant. The indications for transplant patient with CNS events, end organ damage like sickle nephropathy, hepatopathy, sickle lung disease, recurrent acute chest syndrome defined by 2 attacks in the last 2 years despite on best available therapy, recurrent VOCs 2 per year requiring admission despite on best available therapy, multiple joint AVN despite on best available therapy, recurrent priapism, regular red blood cell transfusion 8 per year to reduce complications or symptoms, red cell aluminization, and poor quality of life. The outcome of transplant in children is excellent and improving over time. In some reports, it's almost approaching 100% overall survival. And as you see here, multiple studies, the collective number is more than 94% overall survival, and disease-free survival is more than 91%. Our colleagues here in this hospital in pediatric, they compared the outcome of sickle cell disease patient who underwent transplant using myeloablative conditioning compared to the reduced intensity conditioning. As you see, the curve for myeloablative conditioning was the survival, event-free survival was 100%, but the reduced intensity was associated with significant lower event-free survival with higher risk of relapses. The concerns using myeloablative conditioning is risk of premature gonadal failure, amenorrhea, and infertility. So you are curing the pediatric patients, and when they grow up, they have this major problem. And this is what we see when these patients refer to the adult long-term follow-up clinic, and the risk of long-term transplant complications. This is a registry-based study from different registries, 1,000 patients, majority pediatric. The outcome based on the stem cell source was, as you see, cord blood was high, followed by bone marrow, and then the peripheral blood. But the overall survival for children in this large study was 95%, and for adult is 81%. So the survival for transplant in adult is lower than children's. And the reason for this worse outcome in adult is multiple, which include organs dysfunction and reduced tolerance to myeloablative conditioning, multiple transfusions and higher risk of graft failure, iron overload, impaired immunity, increased risk of CNS event. So different centers start to look for different protocols, especially using reduced intensity conditioning and non-myeloablative conditioning in adult patients. This protocol, which was developed by NIH, it's a chemotherapy-free regimen. Basically, there is the conditioning is alemtuzumab, which is a monoclonal antibody against CD52 on T cell and B cells, and plus total body irradiation 300 centigrade. And the GVHD prophylaxis was sirolimus. And the outcome of this protocol was reported in different publications, but overall survival 94% and disease-free survival 88.5%. And this was also done in other centers and published in multiple publications from different centers. And our publication in collaboration with NIH and Chicago, 110 patients, almost resulted in similar outcome, 94% overall survival and 87% event-free survival. The fourth study is a pediatric population, which has also a similar outcome. One of the things in this protocol, all patients have mixed lymphoid chimerism, as you see in the curves on the left side. For our group, we have this abstract in ASH in 2020. So event-free survival is 87% and overall survival 97%. When we compared our transplant using this protocol for adult to pediatric group in our hospital using myeloablative conditioning, as you see, the event-free survival and overall survival for pediatric group is 100%. But if you for overall survival, we improved the curve compared to the previous publication from the large registry-based study that it was 81% for adult. Now we improved it to 97%. This is another case that we did for him, the transplant, 43-year male patient with sickle cell anemia, and he has sickle nephropathy and end-stage renal disease. He was treated with transfusion hydroxyurea and he was in peritoneal dialysis. We did transplant for him in June 2021 from a match-related donor carrier, his sibling, and as you see, his hemoglobin pre-transplant was 56 gram per liter, and post-transplanted was 147 gram per liter. His creatinine was high, so we have special modifications in this protocol to accommodate patient with end-stage renal disease. He underwent kidney transplant 18 months post bone marrow transplant, and it was successful double organ transplant, and now his creatinine, as you see, is normal. And we have this publication in last EBMT as abstract showing the feasibility of doing a transplant for patients with end-stage organ damage like kidney failure and liver cirrhosis, child A and child B. With, as you see, the event-free survival was 100% and overall survival was 100%. 6 patients with sickle hepatopathy and 6 patients with sickle nephropathy. Now we are doing this transplant as outpatient mainly, with giving prophylactic antifungal, antiviral, anti-BCG, and ciprofloxacin. We did 39 patients as outpatient almost for the last 8 months. 8 patients did not require admission, 31 patients required admission, but there was no ICU admission. The median days of admission was less 21 days. 3 patients developed febrile neutropenia, and the platelet and neutrophil engraftment was not affected by doing this as outpatient. So this allows us to do more transplant of patients with this protocol, and it will be improve the quality of life for this patient when they underwent transplant as outpatient. So in our experience, the advantages of this protocol, it is tolerable, no age restrictions, no GVHD, can be done in high-risk patient, and it preserves fertility. So from the total group we did so far 250 patients, 21 had successful pregnancies. Some of them they have multiple pregnancies, and 1 had twin. It can be done as outpatient. Disadvantage, graft failure is 13%. Patient may need to continue on sirolimus. In our previous publication, 17% of patients at 5 years, they continue on sirolimus, and the last follow-up for us is only 4% they are on sirolimus. Mixed chimerism, majority of patients, and there are studies showing now linking this mixed chimerism in hemoglobinopathies post-transplant with increased risk of clonal hematopoiesis and myeloid malignancy. In our experience, we did 251 patients, 204 patients, they are more than 1 year post-transplant. 75% of them, they have mixed chimerism with median follow-up 39 months. Some patients, they reach 7 years. None develop this clonal hematopoiesis and none develop myeloid malignancies. We are not checking for it, but with follow-up, we did not have any patient who developed this complication. So the graft failure is the major problem with this using like non-malleability or reduced intensity conditioning. And not only that, it's associated with lower survival. This is a publication from last ASH from our group by our fellow Dr. Isra. So those who has graft failure, they have lower survival, 74%, compared to those with no graft failure. And when we look to the factor that increase the risk of graft failure, ABO incompatibility, the minor ABO incompatibility was associated with increased risk of graft failure. Major ABO incompatibility was not, actually it was predictive. 16 patients with major ABO incompatibility, none of them developed graft failure. Alloimmunization was not associated with increased risk of graft failure. However, RBC antibodies against donor RBC antigen was associated with graft failure. RH mismatch, CD34 dose, CD3 dose was not increasing the risk of graft failure. And the multivariate analysis, the only factor that was associated with graft failure is RBC alloantibodies against donor RBCs and minor ABO incompatibility. Major ABO incompatibility was protective because in this group we are using rituximab before the transplant. So strategies to reduce the risk of graft failure, to select the best donor with the full HLA match, ABO match, and avoid a donor who has antigen and the recipient has antibody against this antigen. Intensification of immunosuppression before conditioning, and I will show abstract from EBMT about this. Intensification of conditioning regimen, using BTCY as GVHT prophylaxis or Hablo protocol for match-related donor, rescue immunosuppression of graft chimerism drop, and use of hydroxyurea and hypertransfusion pre-transplant. This is what we are doing with Hablo transplant. So our protocol to reduce the risk of graft failure, as I mentioned, to select the best donor who is ABO match. If the patient has RBC alloantibodies directed against donor RBC antigen, now we try to look for another donor. If there is no other donor, we do desensitization with rituximab, steroid, and plasmapheresis. If there is major ABO incompatibility, we give rituximab and 3 sessions of plasmapheresis, and we make sure the azoagglutinin titer is less than 32. Other factors to consider: the pre-transplant hydroxyurea, high dose of CD34. In this protocol, we use mega dose of CD34 and optimum cellular mass level post-transplant. This is from ABMT last meeting from Netherlands. They are using the same protocol, but they give in this protocol preconditioning like immunosuppression with azathioprine and hydroxyurea for 3 months. And as you see in the graph there, the level of T-cell chimerism improved significantly, reaching 80%. The event-free survival is improved also. In our experience, it was 87%. Here, it was 94%. So, by giving the immunosuppression before conditioning regimen may reduce the risk of graft failure. Another publication from the EBMT. This is from Indian group. They use this. They call it Apollo protocol for match. This is a pediatric group from match-related donor or unrelated donor. So. They used the Hablo protocol, Fluocy TBI, plus they added Thiotiba and ATG and BTCY as GVHT prophylaxis plus sirolimus. But they had the same concept of immunosuppression preconditioning with azathioprine and hydroxyurea for 3 months. And they also here they use the peripheral blood, not the bone marrow harvest. And as you see in the Kaplan-Meier curve, there is improvement in overall survival and reduced risk of graft failure. both reaching 95%. Another abstract from the EBMT, this is from our colleague in King Faisal Hospital here. They compared their outcome for adult patients between myeloablative conditioning and haploidentical transplant. So in the myeloablative conditioning, they give Flu-BU4 plus ATG with GVHD prophylaxis, MTX plus calcineurin inhibitors. And the Haplo protocol is the protocol that we use in the Vanderbilt consortium, which is Flu-Cy TBI plus Thiotiba ATG pre-transplant and BTCY, and the source of the stem cells is the bone marrow harvest. They have shown the 3-year overall survival for matched sibling donor is 95.1%. There was no graft failure. So by giving myeloablative conditioning, you can reduce the risk of graft failure. But however, there is still risk of 5% mortality, and mostly come from complications from myeloablative conditioning. And the haplo transplant, although small number and short follow-up, it was 100% overall survival. So the concept here, you can use myeloablative conditioning in adult, but there is an increased risk of complication, morbidity, and mortality. This was also abstract from the last EBMT from different centers from Netherlands and Vanderbilt and the group of Dr. Jisoo, who is here with us. So they do the transplant and they follow the chimerism. If there is full lymphoid chimerism and with time there is drop in the lymphoid chimerism, they give immunosuppression with alemtuzumab, 1 milligram per kg. And there was 6 patients who have low non-myeloablative, 3 match-related non-myeloablative, and 1 match-related myeloablative. 5 patients responded to this immunosuppression with alemtuzumab. There was no increase of viral infection. This approach needs to be explored in large cohort. So now we'll talk about the other challenge, which is availability of donors. The finding of donor from this is multiple studies from Western world, 18% to find a matched sibling donor, and match unrelated donor is less than 18%, and haploidentical is universal availability. In our centers, for sickle cell disease, 57% we were able to find matched sibling donor for them. So if you don't have a matched sibling donor or match related donor, the next choice, like in malignant indication, you go for match unrelated donor. Now, there are multiple studies showing the effect of the outcome of match unrelated donor in sickle cell disease. I will just highlight this publication from Dr. Shinoy. It is BMT CTN study, phase 2 study, Flumil alemtuzumab. As you see, the risk of graft failure was 10%, overall survival 79%, and event-free survival 69%. This is a children group, and this is a very low outcome. With acute GVHD 28%, chronic GVHD 62%, 38 of them is extensive, and transplant-related mortality 28%. So after this publication, many of the centers, they avoid the match unrelated donor for sickle cell disease, unless in clinical trial. The other option is the haploidentical transplant. So you have the two concepts of reducing the risk of graft failure and GVHD either by giving BTCY or by ex vivo T cell depletion. I'll just talk about one, for the sake of time, one publication, which is our international collaborative or consortium, Vanderbilt consortium, which is using the haploidentical platform, Flu-Cy TBI, adding to it Thiotiba and ATG with the source of stem cell bone marrow, and BTCY plus MMF and sirolimus at the GVHD prophylaxis. The initial publication was in 2018 by Dr. Rizzo on 18 patients. Overall survival was 100%, and event-free survival was more than 90%. When more studies joined more centers, they joined this consortium, including our center and King Faisal here in Riyadh, with enrollment of more patients, 80 patients, as you see in the table. There was 50% for children and 50% adult. The graft failure for adult was 0%. So this protocol reduced the risk of graft failure in adult, but in children it was 25%. So this was not enough to reduce the risk of graft failure. and the risk of mortality was 5% in both groups. So for children, pediatric group in this consortium, there is more modification by giving hydroxyurea and hypertransfusion 2 months before transplant, and this hopefully may reduce the risk of graft failure. So in conclusion, there is global increase in awareness and utilization of transplant in sickle cell disease, especially with improved outcome of transplant lately. Transplant at young age with maturated donor using myeloablative conditioning provide the best result. Acceptable outcome in adult patient using RIC or non-myeloablative regimens. Graft failure is a major challenge. Strategies to mitigate this risk is proposed. Haploidentical donor transplant is the next donor of choice based on the current evidence. Thank you very much.
Thank you very much, Dr. Mohsen. It's great. 2 minutes, you passed your time by 2 minutes. So we have 3 minutes to take a couple of questions.
Assalamu alaikum. معك ناصر from جامعة الملك عبد العزيز في جدة. Thank you for a great talk. I was wondering, so in the past when we were taking these sickle cell patients to transplant, with the MAT conditioning, we were kind of selecting the more higher risk patients. The HENA, as we're moving more towards non-myeloablative, especially with the promising results in the SUN trial, what would you think is an ideal time to be offering transplant or to be taking these kids to transplant?
I think at pediatric age will be the best time to do the transplant, either using myeloablative conditioning, which will be the best choice. But the problem is the risk of gonadal failure. Non-myeloablative regimen or RIC, there are studies showing it is acceptable. And from our experience, it's we have couples who get like children or successful pregnancies. So this is the major problem with myeloablative conditioning. So doing this in children, I think this will be the best time to do the transplant. However, the number of the cases that need transplant is very high. As I told you, around 10,000, with clear indication for transplant like stroke, acute syndrome, recurrent VOCs, and maybe other, if you include other indications, the number will go high. So we have to prioritize our indications for transplant. So still, I think we should take the patient who have a strong indication for transplant. Those who doesn't have indications, they should have less priority.
The last question regarding
Actually, the idea of
we'll take one question.
The idea of RIC at King Faisal Specialist Hospital, which was started in 2011, was not only to deliver a reduced intensity to reduce the toxicity, but also to try to compensate for this reduced intensity by pre-transplant fractionated myelosuppression as well as immunosuppression. So we used to start a small intermittent doses of steroids for 2 months, like 10 to 20 milligram prednisone every other day for 3 days per week, with an optimized dose of hydroxyurea, which was targeting managing sickle cell disease as a clonal disorder. You induce remission in acute leukemia by intense chemotherapy, then conservation, and then maintenance of others. But with another clonal disorder like sickle cell disease, which is a stronger clone than acute leukemia perhaps, we don't usually induce myelosuppression. So this was the idea at King Faisal initially, and it did very well. One of the major factors of graft failure that was not published in the abstract, because I was not there at that time, was actually the presence of splenomegaly. They started to admit more patients with sickle cell disease without noticing that the presence of splenomegaly could actually suction the stem cells, because most of these cells were actually mobilized bone marrow stem cells. They are not peripheral blood mobilized stem cells, so they have homing quality different from the other types of cells. So many of these patients had their stem cells homing to the spleen, so the number of and the fraction of stem cells going to the bone marrow and proliferating there was actually much less. So we had to augment the graft after some time by more grafts. So the two major factors we need to optimize in our institutions, in King Faisal and National Guard and everywhere, is to try to treat sickle cell disease as a clonal disease. It's like leukemia. So you optimize the dose of hydroxyurea. You reduce the immune suppression. because they are heavily transfused. Number 3, highly selecting this patient is very important tool in the outcome of your patient. We tried to do fractionated splenic irradiation, but it failed because of lack of cooperation with the radiation department. So these 2 major factors over here will actually improve a lot, because you have nearly 30% of your sickle cell patients at the Eastern Province are fibrocongestive splenomegaly type of sickle cell disease. So they will cause homing problem as well as engraftment problem, etc.
Thank you.
Thank you for this comment. So last question, brief, please.
Regarding infertility, are we doing sperm or over freezing?
Yeah, thank you for this question. So all our patient, male patient, we do for them sperm banking. We stop the hydroxyurea 3 months and we offer them sperm banking. So far, none of our patients utilize this so far, but it is done for all male patients as optional. For female, we refer them to, we have fertility clinic in our oncology. So we refer them, they can do the oocyte preservation and they can give the gene RH analog.
Thank you very much.
Thank you
for this excellent presentation.
It's my pleasure to introduce the next speaker, who needs really no introduction, Professor Joso De La Fonte, a consultant hematologist and a professor of cellular and gene therapy at Imperial College of London. He was appointed as the director of the Pediatric Blood and Cancer Program and Transplant Program in 2016, specializing in transplantation for hemoglobinopathies and bone marrow failures. He is also the vice chair of the Pediatric Disease Working Group at the EBMT, a member of the steering committee of the BMT CTN 1507 trial, and the co-director of the Vanderbilt Global Consortium for a Cure. He is an investigator and the steering committee of several gene therapy trials in sickle cell disease and gene therapy and thalassemia. His talk today is Thalassemia, Advances in Conventional Transplantation and Gene Therapy. Professor Joso, the stage is yours.
Well, thank you very much for inviting me. It's a great pleasure to be here in the Kingdom, which I always find incredibly welcoming and feel part of one of you. And it's a reflection, I suppose, of the amount of collaboration that we have had over the years. So I really thank you, and I also thank EBMT for proposing me to be here. So my talk today is going to be an overview of the advances that have occurred in the management of thalassemia, both with conventional transplantation and gene therapy. Those are my disclosures. And so thalassemia, as all the other hemoglobin disorders, has its manifestations in relation to the switching on the globin chains. And this gives us an opportunity not just to change the actual stem cells and produce novel erythropoiesis that has a normal hemoglobin production, but actually to manipulate that switching, which is what we do with gene editing. As you know, the change of the gamma chain leading to hemoglobin F production onto adult hemoglobin with the beta chain production is controlled by the gene BCL11A that leads to the repression of that gamma chain production, and we now have the ability to switch that off, as we will discuss a little bit later. But let's start with thalassemia itself. The alpha and beta chain imbalance caused by the different mutations leading to this condition leads to ineffective erythropoiesis. As a consequence of that, there is not just anemia, but there is iron overload because of the disruption of the hepcidin axis. And so we have patients where there is organ damage, both by the iron loading and the anemia caused the disease, but also by the treatment that we provide. In addition, there is marrow expansion and bone disease, extramedullary hematopoiesis, peripheral hemolysis, causing gallstones and a hypercoagulability state that leads to further endothelial damage. And so we truly have a systemic disorder, which is not always well recognized in the context of thalassemia, unlike in sickle cell disease. Now, the survival of patients with the availability of transfusions and chelation treatment has improved substantially since the 70s when that was introduced, and you see that reflected in the improvement between the red and the green lines. But we have recently looked at this very carefully in 2 European countries where there is centralized healthcare systems. One is Cyprus and the other one is England. And despite of the initial promise of the oral chelators and the availability to be able to target the chelation treatment with MRI techniques, the reality is that there is still a significant reduction in the overall survival of these patients. And you see that in Cyprus, there is a 15% reduction against the general population in the modern period of care, and in the UK, there is a 5 times greater chance of mortality in comparison to the equivalent general population. In fact, it's not just a matter of survival, but of morbidity. And although many of these patients grow into the 40s and 50s, the reality is that there is a very substantial burden of care. And what you see there is data from the National Hemoglobin Registry in England. And so that encompasses all the patients and has been analyzed between 2009 and 2018, so a modern period of care where there was good chelation availability and the use of MRI T2 and ferret scan nationwide. And despite of that, after 25 years of transfusion treatment, over 90% of the patients have at least one organ affected, and often multiple organs, so that 40% of the patients have endocrine complications, 40% of the patients have osteoporosis with fractures and pains, a third of the patients have diabetes, and at least 1 in 5 patients have cardiac disease, half of them with arrhythmias, and half of them with heart failure. Now, in comparison to that, we have the ability of correcting this disease with conventional bone marrow transplantation, of which Lucarelli and his deputy, Emanuele Angelucci, who is the new Hemoglobinopathy Working Party chair, were fundamental in being able to introduce the technique. And some of you will be aware that it is ion control what determines the outcomes best in the context of the traditional busulfan and cyclophosphamide chemotherapy regimens. And so patients can be stratified according to whether they start the chelation early in life in the treatment, whether they had the chelation done regularly, whether it's portal fibrosis, and whether it's hepatomegaly. Now, the second thing to realize is that actually transplantation not only achieves a cure of the disease, but actually improves quality of life. And so what you see there is data from the Italian registry that clearly shows that, of course, the intensity of the transplant procedure leads to a reduction in the quality of life in the initial period. But if you were to measure the situation of these children a year and a half post-transplantation, they actually have regained a quality score which is indistinguishable from the general population unless they have developed chronic graft-versus disease, which is those who are dropping off in that graph. And so the approach to transplantation for thalassemia is very different than that done for hematological malignancies, in that even in the fully match-related setting, there needs to be an element of prevention of GVHD with serotherapy. And long term, we now have data of over 30 years comparing patients who have been transplanted against those who continue transfusion and chelation treatment. And despite of the fact that the majority of these patients were done with double alkylated agents, they actually, as you can see in the blue bars, had better quality of life than those who continue with conventional treatment, particularly in role limitations. So this is the ability to maintain a job, bodily pain, and emotional functioning, which is the ability to maintain a partnership with another person, despite of the fact that many of these patients, because they have received BUSI, will have been infertile. Now, there are a number of things that we have learned, and that is that expanded ineffective hemopoiesis puts the patients at risk of graft failure. And very much as the discussions that we were having a few moments ago about sickle cell disease, that can be quantified with MRI techniques, and we have adopted a number of strategies to be able to minimize this. And so we use hypertransfusions or hydroxychloroquine combined with azathioprine, or we add thiotepa, particularly to those patients who are of a young age. The greatest development in the last 15 to 20 years has been the adoption of fludarabine-based conditioning regimens. This was pioneered by Franco Locatelli and his group in combination with triosulfan and thiotepa, and that led to a very substantial reduction of toxicity. What you see in those graphs is that in that context, unrelated transplantation is not significantly different than related transplantation, and that the old classification according to the iron load of the patients seems to disappear in relation to the amount of events. Something that does not happen when you use busulfan, where there is still a significant difference between class 3 and the rest of the groups, though with the use of fludarabine and busulfan, class 1 and class 2 have similar outcomes. We went further and adopted the FTT strategy, but added serotherapy even in the context of related transplants. And that, of course, that leads to a greater risk of a stable mixed chimerism, but does have very low graft-versus disease. And so the 58 patients that we have done over a 10-year period leads to an event-free survival, or disease-free survival of around 93%, as you can see, with very prompt engraftment of around 12 days, and low rates of graft-versus disease of around 10 to 14% for acute GVHD, and a chronic graft-versus disease rate at 18 months of less than 2%. And that is by adding the use of a form of ATG or alemtuzumab, preferably Fresenius, because it has a shorter half-life and leads to less unstable hemopoiesis. And so the price that we paid is that, of course, only half of the patients achieve full donor chimerism in both the myeloid and the T-cell fraction, but this remains stable over time and leads to disease correction. Now, real-world data is now available from both EBMT and CIBMTR, and they are able to determine what are the most important factors for the long-term effect of these transplants. And interestingly, age has been the most important of these factors, with optimal transplant outcomes up to 13 years of age, particularly in the younger patients. And so what this is telling us is that we need to make bone marrow transplantation part of the treatment algorithm of these patients from the moment of diagnosis, and not to leave transplantation for those desperate cases where otherwise the chelation treatment is not going well. Indeed, CIBMTR has done the same analysis, like with EBMT, of over 1,000 patients, of which 2/3 were related patients and the rest unrelated patients, and they have encountered exactly the same. That age is the most fundamental determinant, with best outcomes up to 6 years of age, but very good outcomes up to 15 years of age. The second important factor is that in a modern setting with molecular typing and the use of fludarabine-based regimens, there is no difference between HLA-match related and HLA-match unrelated donors, unlike sickle cell disease, so that a greater number of patients are able to be cured with conventional transplantation. Whereas there is a problem of graft failure the moment that you start to introduce mismatched donors. And in the setting of fludarabine-based therapy, so not combined with double alkylated agents, there is very comparable cure rates with both busulfan and triosulfan for those of you who do not have triosulfan available in your countries. However, there is a lower toxicity when you use triosulfan, although there is probably also a slightly higher risk of secondary graft failure. And this also yet again identified that it is age, that of more than 10 years of age, and the use of mismatched donors, which are the factors associated with increased mortality and reduced long-term engraftment. Now, in my center, we have been working with the Johns Hopkins group to try to see whether we can apply a reduced intensity haploidentical protocol to this disease in the same way that we did for sickle cell disease. Cleveland Clinic and Vanderbilt Group also contributed a number of patients to this work. And so when we started trying to replicate what Molagios Meade had done, we found exactly the same as then, that 50% of the patients rejected the transplant. However, if you add either thiotepa or TPR, it is possible to reduce that graft failure rate to somewhere around 10%. With risk of graft-versus disease that, as you can see, is very acceptable, of somewhere between 20 to 30% in what it constitutes a haploidentical setting for an otherwise complex disease to undertake haploidentical transplants. We haven't been able to identify long-term differences between either use of TBI or 400 TBI or thiotepa. Though if you look carefully at the bottom, you can see that the event-free survival appears to have a trend towards being better in the 400 centigrade group, with a better overall survival, and that is the arm that we are currently adopting. However, it is from the countries in Asia, from Thailand and India, where I think the most exciting modifications to our protocol are coming and may be able to reduce further the graft failure rate and improve outcomes by minimizing graft-versus disease and any other alloreactive complications. And this constitutes the adoption of post-transplantation immunosuppression. So this is 2 cycles of dexamethasone and fludarabine previous to actually undertaking the transplant, and the adoption of abatacept, which, as you know, is now FDA approved, both for stabilization of the graft and to minimize graft-versus disease, given regularly until at least day +100. Now, I want to finalize the conventional transplant part of my talk by giving you a word of caution in relation to unstable myeloid chimerism and poor graft function, because I don't think this is specific to sickle cell disease or gene therapy or the use of hydroxychloroquine. We have looked very carefully at our last 65 patients with thalassemia, and we have identified 3 cases in whom there has been MDS AML, all of them with deletion 7 involved, and presented somewhere between day 60 to day 200 in the context of poor graft function and myeloid chimerism that was rapidly decreasing below 50%. And so it is essential that we are able to optimize our protocols to stabilize the graft function, and hence the use of post-transplantation immunosuppression, pre-transplantation immunosuppression in the haploidentical setting. Now I'm going to now move on to giving you an overview of the 2 strategies that exist for gene therapy. The first one is that of gene addition. So this is the Bluebird Bio product, Beticel, by which a functional hemoglobin is integrated with the use of lentiviruses, and this is the data of the long-term follow-up study. As you know, gene therapy patients need to be followed up for a minimum of 15 years as requested by the regulatory authorities. And so the data I'm presenting you here is when the patients have completed the first 2 years and they have enrolled in the long-term studies, either from the original phase 1, phase 2, or phase 3 studies. And this constitutes data on 32 patients. Now, the phase 1, phase 2 patients didn't have the product optimized, and so didn't achieve the good hemoglobins that the phase 3 have achieved, and so we have to be careful when looking at the data from that point of view. However, following 2 years of infusion, all patients have remained alive at last follow-up, and there have been no vector-derived replication or any transplant-associated complications. Those adverse effects that have been reported have been in relation to previous damage caused by the disease, like, for example, gallstones. And the transfusion independent, as you can see there, is durable. And so the moment that you have the dark blue lines, it means that the patient has remained transfusion independent. And so in the optimized product, in the phase 3 study, 90% of the patients remain transfusion independent, whereas in the previous product, before the manufacturing improvement, which was selecting a bright CD34 population with vector integration, only 2/3 of the patients were being cured. And you see in the continuous line what is the total hemoglobin of the patients, which is within the normal range, of which the majority, as you can see in the continuous blue line, is constituted by the new T87, this continuous line is the total T87Q hemoglobin that was integrated in the genome of the cells. And that allowed an improvement in the erythropoiesis, and whether you look at it by measuring the soluble transferrin receptor or looking at the trophon biopsies, you can see that the hypercellularity, the expansion of the hematopoiesis, returns to normality with a normalization of the ME ratio. And that is linked to the fact that you are able to reduce the ion burden either by venesections or the use of chelator agents, so that you do not leave ion in the organs of the patients that might cause long-term harm. Now, an alternative approach is what I was alluding to you at the very beginning, and is the cause of indels or insertions of deletions in the erythroid enhancer of BCL11A in order to inactivate it, so that hemoglobin F gets reactivated. And there are potential benefits of doing this approach in that you are not randomly integrated anything into the genome, and it may well be that that is a safer way of dealing with this disease. And so I'm going to present you here the 111 part of the Vertex trials, which accrued patients between the age of 12 and 35 who have been transfusion dependent for a minimum of 2 years. And so one of the benefits of doing gene therapy in thalassemia is that we are able to mobilize these patients with the use of G-CSF and plerixafor, unlike in sickle cell disease when one can only use plerixafor. And so very substantial number of cells are able to be harvested, to be edited ex vivo. Neutrophil and platelet engraftment is later than you will expect for an autograft procedure, and that probably is a reflection of the fact that the cells have been in the laboratory being dealt with. But the actual period of neutropenia is not substantially increased because the patients are only conditioned with busulfan, and they don't become neutropenic until around day 7 or 8 post-transplantation. So far, there have been 44 patients who have received exa-cel, and 42 of those patients are transfusion independent, with the 2 patients who haven't reached that point having reduced the amount of blood use between 75 to 89%. And patients who have received exa-cel achieve a normal hemoglobin level somewhere around 3 to 4 months post-transplantation, of which the majority, as you can see in that graph in dark blue, is hemoglobin F, and that is stable over time. And indeed, not only that hemoglobin F is pancellular, so it is in the majority of the stem cells of that bone marrow and is stable over time, but when we look at the editing, whether it's in peripheral blood, at the bottom on bone marrow at the top, you can see that there is a dropout, that we are really dealing with very early stem cells, which so far they appear to be able to provide normal hematopoiesis long term. And the safety profile is consistent with that of busulfan myeloablation. There have been 2 cases in the thalassemia arm where there could have been serious adverse events related to the actual product, but not because it was proven, rather than because we couldn't exclude it. One was a patient who had thrombocytopenia for quite a few months, and the other a patient who developed macrophage activation syndrome with idiopathic pneumonia syndrome, who was under my care, but both patients are transfusion independent and well at present. There has been 1 death in the sickle cell arm around 8 months post-transplantation in a patient who got COVID, although there may have been an element of busulfan lung damage. But overall, I hope I've been able to show you that age is the major determinant of transplant outcomes in thalassemia, that unrelated transplantation offers a long-term equivalent solution to patients with sibling transplantation in this disease. And so that you shouldn't be afraid of restricting conventional transplantation to those who have a related donor. That haploidentical transplantation is feasible and addresses the poor donor availability, and that we're starting to address the remaining challenges of GVHD and graft failure with the adoption of pre-transplantation immunosuppression and abatacept. However, there is no doubt that this early identification and incorporation of transplant techniques in the overall care of these patients, who is going to enable these patients to be cured at an early age and to grow into adulthood without organ damage. And now we have the possibility that a form of correction of the patient's own cells may offer us a solution without having to take the risks or more complex or mismatched transplants. So thank you very much, and I'm very happy to take any questions.
Thank you very much, Professor Joe. So there's time for 2 questions.
Dr. Abdullah. Thank you very much, Khoso, for an elegant, as usual, presentation. I have a question comparing the two genetic procedure, the beta cell versus X cell, in terms of how effective are they in the severe thalassemia, beta 0, in terms of maintaining transfusion-free, procedure. The other question, for the same thing, for the side effects, which one is more safe?
So in practical terms, and we have to be cautious that, of course, XSL has had a substantially shorter follow-up than beta cell. So we have to be careful not to be too prescriptive on the actual numbers. But I think they are very similar. They are somewhere around the 90% transfusion independence, no matter which one of the two techniques you use, with very similar normalization of the hemoglobin levels. We don't yet have data on XSL as to how effective it is in reducing the ineffective erythropoiesis. There is no soluble transferrin receptor data. There may be towards the end of the year for us. But the early data, at least, looks completely superimposable. I suspect as to which technique is going to be better will eventually depend on the price tag. I generally believe that that's what's going to drive one or the other. And whether the random, despite of the fact that, of course, it's very well controlled and there are lots of safety features in the vector, at the end of the day, there's a random integration when you use lentiviruses in a way that the CRISPR technology doesn't cause. So there is a theoretical advantage in using gene editing versus gene addition. But in reality, there haven't been vector-related events in the beta cell population. Everybody, I think, is aware that there have been 2-3 cases of NDS-AML, but they were all in the phase 1, phase 2 study where they didn't achieve good graft function, very similar to the cases I presented with conventional transplantation. And so I think we have to accept that it wasn't the actual gene therapy itself, but the inability to achieve good hemopoiesis that led to that clonal evolution. So Hani Had Abdullah, I don't think I can distinguish efficacy between two of them. There is at least a theoretical advantage of gene editing, but I suspect the final decision will come down to cost, and in principle, CRISPR technology is probably cheaper than the use of lentiviruses.
Great, one more question.
Now, I think one of the major playing factors in the success of any system, any indication, is the affordability. If you have a national epidemic disease or endemic disease like sickle cell disease and hemoglobinopathies, with an average number of 154,000 patients in the kingdom, which is 1.5 times the American level, and the healthcare system cannot afford it. I think we have to be more or less honest with our population over here. We cannot transplant 1,000 patient population on a yearly basis by all our systems, as Dr. Mohsen Zahrani said. We cannot advance all of these technologies to bring it in over here to try to apply it for even a significant proportion of our patients. But I think all of us over here from this region should be very, very strong regarding the recommendations of sticking to a major national system of premarital screening, doing all the comprehensive care segments for sickle cell disease patients, with offering enough hydroxyurea at preborn hospitals, enough medical care and medical awareness, vaccinations, antibiotics, and all other segments of the care, and instead of transplanting 50 patients per year to spend $5 million, 20 million real over here, you can actually offer a larger number of population over here some hydroxyurea to survive better, even to go for transplant in a better shape. So I agree with you, it's one of the best options over here. We have to move the curve from 81% survival to 90% survival to 97% survival to 100% survival. At how much cost? We over here, Dr. Ahmed Al-Askar, we should actually send a recommendation to the Ministry of Health and responsible bodies in the kingdom that we as hematologists need to have a better distribution of wealth for the needy population. That's it.
So that is a problem that we have throughout. You know, in the UK, the adoption of transplantation for adult patients has been very slow. And the reason for that is, of course, because it's a very substantial numbers. I think my view on the matter is that we should move away from using transplantation for complex and desperate cases, because those are the patients where the gain in the economic gain and the years gain for the patient is the least. And so sometimes you have to accept that there are going to be patients with very significant organ toxicity and damage for whom there is no solution. And so those are not the patients for whom you should recommend transplantation. And that will be even more difficult once, of course, gene therapy is commercially available. And my personal view is that we should be restricting it to relatively young patients, maybe teenagers or early 20s, where there is going to be significant gain and there is no organ damage, rather than to spend this tremendous amount of money in people for whom benefit is going to be limited. In the longer term, I remain very positive. It's already possible to put the CRISPR-Cas technology within nanoparticles, and I think at some point in the next 5-10 years, I don't know exactly when, we will be able to cut away the transplant bit of the treatment and to be able to do in vivo gene correction, and that will reduce the cost substantially. So, but that may take another 10-15 years, and we have to deal with the patients that we have in front of us now.
Thank you very much. We'll end this lecture. The last but not the least lecture in this session is with the title of Wondering Splenomegaly, Not Always a Malignancy. It's a Sanofi Satellite Symposium. Speaker is Dr. Maha Fadan. She's a consultant of clinical genetics and skeletal dysplasia, King Saud Medical City, Riyadh, and she's an assistant professor at the College of Medicine at Al Faisal University here in Riyadh. So, Dr. Maha, you have 20 minutes.
Okay. Assalamu alaikum. I know I'm the last speaker, so I hope that people are still awake. This is what. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وآله وصحبه أجمعين. My topic today is about wondering what causes hepatosplenomegaly. Not always malignancy. It's a little weird title. Okay. So as we know, we have a lot of long list of differential diagnoses for hepatosplenomegaly. Mainly, it is everything, all the medicine, If hepatosplenomegaly is combined with fever, we know that we should think about infection. If there is jaundice, anorexia, vomiting, we should look for liver diseases and cirrhosis as well with portal hypertension. If the patient have a history of recurrent jaundice, we have again to think of liver disease and hemolytic anemia. Dyspnea, difficulty in feeding, we should think about cardiac problems. And for delayed development in children, we have to think about carbohydrate and lipid storage disorders. And if there is family history of genetic disorders as well, this will make us think more about those diseases. So the most common important storage diseases we have to think about it when we see a patient with hepatosplenomegaly. From a metabolic genetic point of view, we have the lipid storage disease. The most important are Gaucher disease and Niemann-Pick disease, gangliosidosis, mucolipidosis. We have another category which is called mucopolysaccharidosis. Hurler and Hunter are mucopolysaccharidosis type 1 and 2. We have glycogen storage disease, mainly type 4, and we have amyloidosis. Going to the target, I will mention two case scenarios. The first case is from my patients, actually. The first case is 4 years old Saudi boy, referred at the age of 1.5 years with history of abdominal distension and constipation over the last 2 months before presentation. Seen in private hospital before and found incidentally to have low hemoglobin of 4 and platelets of low platelets, also thrombocytopenia. It was 51,000, but white BCs was normal. He received twice blood transfusion because of low hemoglobin. No history of major problems like in ICU admission, surgical procedure, no history of traveling abroad or contact with sick people. Developmentally, he was totally normal, and regarding family history, the parents are first cousins, and they have 2 other normal siblings with no similar problem in the family before. So this is my patient. They brought him to our hospital for further workup, and you can see on examinations wearing eyeglass, although he's a little boy. He was well and active, but has mild pallor and stable vital signs. Normal growth parameters. He was wearing eyeglass because of refractory error, and he has strabismus. No dysmorphic feature, as you can see, but his abdomen looks distended. He has significant hepatosplenomegaly, 3 and 5 centimeters below costal margins, respectively. Other systemic examination are unremarkable. We have done bone marrow biopsy that showed hypercellular bone marrow in many cells with wrinkled tissue paper appearance. You can see it, the arrow side, and this is what we call Gaucher cells. We proceed to enzyme assay, and they found the enzyme assay showed low activity of glucocerebrosidase activity. And we proceed to molecular testing that showed homozygous mutation at GBA gene. This is the mutation, the leucine to proline at 483 position, which is a frequent pathogenic missense mutation that confirmed Gaucher disease. Patient started immediately on enzyme replacement therapy, and he is on it up to now. And we referred the patient to multidisciplinary team specialties to take care of his problems, other problems. So starting with Gaucher disease, it's a multi-systemic inherited lysosomal storage disease with variable degree of involvement of central nervous system. It was first described in 1882 by French dermatologist Philippe Charles Gaucher. He described a woman, 32 years old, with big splenomegaly, and they thought at that time that it is splenic cancer. Later on, in 1965, the true biochemical nature of Gaucher disease was understood. And the gene that caused a mutation in GPA gene caused Gaucher disease, which located on the long arm of chromosome 1. This disease is inherited. It's an autosomal recessive inherited disorders. The parents should be carrier, and there is a chance of a 25% chance of having Gaucher disease in each pregnancy, another 25% chance of having normal child, and 50% chance of being carrier like both parents. So what's the problem in Gaucher disease? Deficiency of glucocerebrosidase enzyme, or what another name, acid beta glucosidase enzyme, will make this problem. If it is absent or it has low activity, it will lead to deposition or accumulation of glucosyl ceramide in the reticuloendothelial system, the monocyte and macrophages. This will cause the problem in every tissue in the body, mainly in the liver and spleen, bone marrow, and brain as well. So the frequency of Gaucher disease is 1 in 40 to 50,000 live birth, but in Ashkenazi Jewish, you know that it's higher. It's 1 in 850 birth. And up to now, up to date, they discovered above 400 mutation in GBA gene. And the most common mutation in 90% of Ashkenazi Jews and 50% of non-Ashkenazi are those 4 mutations. There is, of course, a genotype-phenotype correlation. The one before the last one is responsible for predict the Gaucher disease type 1. And the second one, which is positive in my patient, predict Gaucher disease type 2 and 3, or the neurological type. There is more mutation discovered, and it causes lethal type, perinatal lethal Gaucher disease, and also the heterozygous mutation in GPA gene is one of the most genetic risk factor for Parkinson's disease and dementia with Lewy bodies. So those are the 3 types of Gaucher disease. Type 1 is non-neuropathic, and the incidence, as I have mentioned before, it present at any age, and the lifespan is variable. There is no CNS involvement, but mainly there is visceromegaly, hematological abnormality, and skeletal abnormality, mild to severe. For the second type 2, it's a neuropathic type, but it's acute problem. It appears in infancy. It's less common than prevalent than type 1. It present in infancy. Usually they die. It is rapidly progressive, and they usually die by the end of the 2nd year. They have very severe CNS manifestation, visceromegaly, severe hematological abnormality, but thank God they don't have skeletal abnormalities. For type 3, it's the same like type 2, but it's more slow, chronic, slowly progressive disorder. And they usually present in the childhood, and the patient can survive up to 4 decades of his life. And all the manifestation range from mild to severe. And there is skeletal abnormalities as well. So in the clinical presentation in adult, there is general symptoms like fatigue, easy bruising, bleeding, menorrhagia, especially which is in female, decreased appetite, abdominal pain, and the most common problems they face is the hepatosplenomegaly. As you can see, splenomegaly 87% and hepatomegaly 79%, thrombocytopenia, anemia, and they have bad problems in their bone. They have bone pain, bone crisis, pathological fractures, collapse, joint collapse, osteonecrosis, osteopenia, all are due to bone marrow infiltration with toxic materials. And they are liable to develop Erlenmeyer flask deformities, and you can see it by radiological studies. What about the clinical presentation? Children, they have more aggressive disease. They have marked splenomegaly. This is the landmark for it in pediatric age group, easy bruising and bleeding, delayed puberty, and growth retardation. And the most common presentation is hepatosplenomegaly, massive splenomegaly actually, in 95% of patients, and 87% it's hepatomegaly, due to hepatomegaly. Thrombocytopenia is common in 50% of patients, but they have less bone problems. They have joint collapse later on, osteonecrosis, osteopenia, and they develop Erlenmeyer flask deformity maybe later in adulthood. That one is the perinatal lethal Gaucher disease, is a severe form. They consider it as one type of type 2 Gaucher disease. The presentation is usually with non-immune hydrops fetalis, with the shiny peeled skin. You can see the peeling here. And you can see the shiny skin, and there is joint problems too. The most common dermatological manifestation are colloidal skin, ichthyosis, desquamation, petechiae, and purpura. Dysmorphic feature as well is there, and the cardiomegaly with the small thorax and lung hypoplasia that lead to respiratory distress is common. Hepatosplenomegaly and pancytopenia, arthrogryposis due to bone deformity, joint deformity, and stiffness. Also neurological, progressive neurological deterioration like seizure and hypotenus, obocytonus is common, and those are the mutations that cause this kind of Gaucher disease. There is diagnostic algorithm in adult. Actually, I get this from a published paper in 2020 by Hazimi et al. About how to approach patient with Gaucher disease. You can go through it. It's in this journal of applied hematology. In pediatric age group, once we catch a patient who is suspected to have Gaucher disease, like with huge splenomegaly and hepatomegaly, with anemia and thrombocytopenia, we usually go immediately for enzyme assay, actually, because it's more rapid and it can give you the results within few days. After that, if it is confirmed that there is lack of acid beta glucosidase, we proceed for molecular testing, whole exome sequencing usually. We don't use panel nowadays for a lot of reasons, but this is now not the time for discussion about it. But whole exome sequencing, and when we confirm it by molecular testing, usually we always refer the patient and his family for genetic counseling, and the genetic counselor usually they do target mutation to screen for carriers, and this will catch the cases before they become symptomatic, and this will, it's good to start treatment even before they become symptomatic. The next step is to start the patient on treatment. We have two modalities, two treatment available, but we have two directions that treatment. One to support the patient and to treat his symptoms, and the other one is drug-specific treatment. So supportive measures for the patient would refer to subspecialties, including orthopedic, neurologist, ophthalmologist, and starting some medication to support his bone is very important. Disease-specific therapy, like which is enzyme replacement therapy mainly, and substrate reduction therapy. The enzyme replacement therapy, we have several kinds created by the recombinant DNA technology. We have amylglycerase, which we are using it now from Chinese hamster ovary cells. We have another type from human fibrosarcoma cells, and we have the genetically modified carrot cells. They use carrot cells and they produce they manufacture this enzyme replacement therapy. It's administered intravenously once every 2 weeks, and it shows a lot of improvement. It increased platelet count, hemoglobin concentration, and it reduced spleen and liver volume, as well as it improved skeletal manifestation, the manifestation like bone pain and crisis. Overall, it improved the quality of life, and generally it's well tolerated. The substrate reduction treatment work on the reverse reaction of the disease. When the beta-glucosidase is deficient, there will be accumulation of glycosyl ceramide. And there is a reverse reaction where it combines ceramide with glucose to form glucosyl ceramide. The substrate reduction therapy work on this stage, and it partially inhibit glycosyl ceramide synthetase, and reduce the substrate in the blood, reduce glycoceramide accumulation in the lysosome, as well as reduce the formation of Gaucher cells, and as a result, it will alleviate clinical manifestation of Gaucher disease. This is the regular assessment which the patient should go through, whether he started on enzyme replacement therapy or not. And you can see for those who started on enzyme replacement therapy, you have to monitor their blood tests every 3 months. But the rest, like the visceral enlargement and then the skeletal abnormalities, you can do it every 1 year. And if the patient achieves therapeutic goals, you can space it and you can do it every 2 years. So there is a lot of comorbidities and complication of Gaucher disease type 1 that may complicate treatment. They might develop neuropsychiatric disorders, mainly Parkinson's disease. They are able to develop different kinds of malignancies, metabolic disorders like insulin-resistant diabetes, cardiovascular problems, and immunological disorders, gastrointestinal disorders as well. So you have to be very careful, and you have to keep your eyes closely on the patient's clinical manifestation and refer him to the proper subspecialties. Break. I know no time for break. This is case. I finished case 1. This is case 2. Case 2 is one of my patients. She's a 3 years old Saudi girl, product of full-term normal spontaneous vertex delivery without complication. She was referred to from a Zulfi hospital with abdominal distension for 7 months due to enlarged liver and spleen. And she had mild motor delay, mainly walking, but she was able to sit without support, and she was able to speak. Since November last year, she started to have recurrent respiratory difficulty because of pneumonia, worsening cough and sputum, and oxygen desaturation reached down to 73%, and it progressed, her pulmonary situation, until she became oxygen dependent. Now she is at home with oxygen through nasal cannula. Regarding her family history, the parents are first cousins, have one older healthy sibling, no similar case in the family, and the patient was referred to me because she has dysmorphic features and abdominal distension with hepatosplenomegaly to rule out metabolic disorders. On examination, she looks unwell, not distressed, but she was on oxygen through nasal cannula. She has her weight was below 5th centile, but her height was okay. She was dysmorphic. Mainly, she has coarsening of facial features. I couldn't bring her photo because the parents did not agree, so I brought similar case from online. And you can see the abdomen, how it is distended. She looks like it exactly, like this picture, photo. The chest was okay, but there was transmitted sound. Cardiovascular system was unremarkable, and the abdomen was so distended with hepatosplenomegaly and severe the splenomegaly. The span was 12.5 centimeters by ultrasound. And CNS examination, only she had mild hypotonia but normal reflexes. Investigation, CBC was okay apart from leukocytosis because at the time of admission she had pneumonia. And she had elevated liver enzymes as well. Skeletal survey showed J-shaped sella turcica. It showed also severe narrowing of the nasopharyngeal airway because of tonsillar adenoid enlargement. And she showed the typical finding of Erlenmeyer-Flask deformity, which appear because of metaphyseal expansion in the lower part, or in the distal part of the femur. And you can see it in adults too. Chest X-ray showed bilateral diffuse interstitial obesity, suggestive of interstitial lung disease. Abdominal ultrasound showed hepatosplenomegaly with enlarged liver and splenomegaly of 12.5 centimeters. We proceed with whole exome sequencing, and the result was showing homozygous pathogenic variants in BD1 gene. That confirmed the diagnosis of autosomal recessive Niemann-Pick type AB disease. The concentration of the biomarkers was so high too because the patient was not treated yet. So Niemann-Pick disease, it is an old name. It's well known that there is a disease called Niemann-Pick disease. But now they replace it with another name, which is acid sphingomyelinase deficiency, or ASMD, and I will tell you why. It's a group of rare autosomal recessive lysosomal storage disorder associated with splenomegaly, variable neurological deficit, and storage of lipid, including sphingomyelin and cholesterol. And it was first described by Albert Niemann. It's a German pediatrician. It was in 1914. Later on, a histopathologist called Pick, he emphasized more on the histopathological part, and that's why they named the disease as Niemann-Pick disease. And the gene responsible for this disease is the SMPD1 gene, which localized on the short arm of chromosome 11. So, when they describe Niemann-Pick, they include, there is Niemann-Pick C, but they found that it is due to a problem in the cholesterol transportation inside the cells, so they exclude it, and they concentrate on A and B, and they call it ASMD. So, sphingomyelin, in this situation, if there is problem in the sphingomyelinase enzyme, it will lead to accumulation of sphingomyelin, and it will accumulate mainly in very vital organs like spleen, liver, brain, and lung. And this will damage the tissue and cause all manifestations of Niemann-Pick disease. Also, the ceramide will reduce ceramide. The ceramide is very important in inflammation and apoptosis. It functions as signaling molecule in other cellular processes like autophagy, cell cycle arrest, and differentiation. There are three types, actually two types, A and B, but there is intermediate type. They call it, it's an overlap between the clinical finding of A and B, so A and B, and B. The A is a rapid progressive disorder with neurological manifestation, and the onset is early in early infancy. The life expectancy is short. The main cause of this is respiratory failure and multisystemic failure. For type 2 is AB, it's intermediate, and it characterized with multi-organ involvement. The onset is a little late, life expectancy is variable, and the leading cause of this is respiratory distress, liver disease, or as a liver transplant complication, and neurodegenerative disorder. For type B, which is the most prevalent type, it's a chronic one, and there is no neurological involvement in this type. The onset is late in infancy and adulthood, and the patient can survive up to the 2nd or 7th decade of life. And the usual cause of this is respiratory distress, liver disease, bleeding, and remember, there is no neurological involvement in this type. There is genotype-phenotype correlation. I will not go through this slide. Maybe it needs more time to emphasize it, but type B has specific genes related to it, and type A as well. The current management for Niemann-Pick disease is symptomatic treatment, also lifestyle change. Multidisciplinary team care is very important. Most of the patients, they needed albuterol for difficult breathing, need extra immunization like flu vaccine and pneumococcal vaccine. For their lung problems, statin, which to control their high cholesterol, and they have to change their lifestyle style. They have to be away from contact sports because of the high risk of spleen rupture. They have to control their diet to manage the GI upset and reduce the activity because they have easy fatigability. There is a treatment coming in the way, but we are waiting for the approval by the Saudi FDA. It's an enzyme replacement therapy. Inshallah, it will be soon with us in the market. So, in conclusion, massive hepatosplenomegaly may indicate a storage disorder rather than malignancy, even in adult age group. Early diagnosis and medical intervention of the storage disease result in better outcome. and referring the family of an index case for genetic counseling and prenatal testing facilitate early diagnosis to prevent recurrence of the disease in the family. Thank you.
Thank you very much. Great. So one or two questions. What's about an allogeneic bone marrow transplant? If you'll take it from the, cost-wise, enzyme therapy for a long time, and it's very expensive compared with the once transplant.
Thank you. It's a very good question, actually. Nowadays, for lysosomal storage disease, bone marrow transplantation is benefit mucopolysaccharidosis type 1. And we are doing bone marrow transplantation, especially before 2 years of age, and if the patient has no much CNS involvement. But for the Gaucher disease and the Niemann-Pick disease, still enzyme replacement therapy is the best. And bone marrow trial was not so successful in it.
Thank you. Any more questions? So, thank you very much.
Thank you.
This session. The next or subsequent, the fourth session will start at 3:30, so we'll have 14 minutes. We'll have a group photo outside. They will guide us where to take it. So please be there.
Exciting session of the day, and I'm very happy that only the enthusiast has just remained in the session. It is actually my pleasure to welcome you today to talk about challenges in the management of myeloma. So our first session will be presented by our Dr. Joshua Richter, who is an associate professor of medicine at the Tisch Cancer Institute. He's actually a well-known myeloma enthusiast, and he's been instrumental in the treatment of myeloma, mainly in the landscape of bispecifics. Today he will be talking about challenges and opportunities in the treatment of myeloma, especially the role of isatuximab. So Dr. Rector, the mic is yours.
Thank you so much for that extremely kind introduction, and thank you so much to the organizers of this Congress. It's an honor to speak at SS BMT. So yes, my deep passion is treating multiple myeloma, and today I'm going to discuss challenges and opportunities for relapsed multiple myeloma and the role of isatuximab. So this is the current approval landscape, and again, obviously approvals differ from country to country. This is our current approval status in the United States, and many of these drugs are approved in various combinations and settings throughout the world. And essentially, we think of approaches in myeloma from a standpoint of classes. We have immunomodulatory drugs, proteasome inhibitors, standard chemotherapy, steroids, the original therapeutics for myeloma, antibodies, selective inhibitors of nuclear export, and now we've embraced the T-cell redirection era of CAR T-cell therapy and bispecific antibodies. But really what has transformed the way that we deal with both newly diagnosed and now relapsed and refractory disease has been the incorporation of the anti-CD38 antibodies into the relapsed refractory myeloma landscape. And mostly because these are ubiquitously utilizable. If you think about the lymphoma world, almost every regimen comes with Rituxan for a B-cell lymphoma, and this is many ways how we approach myeloma, that the addition of a CD38 antibody into the relapsed refractory setting brings with it high levels of efficacy and relatively low levels of toxicity. And although, yes, we're all quite excited about the role of T-cell redirection therapy, these therapies are not available everywhere. They're not applicable everywhere, but CD38 antibodies are. And this is the recent data that has been presented regarding the large randomized controlled trials, both with daratumumab, as seen in the Apollo and Candor studies, and isatuximab seen here with the Icaria and Ikema studies. And really what I want to note here is the median progression-free survival. And although, of course, we cannot compare trial to trial, probably the most high-level progression-free survival in the relapse setting, specifically in the lenalidomide refractory group, has been seen in the Ikema trial. And we recognize that CD38 antibodies plus IMiDs are wonderful, but perhaps even better is the CD38 plus Kyprolis. So when we talk about selecting therapies in myeloma, we are not as advanced as our AML lymphoma colleagues who have targeted agents that really you find a mutation and you target it. In myeloma, we use broad categories to discuss what therapy might or not be optimal for a patient, including patient-related factors, disease-related and treatment-related factors. Is the patient old or young, fit or frail? Is the disease growing fast or slow? What therapies have they had before? But really what I want to focus on for the purpose of this talk are three areas that are kind of the worst players of myeloma. And we embrace the fact that with so many therapies, we've had amazing advances, but there's a couple areas we're not doing as well. One is extramedullary disease. And we recognize that despite our best efforts, EMD is not well overcome in the setting of myeloma, especially in the relapse setting. Genomically high-risk disease, and things like 17p, and most notably, the recent publication of the second revision of the revised ISS, the R2 ISS, which now includes 1Q gain as part of the paradigm of high-risk disease. These are poor outcome patients, and refractory patients, patients who are refractory to IMiDs, specifically lenalidomide. We date back to the original data from Shaji Kumar published in Leukemia that once you're refractory to one or more of these drugs, your outcomes become worse. So when we talk about high-risk myeloma, I put this slide up not for the granularity of it, but to show that there are innumerable ways that we define high risk. And we can define this from a genomic standpoint. We can define this from an extramedullary standpoint. We can define this from a functional standpoint. If a given regimen in the trial had a 30-month PFS and you progress after 6 months, you are functionally high risk. And of course, our myeloma colleagues at the Mayo Clinic maintain the M-SMART guidelines, which help to guide us. But really where I want to start is cytogenetic high risk, because I think this is some of the most tangible, and all patients with myeloma should be getting bone marrow. It's definitely a diagnosis, and potentially as we go through relapse settings, because we can acquire mutations, and 1Q is one of the most common to be acquired. Now we talk about 1Q amplification and 1Q gain, and just to make sure we have the stage set, 2 copies of 1Q are normal. 3 copies is called a gain, and that's bad. But the more copies you have, the worse. And if you have 4 or more copies of 1Q, we call that 1Q amplification. And here we see some data published by Tom Martin relating back to the Icaria study comparing Isa-Pomdex versus Pomdex. And when we evaluate patients with this cytogenomically high risk 1Q gain and 1Q amplification, we see that pound for pound in every category, both in terms of overall response rate and achievement of VGPR or better, the triplet including ISA outperforms the doublet of Pomdex, and we see relatively high response rates and deep response rates regardless of the 1Q impact. When we translate this out not just to the depth of response, but to the survival outcomes in Icaria, we can see the progression-free survival and overall survival curves here of Isa-Pomdex versus Pomdex. And again, if we look carefully, up to 30 or 40 or more % of myeloma patients will have a 1Q gain. So it's very important to note this, especially in the relapse setting. When we talk about PFS, the doublet gives us under 4 months. However, the ISA triplet gives us over 9 months, around 9.5. In terms of overall survival, we go from 13.9 to 21.3. So again, approaching a patient with high-risk disease, incorporating a CD38 antibody like isatuximab is crucial. What about when we switch over to the IKEMA data? So this is Isa-Kyprolis dex. And we see here that although the Kyprolis dex backbone is probably better than the Pomdex backbone in terms of disease control. And we see here the PFS of KD alone is 16.2 months, but ISA-KD is not reached. And really, when we think about first relapse or early relapse in myeloma, where we're not going to go the direction of a T-cell redirection therapy, the highest risk disease we really need to approach with CD38 plus Kyprolis, either Dara-Kyprolis or Isa-Kyprolis. And again, so far to date, the IKEMA data really shows the best outcomes in these patients. When we look at a forest plot across the different studies, and this is Icaria and IKEMA, which represents the 2 current FDA approvals for isatuximab in the US, we can see across patients with standard risk, high risk, isolated 1Q, 1Q gain, 1Q amp, that across the board we see improvements in outcomes with the ISA triplets. Now, we will note down at the IKEMA study for amplification 1Q, the confidence interval does cross the hazard ratio of 1, but know that this is a very wide confidence interval, and still the trend is clearly towards improvement with the triplet over the doublet. Now, what happens when we move beyond lenalidomide and we enter the realm of lenalidomide refractory patients? Now, we recognize that although newly diagnosed approvals will differ greatly from country to country, in the US, probably 80 to 90% or more of patients will receive lenalidomide in the upfront setting. And if we look across a variety of other countries, mostly in Europe, we see that the majority of patients either receive it in first line or second line. And given the current paradigm of treatment until progression or intolerability in myeloma, we note that many patients will be entering early relapse already lenalidomide refractory, and that develops a different type of disease than we had seen in the past. So as our disease control gets better and better, the disease that survives and we select out becomes more and more resistant and more deadly. And we see here in terms of all the outcomes in terms of disease burden, hypercalcemia, renal insufficiency, all the bad systemic problems of myeloma, are higher when you're lenalidomide refractory and not just relapsing after it. In terms of progression-free survival in the second line, if you are refractory to it as opposed to just relapsing from it, meaning you're progressing on within 60 days, your progression-free survival drops from almost 20 months down to 7.5. So this is a worse group overall. So let's go through some of the isatuximab data for this group. And Akari is the combination of ISA-POMDEX. And when we look at patients who are len refractory, we almost double our overall survival going from POMDEX to ISA-POM from around 31 to 59% overall response rate. We have about a third of patients achieving a VGPR or better in the ISA-POMDEX triplet. We see similar outcomes to patients who are not len refractory but had lenalidomide in their last line. And again, on the right, looking at the forest plot, whether or not you're len refractory, PI refractory, len and PI refractory, the so-called dual refractory patients, we still do better overall when we combine ISA-POMDEX. So I think in a world where the average myeloma patient is 70 years or older with multiple medical comorbidities, we tend to want to approach that with low-level treatment to not overburden them, and doublets have been a standard for many years. I think we are now staunching the area where we're not adding a classical chemo drug, we're adding an antibody-based drug, and I would say that I have never encountered a patient that you could not add a CD38 antibody to regardless of age, so I think it's very important to pretty much always give triplets. Now, we recognize that clinical trials are highly controlled, but what happens when we look at these outcomes in a real-world setting? And that's what the IMAGE study did, is really trying to match pound for pound or note for note what the outcomes were on Akaria and to see if this is what we're truly seeing in real-world practice. And we can see here when we look across patients who are len non-refractory, len refractory, or len as refractory as the last line of therapy, we're seeing similar outcomes both from the Akaria trial and when we transport this into a real-world setting. With len non-refractory patients having a better progression-free survival, almost 20 months. But when we look at the len refractory group, we're looking around 9 to 11 months across the board, both in the clinical trial and the real-world setting. Now, we always want to evaluate what things look like at different lines of therapy, recognizing that any time you push a regimen earlier in lines of therapy in myeloma, you get better outcomes. The patient is less refractory, they're exposed to fewer drugs. But again, comparing real world to trial data, we see them match up very closely in terms of patients who receive something like ISA-POM in the first relapse. They have extremely extended progression-free survivals, and in these studies not yet reached. In the second line and third line, we see this decline from around 10 months in the second line to 3 to 5 months in the third line plus. Now, transitioning over to the IKEMA data, IKEMA is really where we see one of the more aggressive regimens or more potent regimens for heavily refractory patients. And here we can see for len refractory, when we combine ISA and Kyprolis, the forest plot pretty much always either trends towards improvement or completely with statistical significance shows improvement over the KD doublet. Remember that the KD doublet already has better efficacy against refractory than pomalidomide. Pomalidomide is the same in class, so when you are refractory to Revlimid, that imparts some degree of refractoriness to pomalidomide. Kyprolis, you're class switching, so you'll get a better response overall, but you'll get an even better response when you add ISA to it. And if we look across the board of depth of response, we see higher rates of overall response rate, VGPR better, CR better, including the MRD negative patients. And the MRD negative patients are really those who are going to have unbelievably long remissions. So where are we at in the IMiD sparing regimen? So if you're progressing on lenalidomide and you're going into your first relapse, second or third, we want to sometimes look for a non-IMiD containing regimen, class switching, to allow us to have better cell kill. And this is a culmination of the recent phase 3 trials, ranging from Optimism, Boston, Castor, Endeavor, Bellini, Candor, and IKEMA. And although all the ones on the left with the VD backbone will show us modest progression-free survivals with triplets ranging from 11 to 23 months, where we see the biggest and best outcomes to date is really when you're combining a CD38 with Kyprolis And so far we have two of those regimens, darakyprolis in Candor, isakyprolis in Ikema, and here again, difficult to compare trial to trial, but we see the DKD backbone giving us around a 29-month progression-free survival, with ISA-KD getting us up to 36. So ultimately, in the len refractory group of patients, if you want to offer patients the best therapy to date without having to go aggressive like a bispecific or T-cell engager, or not having the opportunity or access to those, or patients are otherwise not eligible for a variety of reasons, we tend to go with CD38 based therapy. And here we've shown that Ikema and Icaria across the earlier relapses in len refractory show some of the best data that can be very well maintained. Now, this is also included in some of our guidelines. So here I show some of the current guidelines that are recommended for the treatment of relapsed and refractory disease. So we have EHA-ESMO's guidelines, the NCCN guidelines, as well as the International Myeloma Working Group guidelines. And we can see that across the board, we have recommendations for the two different ISA triplets, including ISA-KD and ISA-POMDEX. Again, I think ultimately ISA-POMDEX is a little bit of a gentler approach, and it's nice because then you're simply getting the CD38 with an oral therapy, and it allows you to go every other week with your treatment, that's the parenteral treatment with isatuximab. However, for more aggressive relapses, ISA-KD is a better regimen. It's more aggressive. It is well tolerated, but it will control disease in a better fashion. So really, one of the biggest areas of difficulty in myeloma has been how to manage extramedullary disease. And we recognize that in a day and age where our current therapies are able to kill so much of the myeloma, the disease that survives is able to survive outside of the bone marrow niche. Plasma cells need that bone marrow niche to survive, but you can select out such an evil group that you don't just have extramedullary disease, you can have bone-related plasmacytomas. And really the way I think about that is inside the bone, 60, 70, 80, 90%, 100%, the tumor breaks out. And now you have a plasmacytoma that's bone-related. But you can even have soft tissue plasmacytomas. And these are myeloma cells that are so de-differentiated or so evil and are so different from their native plasma cell that they can survive outside of the bone marrow niche. And I describe this as thinking of a tree. You know, we see a tree that needs to be planted in good soil, but if you saw a tree walking down the street that didn't need to be in a pot of soil, I don't know about you, I would be quite scared, and that's what I think about from soft tissue plasmacytomas. We recognize that we're seeing this in higher and higher rates. Now, part of this is our disease, our patients are living longer, we're able to select out more difficult disease, but we're also in a day and age now where imaging is a lot more available than it was 20 and 30 years ago, with current estimates between 3 and 14% of patients in the relapse setting having extramedullary disease. Now, once these plasma cells can survive outside the bone marrow niche, they can go virtually anywhere. And here's a listing of some of the more common sites. And again, they can be seen at the diagnosis, they can be seen in the relapse, bone-based, not bone-based, but we can see them in a variety of places, including in the CNS. And I actually got a call about a patient last night who has a soft tissue plasmacytoma in the brain. So unfortunately, anywhere that blood or plasma cells can go, so can malignant ones. Now, it turns out that myeloma in general, we've gone better and better. When you have bone-related plasmacytomas, you do worse. When you have soft tissue, purely soft tissue plasmacytomas, even worse. And we can see here, OS in this data set goes from around 44 and 45 months for even the bone-related plasmacytomas down to 20 months for soft tissue. And from first relapse, we see this really drop down to 13 months. So how do we approach these patients is really a major issue. And there are certain risk factors for the development of secondary EMD, age of diagnosis. We recognize that high-risk disease in all forms, be it cytogenomic or extramedullary, tends to decrease with age. So our patients over the age of 75, less likely to have EMD, less likely to have high-risk cytogenetic features, but our younger and younger patients have them. High LDH is associated with EMD. The presence of diffuse osteolytic bone lesions really giving us a fact that the plasma cells are really starting to spread out and be more aggressive. So these are some of the major risk factors that we see for EMD. And we've actually evaluated this both in the ACARIA and the IKEMA studies. So again, these are small numbers of patients, but it's important to note the significant difference. So here in ACARIA, we saw ESA-POMDEX and POMDEX, 14 patients with soft tissue plasmacytomas, 10 in the POMDEX. In terms of the response rate, we're seeing half the patients in ESA-POMDEX responded, 10%, only 1 in 10 responded for POMDEX. In terms of their progression-free survival at 12 months, 31% in the ESA-POM versus 0% in the POMDEX. So ultimately, we are definitely noting that if you have a patient with a soft tissue plasmacytoma, you need to enhance the doublet back to a triplet and give something like ESA-POM. When we look at across the board, ESA-POM and ESA-Kyprolis without plasmacytomas with, and the doublets with or without, we can see that if you are on any of the triplets, your outcomes are pretty good. And if you're on a doublet without plasmacytomas, you're still kind of in the running. But if you were on a doublet with plasmacytomas, that is that purple line at the bottom, those are the patients that absolutely do the worst. And really where this comes into it is, I think that we are, because myeloma is a disease of blood, we are very set on just following M spikes and light chains. But patients, even in disease control, need regular imaging to help inform disease and to rule out areas of progression. When it comes to overall survival, same cohort. This is the ESA-POM triplets with and without plasmacytomas, and you look at POMDEX without plasmacytomas, those 3 line survival curves are almost overlapping. If you're giving a POMDEX doublet in someone with plasmacytomas, the overall survival is dismal. So very important to incorporate the CD38 antibody. When we look into the IKEMA cohort, again, relatively small numbers between ESA-KD and KD, but we see 12 patients with plasmacytomas in ESA-KD, 7 with KD. In terms of overall response rate, again, 50% with ESA-KD, 28% in the KD arm. In terms of progression-free survival, definitely better in the ESA-KD group. The high rate of MRD negativity, and overall a much better regimen to attack this. So if you have a patient who is progressing, really consider obtaining imaging to help stratify, because we do recognize that doing bone marrows to re-stratify cytogenomically are more invasive and the patients don't always want it, but obtaining imaging is a non-invasive way to further stratify. Is your patient likely to do well, likely to do worse? How much do we need to advance to a triplet or even in some cases quadruplet? When we look at the impact, again, this is I think a repeated one, I apologize, but again, POMDEX with plasmacytomas do generally worse. So coming really to the aggregated data, if we look at the pooled data from IKEMA and ACARIA, so this is all the triplets versus all the doublets, we see the overall response rate 50% with the triplets, 17.7% with one of the doublets. VGPR rates are more than doubled. CR rates are 0 in the doublets, 11%, again, small numbers, but those patients, the deeper response you get correlates to the durability of that response. So really in conclusions, myeloma patients in general, through the advent of modern therapies, have had unbelievable outcomes in survival, both progression-free and overall. However, despite these amazing advances across the last 10 to 20 years, there's still a select group of patients who have worse outcome. Cytogenetically high-risk patients. IMiD refractory, so being refractory to REV or POM, and extramedullary disease. And we recognize that there are a variety of approaches, but we so far have had some great data to show that isatuximab-based triplets seem to overcome some of these adverse events on maybe a mainstay of how we can approach these patients, especially in the early relapse. And with that, I'd like to thank SS BMT for allowing me to speak. Please find my email and Twitter handle if I can ever be of any help. And thank you to Sanofi for supporting this. And I will take any questions.
Thank you very much. And Josh, as usual, you give elegant presentations.
Thank you, sir.
I don't know about you, but if I see a tree walking up the street, I'll actually freak out. Okay, so since this is actually a virtual presentation, we'll take questions now. For any questions for Dr. Richter?
Thank you, Doctor. Now, with the using of anti-CD38 earlier up front, how much this will make a challenge of treating relapse refractory multiple myeloma?
So I think this is actually a brilliant question, and so this is so myeloma is now mimicking what was argued a generation ago in the lymphoma world, which is if you give Rituxan up front, you need to give Rituxan in maintenance and all of this. So I think there's two settings in terms of CD38s being used up front in the relapse. One is many patients, so transplant eligible patients, are getting quadruplets like Dara-VRd up front, transplanted and Rev maintenance, and are not CD38 refractory. And therefore, if you progress on Rev, you can then go back to CD38. So I think for those patients, we clearly go back. But I think the point that you're talking about, which is even more potent, is those who get something like Dara-Len-Dex up front and progress on a CD38. And the question is that it? Can we never use it again? And the answer is no, we can. So we know that it takes about 4 to 6 months to re-express CD38 on the plasma cells. So if somebody gets Dara-Len-Dex up front and then gets a pomalidomide regimen in the second line, in the third or fourth line, you can come back with isatuximab because you've now re-expressed CD38.
And would you check for that CD38 on a bone marrow?
It's a great question. I don't routinely check for it. You absolutely can, but we know that almost universally after, certainly it starts to recuperate at 4 months, but definitely at the 6-month mark, essentially everybody re-expresses CD38.
Okay, so can I use this satellite symposium to ask an off-topic but still a myeloma question?
Sure.
I've always looked at the revolutionary change in myeloma, especially in the area of bispecifics and CAR-T, to be something that will probably improve the survival of patients. But I was just reviewing the EHA abstracts, this year, and I've noticed that the Mayo group has actually published their CAR-T experience mainly in myeloma, and they did about 300 patients. Ultimately at 3 years, 9% developed therapy-related myeloid neoplasms. Do you have any thoughts about this? Especially now we're talking about, CAR-T, teclistamab, talquetamab, rituximab, cifustamab. Are we really driving those patients to a survivable quality of life, or not really?
So I think your point about myeloid neoplasms is one that is a really important topic, because we recognize that at the end of the road, redirection therapy is better than standard therapy. But right now, there are a number of trials trying to compare transplant versus T-cell redirection. And I think everyone was initially, transplant causes second myeloid malignancies. CAR-Ts and T-cell redirection can clearly do the same. I think one of the things that we're starting to really only scratch the surface of is the understanding of the role of chip mutations in myeloma. So things like TET2, TNMT3A, ASXL1, even going as far as even 17P and JAK2. And it may be that if we really stratify, I believe it's probably going to be those patients with underlying chip that end up developing subsequent myeloid neoplasms, because there's some innate immunity holding those chip myeloid cells under control. And once we immune suppress and redirect the T cells, that's allowed to flourish and become a myeloid neoplasm. Again, that's what I believe. I don't know that that's really proven at this point. So I think it's really, we've had this huge advance in therapeutics. The next advance that we must now do is catch up and figure out which patients will ultimately benefit from which therapies, and for which patients are these going to lead to long-term toxicities.
Thank you very much. And with this, I'd like to thank Dr. Richter, and we'll see you at EHA. Thank you very much.
Thank you.
Okay, so our next speaker is actually a very close friend of mine and a well-known myeloid physician, I would say. Dr. Ahmed Al-Ataibi is a consultant hematologist at King Faisal Student Hospital. Ahmed and I first met in Toronto. I wouldn't say when, but several years ago when he was doing his myeloma training at the Princess Margaret, and then he went down south to MD Anderson to do his leukemia training. And today he's going to talk to us about management of relapse refractory FLT3 mutated AML, and this is a satellite symposium sponsored by Astellas. Ahmed, the floor is yours.
Yeah, thank you very much, Dr. Ghazi. I mean, shifting from myeloma to AML, and I hope one time in AML we'll have this option of treatment like in myeloma. So thank you again, Ghazi. Thank you, Dr. Ahmed. Thank you for SS BMT, Dr. Asker, for this nice conference, and thank you for Astella. Okay, so we'll speak today about relapse refractory FLT3 mutated AML. So we all know that the field of AML has been significantly improved over the last years. I mean, our understanding of AML has been significantly improved, and this is due to the advances in molecular study and mutational analysis. We now have better classification of AML, and this is clearly translated on the new WHO. We are moving now from the morphological based to more molecular based diagnosis. And even the paradigm is shift in AML treatment from intensive chemo, transplant to more of targeted therapy. And over the last couple of years, a couple of targeted therapy has been approved for AML, and more now under work in preclinical and clinical. So we hope more option will come for AML. So we know AML is a heterogeneous disease, and a couple of mutations has been identified, and we know that FLT3 mutation is one of the common mutation. It's around 37% of AML will have FLT3 mutation. And we know that AML is a tyrosine kinase receptors, and like other tyrosine kinase receptor, we have the extracellular and the intramembrane and the intracellular kinase domain. And we have commonly two types of mutation in FLT3. The FLT3 internal tandem duplication, which usually on the juxtamembrane site or juxtamembrane domain. We have also the FLT3 tyrosine kinase point mutation. It's on the tyrosine kinase domain. The FLT3 ITD is account for almost 30%, and it's clear negative prognostic marker for AML. FLT3 TKD around 7 to 10%, and it's actually controversial about the prognostic factor, but the good thing that we have targeted treatment now even for FLT3 TKD. So all of us, we know that FLT3 ITD negatively impact the outcome of acute myeloid leukemia, and this has been clear before the targeted therapy for FLT3. This is one of the earlier study for FLT3 ITD mutated AML. It's around 2002, and this is on the intensive chemotherapy era without targeted therapy, and you can see clearly that FLT3 mutated AML, they had shorter duration of remission compared to FLT3 wild type AML, and this is translated for shorter overall survival for FLT3 mutated AML compared to wild type, and this is before the targeted therapy during the intensive chemotherapy era. So we all know that FLT3 ITD negatively impact the outcome of AML by mainly increasing the relapse, shorter disease-free survival, and definitely shorter overall survival. We all aware about the new ALN classification 2022. We used before to debate a lot when we have patients with NPM1 mutated and low allelic ratio FLT3, shall we transplant them, not to transplant them? It was a common debate, and most of us were advocating to transplant them, especially we don't have a good MRD marker to follow. And now with the new European Leukemia Net classification, all FLT3 now is intermediate risk, so no more favorable risk for FLT3. So now we should advocate more any FLT3 mutated AML. If you can transplant them upfront, they should proceed for transplant. There are several changes in the ALN criteria. I will not go through them. So we clearly know that FLT3 mutation negatively affect the newly diagnosed AML. So how about FLT3 mutation in relapse refractory AML? Can you fix it? just يعطيك العافية.
الله يعافيك بس خليني بس اوقف هذا.
خلاص Yeah, so we said that the FLT3 ITD is clearly negatively impact the So we know that all relapse refractory AML they do poor, but even though the FLT3 positive AML and relapse they do even more negative impact than the FLT3 wild type on relapse, and this is two cohort study with the FLT3 mutated AML upon relapse, and you can see the overall survival is very poor, less than 10% for relapse FLT3 if relapse AML if they have FLT3 positive. And here is a very important point. So we know that AML is heterogeneous disease and it's also a dynamic disease. So the mutation can change with AML, and we know that FLT3 is a late mutation and it's unstable mutation. It can evolve with relapse and sometimes disappear with relapse. So here an example, one retrospective study, patient with FLT3 negative AML, there are around 260 patients. Upon relapse, 10% of them relapse with acquired FLT3 ITD mutation. The other way around, 60 patients with FLT3 ITD mutation alone, prior to therapy, they relapsed without FLT3 mutation. And this is very nice work by Dr. Takahashi from MD Anderson when they did a single cell analysis, and you can see how the clone changed with time with treatment. Example, this patient had NPM1 mutation. Upon diagnosis, the main clone was FLT3 ITD, treated with sorafenib A achieved remission, then when relapse, and you can see that initially he had very small clone of FLT3 TKD, and upon relapse, the FLT3 ITD disappeared, and the main clone with relapse is FLT3 TKD. And it makes sense because sorafenib will not affect FLT3 TKD. So the main message here that when you have relapsed AML, you have to test for mutation, especially FLT3 and other mutation that you have targeted therapy for them. How about FLT3 inhibitors? There is a couple of FLT3 inhibitors on the pipeline. So we have the first generation, second generations. The first generation sorafenib, it's the old FLT3, old tyrosine kinase inhibitors, some of them meant for other malignancy. So they inhibit a wide range of tyrosine kinase, so you will have a wide side effect, off-target side effect, sorafenib, midostaurin. The second generation, it's more selective, more potent, and less off-target side effect, like quizartinib, crinolinib, and gilteritinib. And the other classification for FLT3 inhibitor, we divide them based on the functions. We have FLT3 type 1 and type 2. Type 1 affect the FLT3 inhibitor in the active and inactive conformation. So it's work in FLT3 ITD and FLT3 TKD. Example, the gilteritinib and midostaurin. Type 2 inhibitors is mainly work on inactive, and it's mainly work for ITD, not TKD. And example is sorafenib and quizartinib. And here example of couple of clinical trials that on FLT3 inhibitors. We all aware about ratified trials, which led for approval of midostaurin in upfront fit patient in combination with intensive chemotherapy, and there was clear survival benefit. We know the Admiral trial, we will explain it in more detail and shortly, and led to approval of gilteritinib for relapse refractory FLT3 positive AML. Quantum R was looking for quizartinib versus intensive chemotherapy for relapse refractory FLT3 ITD. There was survival benefit, but for some reason did not lead to approval. FDA, it's approved in Japan. I should have added the Quantum first trials that now show a benefit of quizartinib plus with 3+7, and we think it will lead for approval of quizartinib in upfront AML patient. So let's focus on relapse refractory FLT3 mutated AML, and the only approved targeted therapy in this situation is gilteritinib. As we said, gilteritinib is highly selective oral FLT3 inhibitor, active on both FLT3 ITD and FLT3 TKD. Gilteritinib is a type 1 FLT3 inhibitor. It's bind to ATP site, so it's highly selective for FLT3. That means less off-target mutation, and we all know that in the gilteritinib is approved for relapse refractory AML, and it is category 1 in NCCN guideline. And this approval is based on the Admiral trial. It is a phase 3 randomized trial that compared gilteritinib to standard of care for relapse refractory FLT3 ITD and TKD AML patient. And patient was randomized 2-to-1 to either gilteritinib 120 milligram, and patient will continue daily until intolerance or progression, and salvage therapy, either intensive chemotherapy 1 or 2 cycles, or low intensive chemotherapy until progression or intolerance. Both group allowed to proceed for stem cell transplant based on investigator choice, and gilteritinib group allowed to resume gilteritinib after relapse, and importantly there was no crossover offered on these trials. This is also explanation of the choice of low-intensive chemotherapy was low-dose cytarabine or azacitidine. The high-intensive chemo was MIC or FLAG-IDA. This is the patient characteristic, and you can see it's almost equal between the two groups. The median age was around 60 in both groups. The cytogenetics was equal. The unfavorable risk was 10% in the gilteritinib, 11% or 8% on the intensive chemo. We need to know the FLT3 inhibitors in both. The briefest exposure to FLT3 inhibitor in both groups was 13% in the gilteritinib group, 11% on the intensive chemo or on standard regimen. So here is the main outcome for the study, the overall survival benefits of gilteritinib compared to standard regimen, which intensive chemo or low intensity chemotherapy. And we can see clearly that patients with gilteritinib had better survival compared to salvage chemotherapy. The median was 9.3 months compared to 5.6 months on salvage chemotherapy. 1 year overall survival was 37% compared to 17%. And when they did the long-term follow-up after 2 years from the study, the overall benefit of gilteritinib continued, and the median 9.3 compared to 5.6. Two important points here that we need to know that more patients on gilteritinib group went for or underwent stem cell transplant compared to salvage group. 25% on gilteritinib group compared to 15%, around 10% difference. And this has raised the question, is this survival benefit in gilteritinib group is due to more stem cell transplant or because of the disease itself? We'll come to how to answer this question. The other point here that 60% of patients resumed gilteritinib post-transplant. So the question comes, is there any difference between patients who resumed gilteritinib post-transplant compared to patients did not resume? But this was not planned. So this will be post-hoc analysis. We'll come to it. So to answer the question, is there any effect of stem cell transplant on the outcome? We know that transplant was more in the gilteritinib group compared to stand or salvage chemotherapy group. But when they did censoring at stem cell transplant time, and that means they will not capture the outcome after transplant, the overall survival is still clearly better with gilteritinib group compared to salvage chemotherapy group when they censored the patient at transplant time. The median was around 8 months compared to 5 months. This is a post-hoc analysis. It's not planned analysis. We'll not take it by guarantee, but it just gives us a hint about the possibility of benefit of gilteritinib post-transplant. And we all now know the press release of the Morpho trial. Maybe there is no benefit of gilteritinib in maintenance. But on this post-hoc analysis, there was clear benefit of patients who resumed gilteritinib post-transplant compared to patients who did not resume it post-transplant, 16 months compared to 8.4 months. This is again a post-hoc analysis. This is to look for the co-primary endpoint, the CR, CRH, and it's clearly better on the gilteritinib group compared to salvage group, 34% compared to 15%. But you need to keep in mind the gilteritinib continued and the intensive chemo is 1 or 2 months only. The side effect, when we look to the first 30 days, it's almost comparable between the two groups. The cytopenia is almost same. Maybe there's more neutropenia on the chemotherapy group, but the more transaminase on the gilteritinib group compared to salvage chemotherapy group. So I'll take you shortly about to see two cases from our clinic. One of them I just saw here last week. So this is the first case. 23-year-old lady presented in outside hospital with flu-like symptom, sore throat, non-specific symptom. They found that she had a leukocytosis. Initial workup suggested of AML, so they referred her to us. When she came to us in King Faisal, this is her initial lab, white blood cell around 20. She had 29% circulating blast, thrombocytopenia. Bone marrow biopsy, hypercellular marrow, 55% blast, flow, going with myeloid neoplasm. Her cytogenetic was translocation 6-9, so she's high-risk disease. NPM1 FLT3 ITD was negative initially. At that time, we did not have the NGS result for her, so we treated her as FLT3 ITD negative. AML high risk, so she underwent 7+3, our standard induction. She achieved CR. We had a match sibling for her, so she went directly after 7+3 to fully myeloablative BU16 site transplant. She did well, tolerated the transplant, engrafted nicely. Her chimerism continued to be 100% on day +30, +90, +60, +90. Because of high-risk disease, we tapered immunosuppression therapy early. We were able to stop it before day 100. But unfortunately, she had disease relapse around day 120 post-transplant. And workup at that time showed again back translocation 6-9 as expected. But surprisingly, she had FLT3 ITD, or this is expected with translocation 6-9. She had FLT3 ITD positive on relapse. We did for her NGS this time, only FLT3 ITD, no other mutations. So she's 4 months post-transplant. She was not fit for intensive chemotherapy. We did not have gilteritinib at that time available, so we offered her AZA, venetoclax as salvage therapy. And we did for her day 21 bone marrow. She was hypocellular 20 to 30%. There was no morphological evidence of disease, but her cytogenetic were positive. FLT3 ITD was still positive. We gave her at that time the first DLI. And with count recovery, we had the gilteritinib arrived, so we started her on gilteritinib. We were able to give her almost 2 months of gilteritinib. She continued to be cytopenic. We did the bone marrow around, like after 2 months of gilteritinib, 40% cellularity, 10% blast. The blast percentage was not accurate. The bone marrow was suboptimal, but the fish was positive for translocation 6-9. FLT3 ITD was also positive. So at this point, she maybe had some response to gilteritinib. It's not clear, so we decided to continue gilteritinib, but to add for her a triplet. So we added AZA plus venetoclax with gilteritinib. And very important, this is a very heavy myelosuppressive regimen, so we have to adjust the medication. We give her gilteritinib 80, and then I think we give it for 10 days only. And we planned for DLI without repeating the bone marrow. So around day 21, 22 with cytopenia, we give her augmented DLI. She had a nice count recovery. This is her lab on last Sunday, on 21st of May. I saw her in the clinic. This is the best count for her since she had relapse. The platelet is 164, ANC is 1,200. And we did the bone marrow, and I just got the result on Thursday. She had 40% cellularity, no evidence of disease by immunomorphology, still bending FLT3 ITD and cytogenetic, still bending chimerism, but I hope that she's clearly showing some response to gilteritinib. So my plan is to continue her on gilteritinib-based therapy, and I will give her more DLI if she had no GVHD. The other case, she was seen in Dr. Said Uthman, our colleague clinic. She's 22-year-old female, presented in December 2018 with syncopal attack that was in outside hospital. Pancytopenia, bone marrow confirmed AML, against translocation 6-9. She had FLT3 ITD positive from the beginning. She received 3+7 plus midostaurin as induction. She achieved CR, received 1 cycle of IDAC. There was issue about transplant, so they gave her 1 IDAC. Unfortunately, disease relapsed at that time. There was some delay on the transplant. They salvaged her again with chemo plus, I think this time they gave her sorafenib. She achieved CR2, normal cytogenetic, FLT3 ITD negative. She underwent haplotransplant from her mother in October 2019. It was complicated by gut and hepatic GVHD. She received the post-BMT sorafenib maintenance, but unfortunately she relapsed almost 1 year in August 2020. They gave her a salvage gilteritinib-based therapy. They started with triplet gilteritinib azacitidine and referred her to us for possible second haplotransplant. When she came to us, she was treated outside Saudi Arabia. When she came to us, her count was a bit acceptable, platelet 54, ANC is around 300. No circulating blast, but we did for her bone marrow, and that was around 4 cycles of triplet. And the bone marrow was hypocellular. There is no blast, but still cytogenetic positive for translocation 6-9, and molecular was still positive for FLT3 ITD despite 4 cycle of triplet gilteritinib azacitidine. So we kept her on single agent gilteritinib at that time, and then we prepared her father for second haplo. She was clinically fit at that time. After long discussion in our BMT, we agreed to proceed for TBI-based second haplotransplant on April 2021. She engrafted and tolerated the transplant very well, and the bone marrow post-transplant, she was in CR, normal cytogenetic, FLT3 ITD was negative. Started on gilteritinib post-transplant on around day +40, and alhamdulillah she continued to be on remission on gilteritinib, and now she passed 2 years post-transplant, and we were able to stop gilteritinib after 2 years, and she continued to be on remission. So in conclusion, AML, as we said, is a molecular heterogeneous disease, and FLT3 ITD mutation is clearly independent negative prognostic factor for AML, and molecular testing for FLT3 is very important at diagnosis and at relapse. Targeted therapy offer a tolerable and maybe improved option for treatment of AML, especially for FLT3 ITD positive on relapse. And there is clearly unmet need for maintenance therapy post-transplant for FLT3 mutated AML. Thank you very much.
Thank you very much, Dr. Ahmed. So I will open the floor for questions. We've got 4 minutes for questions. Please.
Thank you, Dr. Ahmed, for this study presentation. My question now, now until we see the final result of the MORPHO trial from the use of the gilteritinib as induction and post-transplant maintenance, we still use the sorafenib as maintenance treatment. And unfortunately, there is a phase 3 trial showing overall survival for this medication, especially if you use it for the phase 3 trial. It shows if you use it for 6 months, it shows you overall survival. But still, it's not approved yet. I don't know what's the reason behind this one. If there is any reason behind not being approved so far.
Yeah, thank you, Dr. Zahrani. I agree with you. Sorafenib, we have maybe, this is recent Chinese trial that 6 months of sorafenib maintenance, there was a survival benefit, but the number was not huge, this small number of patients. And we have the phase 2, the Soramin trial, there was no survival benefit, there was a PFS benefit. So maybe that's the reason, the number of patients, the quality of the trials, that's why it's not approved. But you know, from our experience with sorafenib, the tolerance is very horrible for patients. It's very difficult, and I don't remember we kept a patient on 400 BID. I don't know how they give it on the clinical trials. Most of our patients, we start 200 BID, and then we cut down 200 daily. I have patients on 200 every other day. Sorafenib is a good, and our standard of care to give it for patients with FLT3 ITD, if treated, if newly diagnosed and transplanted. So we put them in sorafenib, and we tried our best to minimize the side effect by interruption, decrease the doses. So I think because of the quality of the trials, it's not approved.
Thank you.
Any more questions? So, if you don't mind, if you're actually in charge of the hospital formulary, knowing that gilteritinib can be approved or probably will be approved in the first-line setting and post-transplant maintenance, we've got a plethora of options now. So you get an old option, cheap option, get midostaurin, quizartinib, gilteritinib. Which one would you choose if you're the PDC in charge person?
I will not say this because if I still gilteritinib, but we have to think about it. We have the selective and non-selective. Yeah, the selective and non-selective. You will choose one of the selective FLT3 inhibitors, less side effect, more potent, and it's proven to have single agent benefit. That's compared to midostaurin. So sorafenib is proven to have single agent benefit in AML. There is a good trials for maintenance. There is a good trial for upfront and in elderly. So sorafenib is good, but the side effect is intolerable. So I would go with gilteritinib. It's approved as relapse refractory. Upfront, we know that there is ongoing phase 3 trials now comparing 3+7 gilt compared to 3+7 midostaurin. I think the big question will come to quizartinib. Would you think about quizartinib? It's now going to be approved as first line. We know it's selective, very potent, and there is a good trials as treatment for relapse refractory FLT3. So the challenge between quizartinib and gilteritinib, but we don't have approval for quizartinib, so I'll go with gilteritinib definitely.
Gotcha. So the 1 minute and my last question will be FLT3 mutation testing.
So this is a very difficult question, and FLT3 ITD is very long mutation, very difficult, and there is a lot of bias. And there is ongoing work to establish a FLT3 MRD test, but we depend mainly on the PCR test, and also now incorporated with all NGS tests to add for FLT3. But it's ongoing challenge to have FLT3 ITD, and it's a lot missed. And this patient that I presented for you initially, she was initially FLT3 ITD negative. But when we reviewed her initial blood, she was positive from the beginning, but it was missed by our PCR. Gotcha. So it's it's very difficult test, but it's improving with time now. And we have a lot of MRD tests for FLT3 now on market.
Thank you very much, Dr. Ahmed.
Thank you very much.
So, we come to the last session of the day. So, thank you for being with us. So the last session will be on maintenance post-transplant in acute leukemia, and we are lucky today to have with us Dr. Charles Craddock, who is a professor of hematology, transplant, and cellular therapy at Birmingham Center for Cellular Therapy and Transplant, University Hospital, Birmingham, UK. Dr. Charles is well known. He's also the chairman of European BMT or BMT Group Clinical Trials, and he's associate editor for GCO. We would like to welcome Dr. Charles Craddock to be with us today at the SS BMT meeting. And again, Dr. Craddock will speak about maintenance post-transplant in acute leukemia. Welcome, Prof.
Hello, and can you hear me?
Yeah. Yes.
Great. That's great news, because I just had a problem with my camera, so I've had to set up on my laptop. So I just need to find the presentation, and then I'm totally with you, and I apologize for any delay. Okay. So if we share the screen. Is that coming through okay to everybody?
Yeah, fine.
All right. It's a real privilege to be invited to this outstanding meeting. And I heard some of the really excellent discussion previously, which just overlaps a little. So I'm going to try and move in 20-25 minutes through a discussion about maintenance strategies. I'm focusing on acute myeloid leukemia. So this is an area of major interest now, not only in patients who have received intensive chemotherapy, and that's quite new, but also patients who've been transplanted for AML. And the reason is, as we know, that patients who relapse either after chemo or after transplant have a very poor outcome, so everything should be done to prevent that occurring. So the guide and key, really, to developing effective therapeutic strategies is to understand as precisely as you can the disease biology underlying the process. And so I think it is important when we're thinking about designing maintenance strategies, either after chemo or after an allograft, to be aware of the significance of clonal evolution as a major driver of resistance. And this was a study that we did with Parish Vars's group in Oxford. And it's one of the only studies where patients have been prospectively examined using NGS at diagnosis, prior to transplant, and if they did relapse after transplant. So you can see we looked at 113 patients, of whom 49 had relapsed post-transplant. And in those, we found 29 patients in whom there was a sample, and we were able to do and compare the next generation sequencing profile at diagnosis, prior to transplant, and relapse. And essentially what we showed was the majority of patients, they have quite distinct molecular profiles at relapse compared with diagnosis. And so if nothing else, this is telling us that we can't rely on diagnostic features to inform a targeted maintenance strategy. Let me just show you some of the patterns we found. I think they're quite interesting. The first was kind of reliable recapitulation of the molecular phenotype at diagnosis at relapse. So that's the top calendar there with the same pattern of WT1, NPM1, and FLT3 mutations at relapse. But we did find other patients who were really very different. There were patients in whom there was clonal evolution at relapse that wasn't detectable prior to transplant. But also, interestingly, look at the bottom left-hand corner, patients in whom chemotherapy itself had exerted clonal pressure. And there was a distinct clonal footprint prior to transplant that was subsequently recapitulated at relapse. So look in the bottom left, you had patients developing a F6 mutation at diagnosis that dominated at relapse, but that wasn't present at diagnosis. And then bottom right, this is a patient who had a small but detectable TP53 clone prior to transplant after induction chemo, which was the dominant clone at relapse. I think that's really interesting. I think that gives you some insight into the sort of maintenance strategies you might want to develop, whether you want a broad or a focused targeted strategy. I think it also emphasizes the importance of mutation analysis post-transplant and pre-transplant in terms of informing what you might use post-transplant. And lastly, is it does mean that it may be misleading for us to be doing risk stratification for patients destined to transplant at diagnosis. Maybe we should be risk stratifying patients on the clone that is present after intensive chemotherapy. Just a thought. So I'm going to talk just quickly about maintenance strategies outside the setting of transplant. I think they're important and they're relevant. So azacitidine has been looked at as a maintenance in patients who've had intensive chemotherapy for AML for a number of years. And the reason for that is it's a very interesting drug in terms of upregulating epigenetically silenced tumor antigens, cancer testis antigens, WT1, a whole bunch of antigens. It even actually, in the context of transplant, upregulates minor histocompatibility antigens. And that's particularly interesting because we showed in one of our phase 2 studies with valproate and azacitidine that just the application of that combination therapy induced a sizable CD8 T cell response to tumor-specific peptides, but not the control population. So I just want to rest the idea with you that it may be that by applying maintenance outside the setting of transplant after chemotherapy that you might induce an autologous anti-tumor response. So going now to the clinical data, well, there was really quite provocative data from the HOVON data set presented in ASH 4 years ago, which showed that patients who'd had chemo were deemed not eligible for transplant, who were randomized to receive AZA maintenance, 50 milligrams per meter squared for 5 days for 12 cycles, actually had a survival advance, had an improved disease-free survival. There was no survival benefit because many of the patients who relapsed crossed over, as happens. But this was provocative data and kind of was the underpinning data for the AML-001 study, published in the New England Journal of Medicine a couple of years ago, where using an oral formulation of azacitidine, CC486, which has a distinct pharmacokinetic profile, was administered as maintenance therapy in fit adults who'd had intensive chemo, but for whatever reason weren't proceeding to transplant. So this was the randomization. It's a very select population of patients, actually, age 55 or more, de novo or secondary AML, intermediate or poor risk cytogenetics alone, who were in first CR or CRI after either a single cycle of intensive chemotherapy or 2 to 3 cycles in total of chemo. So they were randomized to receive maintenance therapy as is outlined there, and it was a placebo randomized study. So I think to some people's surprise, actually, this showed a significant improvement in overall survival in the population of patients who got CC486 maintenance. The curve comes together, we'll talk about that in a bit, later. So it doesn't look like you're getting a significant number of patients who are achieving a very long-term benefit, but clearly a significant survival benefit on the basis of these data. And sorry about that, this slide always does that. So the patients who are NPM1 positive did particularly well in this study. And interestingly, the survival benefit was observed whether patients were MRD negative or MRD positive. So that study has informed licensing approval for CC486 in patients who are in remission but not proceeding to chemotherapy. Interestingly, in the UK, that has been a very broad, permissive licensing indication for any adults with AML who've had intensive chemo, regardless of cytogenetic risk. And I think one of the other questions that is raised is that a significant number of people in this study only had 1 or 2 courses of chemo. So how representative are they of the general population? But those points aside, the generalizability of data and the number of people who'd had only a modest number of courses of chemo, I think this is a very important development, because for people either who don't wish to transplant or who cannot proceed to transplant, and we know that inability to access donors is a particular issue, particularly in certain ethnic subgroups, then this provides an additional, potentially highly effective treatment option. So I just wanted to show you a couple of slides. We were interested in this question about why was it that patients who have a therapy for high-risk MDS or AML, why do they always relapse? So we wanted to quantitate leukemic stem cell numbers in patients who'd had azacitidine. I just want to show you these data. I mean, it's a bit old now, but they get quoted a lot, and I think for good reason. What we were able to demonstrate is that in patients who treated with this was in AZA and vorinostat, this was a study we did, who got either of those, either AZA and vorinostat or AZA monotherapy, obviously no reduction in the stem progenitor numbers if you don't have a clinical response. But interestingly, in the patients who achieved a CR or a CRI, you are almost always still able to detect leukemic stem progenitors. So I've proposed biological insights, I think 3 probably. One is mutational instability. Secondly is induction of CD8 T cell responses by drug therapies. We need to explore that further. And lastly, the importance of sequential leukemic stem cell quantitation to understand the biology of disease resistance. So now to turn to the main purpose of this talk in my last 12 minutes, which is how might we use maintenance strategies to improve outcomes of patients allografted for AML. I don't need to tell this audience that allogeneic transplants now pivotal curative strategy. We have reduced intensity regimens, we have increased unrelated donor panels, we have cord, we have haplo. So most people who we think should have a transplant can now proceed to a transplant. The challenge, of course, remains disease relapse. And whilst there's been a substantial reduction in transplant-related mortality, particularly using haploidentical donors, which are turning out to be a very important stem cell source, disease relapse has not changed in incidence. When it occurs, we know it occurs early. More than 80% of those deaths into relapse do so in the first year post-transplant. And as I've said, your outcome after relapse is very poor indeed. So we need to think about pulling out those patients who are likely to have a high risk of transplant, because that might shape either how we transplant them or actually what we do in terms of maintenance. And these are the important factors. The other piece of the jigsaw that's been looked at perhaps a little less comprehensively, which is relevant when you're applying a maintenance therapy post-transplant, is the kinetics of relapse. So in this study that we did with HOVON and the EBMT, we were really interested to look people who'd had an allograft. Were the particular factors that drove rapid relapse? Because that could inform when you might start maintenance therapy. And this is what we found in the multivariate analysis, that the factors that were driving early relapse were the presence of a FLT3 mutation, older patients, and a long time to achieve relapse, complete remission, drove early relapse. And interestingly, and use of an unrelated donor seemed to protect you. So we also then looked at people who relapsed later, and the people who relapsed later, it's interesting this, I can't explain it, but they're people who had a mutated NPM1 and also patients who had in vivo T-cell depletion. So I think all I'm saying here is we need to be really thoughtful about stratifying patients at particularly high risk of relapse and also pulling out people at a risk of early relapse. So conceptually, what might we do to improve outcomes by reducing relapse? Well, I'm not going to dwell on the opportunities to reduce pre-transplant MRD status. That's plausible. We need randomized trials of agents that might do that. We haven't historically had such agents, but I think ven-based regimens, particularly, the air-ven-aza guilt triplet might be interesting in that context. The conditioning regimen could be important to, is there a Cinderella conditioning regimen with not too much toxicity and just the right anti-tumor activity? There is interesting data that using cord blood in particularly children with high-risk AML, very nice paper from Rob Wynn's group in Blood Advances yesterday, is associated with reduced risk of relapse, and that's not the only paper. There's some Seattle data. So I think we must continue to explore the optimal stem cell source in this setting. But the last, of course, is to maximize the graft versus tumor effect. So looking just briefly at MRD, we've thought about this a bit in our group. So the retrospective data, this is the first data, the Iraqi retrospective study, that showed if you were pre-transplant MRD positive, you had a really high risk of relapse. It was the same as if you had refractory AML. And other retrospective studies, they're flawed, aren't they, these retrospective studies? You don't quite know when the MRD was taken pre-transplant. You don't know what the technology was. You don't know why certain people had MRD done and certain people didn't have MRD. But they showed a variable size effect. So we wanted to explore this issue at the same time as looking in patients having a reduced intensity regimen, whether there might be a Cinderella RIC regimen, and we were in a randomized study exploring the benefit of the FLAMSA, the sequential regimen developed by Christoph Schmidt and Hans Kolb. So this was patients AML, CR1 or CR2, randomized to receive either FLAMSA abuse their conditioning regimen, or essentially people got FB2, FluBu2 using the French regimen. stem cells infused, primary endpoint, 2-year follow-up, 2-year survival. But Sylvie Freeman in our group very brilliantly did prospective pre-transplant flow MRD, never been done before prospectively on all these patients. We were disappointed to see that this intensified regimen, that means people are in hospital for another week, have more toxicity. There was no improvement in survival in any subgroup. So that's interesting because it's been previously widely used in AML CR1, but when you actually did a randomized study, there was no benefit. The second thing that Sylvie did, which was very nice, was, yes, she confirmed that by flow MRD, there is an increased risk of relapse. That's the red line in patients who are MRD pre-transplant. She showed that the cumulative incidence of relapse doubled from 20% to 40%. But importantly, I think in this study, we showed that actually even for the MRD positive patients, if they're in CR1 or CR2, they still actually did quite well with the transplant. Their 2-year overall survival was 51%. 70% if you're MRD negative. But we again would, in our group, would be saying the data would suggest that if you're MRD positive, there's no rationale for not proceeding to transplant. What you need to do is try and think post-transplant about strategies to reduce the risk of relapse. That might be a rapid cyclosporine taper, mightn't it? Or it might be DLI. And relevant to the maintenance discussion was these exploratory data that we pulled out from the Figaro study, showing, look to the right, arm B, panel B, in brown, in patients who were pre-transplant MRD positive and didn't achieve full donor T-cell chimerism, who had mixed T-cell chimerism at day 100, their risk of relapse was much, much higher than those patients in the aquamarine who were MRD positive but achieved full donor T-cell chimerism. So our interpretation of this data is it's another piece of evidence that there's a very potent graft versus tumor effect that we might exploit using maintenance strategies. The other piece of evidence, of course, is the typical one. This was from a RIC population we did with the NCRI group, showing patients with high cyclosporine exposure had worse overall survival because of increased relapse compared with patients with a lower cyclosporine level. Both compelling pieces of evidence to say there's a powerful graft versus tumor effect post-transplant. Can you do anything to maintenance? And just to finally close out on the conditioning regimen question. So these are a study that's just closed, having randomized 290 patients, looking at TBF versus FP4, and we're waiting for the results from that study. So let's think about post-transplant maintenance. How might it work? Well, I mean, we showed in the previous study that azacitidine improves outcome, but there's still residual leukemic cells. So if you had a pharmacological agent that targeted leukemic stem progenitus, that would be perfect. But the alternative is that you actually just delay relapse and you buy time for this graft versus tumor effect. And so what's that principle look like? Well, it takes a while for a graft versus leukemia effect to be clinically operational. I mean, either transplanted donor CD8 T cells take a time to expand, or your CD8 T cell population from the transplanted donor stem cell takes some time. And it's perfectly possible that relapse occurs before you have a clinically significant or meaningful graft versus tumor effect. So if you had an agent that just pushed relapse back, maybe that buys you the time. I mean, ideally, we'll talk about this in a minute, if you have a drug that augmented a graft versus tumor effect, that would be nice. So the previous speaker very elegantly talked about post-transplant sorafenib and AMP3 inhibitors. So I don't want to replicate this. He mentioned the retrospective data, and this is the Burkett data. It's been replicated in a Chinese study with a survival advantage if you have post-transplant sorafenib. And I thought he commented very accurately that these are quite small populations, but there was a survival benefit. Trouble is, sorafenib is not very well rated post-transplant, although I think it is possible to deliver in a number of. So it kind of doesn't solve the problem. And interestingly, one of the pieces of evidence to suggest why sorafenib may work is that this was a nice paper in Nature Medicine, it can augment production in FLT3 positive cells. So it may actually drive T cell expansion, just thinking conceptually how this drug might work. We're all waiting, of course, for the results of the Morpho study in 10 days' time. I suspect that we will have some very provocative data and that it will not be entirely negative. So we were interested actually, partly because of our work showing considerable mutational instability, about not so much a targeted maintenance strategy, but a mutational agnostic strategy. So azacitidine is interesting in that setting. I've shown you how it upregulates tumor antigens, but we're also able to demonstrate that it accelerates Treg reconstitution. So this may be a very interesting agent, both in terms of anti-tumor effect, augmenting GBL, but also reducing GVHD, which led to Mohammed Moti coming up with this very nice diagram. So sub-Q is jolly difficult to administer post-transplant. There has been one randomized study done. It was negative. Patients didn't see much AZA. So we were interested in using CC486. We established, this was work with Marcos de Lima in Seattle and New York. We established an MTD, which was 200 milligrams for 14 days. And we randomized patients who'd had an allogeneic transplant for AML and CR1, who were in remission post-transplant, to receive azacitidine, 200 milligrams for 14 days, or they got randomly assigned a placebo. The primary endpoint was 24-month relapse-free survival. I'm delighted to report to you that despite the COVID pandemic, we randomized and recruited on time, 326 patients. The study was closed out March this year, and we hope to have results in about 18 months' time. The alternative approach, and the heading hasn't come up, the title hasn't come up, is a study called VRLT, which is actually using sub-Q-AZA and oral venetoclax. That study is recruiting well. So my conclusion is we need increasingly to think about identified patients who are going to have a high risk of relapse and those who might relapse early. We need to think about tailoring maintenance to mutational profile. We need to be thoughtful with post-transplant maintenance therapies, whether they're targeted or a broad anti-tumor specificity, that they are well tolerated by patients, that particularly post-transplant, you can start them early, and they need to be validated in randomized studies, because it is possible that maintenance pharmacological agents could blunt a graft versus tumor effect. And increasingly, we need to understand more about the factors driving these incidences of relapse. So I'd like to end it there, and I'm very happy to take any questions.
Thank you for this nice presentation, and floor is open for questions. Rahmat.
Yeah, thank you very much for this very nice talk. Question about this Chinese trial, the survival maintenance. You know, they give it only for 6 months. We see the survival benefit. We used to say that the importance of FLT3 inhibitor is the continuous inhibition for FLT3. The survival they give it for 2 months. So we used to say continuous survival is the minimum dose you can. The important thing is the continuous inhibition. But how can you explain with 6 months survival? Is it the degree of inhibition?
Well, I don't know that we can explain it. I mean, there are possible explanations why a shorter duration of a pharmacological agent might deliver some viable benefit, aren't there? I showed that really interesting data from Figaro that switching people to full donor T cell chimerism seems to be important in the MRD positive population, and of course in the Morpho study, that's going to be the population where we're going to be looking for a benefit. And it may be that there is no overall survival benefit simply because they included patients who had a better outcome than they might have predicted in the control arm because of the use of a TK inhibitor, midostaurin, up front, or because they were MRD negative. Maybe we need to be more thoughtful about focusing maintenance studies on patients who are pre or post-transplant MRD positive. But to go back to your question, I think it is plausible, and that data from Matthew suggested it, that you can give a pharmacological agent that could switch your chimerism status, that could be immunomodulatory, so you don't need to take it forever. I think the second point that you make is a good one. And we wrestled with this with the design of the Amadeus trial, is how long should people take these maintenance therapies? And we only did 12 months, CC486, and you could criticize that. But the other reason we did that was we felt pragmatically it's incredibly difficult to keep taking these agents, particularly if they're not very well tolerated beyond a year. In fact, CC486, I can tell you one thing, it's very well tolerated. Whether it's active or not, we'll have to see. But I think that the notion of an effective maintenance strategy may not be deliverable through drugs. It's perfectly possible. And I think you need to say it needs to be a strategy that is well tolerated, that you can give early, and I suggest to you, as life becomes more complex for our patients, a maintenance therapy that you have to take for 5 years is not a fantastic maintenance therapy. So I think trying to define immunomodulatory strategies that switch you to full donor chimerism and do it quite quickly without excessive risk in GVHD is probably where I'm going to be putting my money, particularly since all the evidence shows that if you're MRD positive pre-transplant, but also MRD positive post-transplant, that's the population we should focus on, and those patients relapse early. And the other challenge with giving drugs as maintenance is it's quite challenging to start them much before day 50. So, sorry, a long answer to a very good question, and a lengthy way of me saying I don't know the answer, but maybe we need to rethink what we're doing with maintenance whilst awaiting the results of Morpho and Amadeus.
Another question to that. You mentioned that regarding the oral azacitidine and the trial itself, they exclude all favorable cytogenetic. However,
yes, it did.
I think you mentioned that in the UK you're giving the cytogenetic. So is it rational?
It's such a great question. I mean, it's approved, interestingly. I don't know what happened to our approval body, NICE. They must have had some happy drug that week because they were very generous. I think I would be able to say to you that many of my colleagues don't use oral azacitidine maintenance because, of course, if you give DA and go and you have good risk cytogenetics, your outcome is very good. You can either do MRD monitoring or anyway the outcome is good. And so most people, although they could use it, they're not employing it in that strategy, in that context, because this is a population, firstly, who will do well with current treatment, and secondly, a patient in whom you can identify the bad players and think about taking them to transplant with MRD.
Okay, maybe I will ask
the last question. Briefly, any data about using IDH1, IDH2 maintenance in subgroups?
It's a great question. I mean, there is data, isn't there, from the Boston group, and it looks encouraging. There's data with the Pranapop, the TP53. I think, if I can be honest with you, the challenge with these targeted therapies is in small molecularly defined populations is actually generating randomized data showing persuasively that there is benefit. So I think increasingly the use of real-world data cohorts or synthetic control arms is going to be necessary in these molecularly defined smaller subgroups.
Okay, so
by this we come to the end. Thank you, Rob, for your lecture.
I'm sorry I can't be with you in person.
Hopefully
next time we'll see you physically.
I hope so, and I wish you well for the rest of the meeting. Thank you, my friends. Bye. Bye.
So we
now we come to the conclusion of
the day.
Yes.
So we come to the conclusion of the day. I'd like to thank all of you for being with us until 5 p.m. and see you tomorrow, inshallah. Tomorrow at 9 a.m.
Hello. Doctor, sorry, I don't have a question because everybody wants to go home. I just want to testify. I'm a living testimony that the treatment given by the Hema-Onco department in our hospital under the care of Dr. Askar, Dr. Zarani,